jutro, poštovane koleginice i kolege i dragi prijatelji. Zahvaljujem se kompaniji Johnson & Johnson i Janssenu, da kažem tu reč sa govornice, iako je u oficijalnome nema, što nam je omogućilo da progovorimo u rane sate o jednom problemu koji nas muči, koji nije rešen, a to je kako poboljšati ishode lečenja pacijenata sa metastatskim nesretnim ćelijskim karcinomom pluća i sa insercijom u egzonu 20. Ova pitanja ćemo razmotriti u jednom trianglu koji osim mene čine moji poštovane kolege, docentkinja Milica Kontić-Jovanović i profesor Bojan Zarić, i sveobuhvatno ćemo u jako kratkom vremenu, vidjet ćete, a efikasno pokušati da damo odgovore na pitanja, odnosno da prikažemo i kliničke studije i nekakve zaključke koje iz toga slede. Zašto nam je potrebna nova terapijska opcija? Pa zato što smo se udaljili od jednostavnosti u onkologiji, to je pripadalo 90-im koji smo zaboravili na svaki način. Karcinom pluća tada nije ista bolest kao i u 21. veku, kada je revolucija pomela mnoge stavove i donela mnoge nove lekove, od kojih su većina našli i FDA i EMA odobrenje u toku ovih prethodnih 10 godina. Pojavljuju se stalno novi lekovi, što ne znači da će svi biti sjajni i veoma korisni, ali mnogo lekova je identifikovano, mnogo mutacija ima, dakle, svoje inhibitore, a vidjet ćemo šta će od toga svega ući u redovnu kliničku praksu. Ono što nas u kliničkoj praksi muči je šta da se radi sa trećim po učestanosti EGFR mutacijama, a to je insercija u egzonu 20. To je mutacija koja pripada oko 12% svih EGFR mutacija, odnosno oko 4% svih u nesretnom ćelijskom karcinomu pluća. Ima praktično preko 120 različitih insercija. Nije zgodno, dakle, izgleda za inhibiciju to što se one nalaze pri kraju C heliksa i u kliničkoj praksi to znači rezistenciju na postojeće EGFR TKI inhibitore, dakle, iz sve tri generacije, loša i imunogenost i jednom rečju terapijski problem koji smo iskusili. Ovo su podaci iz svetske prakse koji govore o tome koliko je inferiorno preživljavanje ako je to u praksi preko 2 godine, ovde je jedva preko godinu dana i PFS je između 5 i 6 meseci za ove pacijente. Pokušalo se sa sve tri generacije TKI-a, pokušalo se sa kombinacijom Erbituxa i erlotiniba, ali osim nekih anegdotalnih poboljšanja, kratkotrajnih i malog responsa, nije bilo zapravo suštinskog napretka u ovoj oblasti. Svelo se na to, kad god se u onkologiji nema rešenje dobro, ide se na platinski dublet i platinski dublet je i ovde pokazao da zapravo može da odigra neku ulogu koju mi, dakle, nismo zadovoljni, ali to je definitivno standard of care koji može da, dakle, obezbedi ukupno preživljavanje do 17-18 meseci i medijanu PFS-a do oko 5,5-6 meseci u prvoj liniji, više nego TKI. Mi svi znamo da smo kretali sa TKI-evima, ali su nas i praksa i vodiči preusmerili na platinski dublet. U drugoj liniji mnogo ima i kombinacija platine sa imunoterapijom ili same imunoterapije, ali to zaista nije donelo nikakav značajan napredak. Ne znači da je polje sasvim pusto, dakle, 2 leka su registrovana od EME, jedno je amivantamab i to je lek o kome ćemo danas i govoriti, a drugi lek je mobocertinib koji je zapravo imao FDA promociju, ali je posle toga praktično kod EME zastao i ta registracija je povučena. Imamo i poziotinib kao jedan od lekova koji je nezanemarljive toksičnosti i zbog mehanizma delovanja, tako da naš armentarijum u ovom slučaju zaista nije veliki. Amivantamab je, dakle, zanimljiv zato što je prvo to jedno humano, praktično G1 imunoglobulinsko antitelo, bispecifično, sa visokim afinitetom, dakle, i za EGFR i za MET. To je jedna činjenica. Druga je da se vezuje ekstracelularno i tako da nije predmet delovanja komutacija koje se nalaze u TKI džepu u samoj ćeliji i samim tim što gađamo EGFR i MET, mi zapravo idemo u terapijskom smislu na dva glavna mehanizma rezistencije u karcinomu pluća, u EGFR mutiranih pacijenata. Evo, to je vrlo kratak uvod do leka samoga, a ja bih sada zamolio profesora Zarića da čujemo o dva glavna klinička ispitivanja. Izvolite, profesor.
Hvala, Davorine. Dobro jutro svima. Želim hvala što ste ovako rano ujutro sa nama došli da podelite neke novine koje se tiču amivantamaba i upotrebe bispecifičnog antitela u lečenju, hajde da kažemo, jedne male podgrupe adenokarcinoma pluća. Prvenstveno sa ove desne strane je grupa pacijenata koji nose Exon 20 inserciju. Ja ću vam vrlo kratko nešto ispričati o Chrysalis studiji, dakle o studiji koja je bila breakthrough u Exonu 20 inserciji, papilonu koji je zapravo prva prava faza 3 kliničke studije. Levu stranu i pravu borbu sa AstraZenecom ostavit ćemo za neku drugu priliku, a to su Mariposa studije, to su frontlineri sa common mutacijama, sa znači 19-icom i sa 20-kecom i zapravo to ćemo ostaviti za neku drugu vrlo slasnu poslasticu u budućnosti. Kada govorimo o samom, znači, Chrysalisu, mislim da svi koji ste ovde više manje znate za moju ljubavnu aferu sa lazertinibom, ali ostavit ćemo i taj lazertinib negde po strani. Ono što je važno u dizajnu Chrysalisa jeste ova kohorta D. Dakle, Chrysalis je vrlo jasno definisao selekciju pacijenata koji su primili platinski dublet i nakon toga progredirali, a nose, dakle govorimo o adenokarcinomima pluća, Exon 20 inserciju. I još jedna važna stvar, malo nas je ovde, ali moramo strašno da razgovaramo sa našim molekularnim biolozima i sa našim eksperimentalcima, drago mi je što je Rada ovde, moramo da zaustavimo priču da nam se izdaje nalaz EGFR-a pozitivan ako pacijent nosi Exon 20 inserciju. To nije pozitivan EGFR, to je Exon 20 insercija i potpuno neka druga populacija. Dakle, vrlo kratko kakav je bio overview, vidite gde su bili key inclusion criteria, metastatski, neresektabilni, nemikrocelularni, dakle u populaciju je definitivno ušao i 3C, 3B stadijum, EGFR 20 Exon insercija koja je pozitivna i progresija na platinu. Malo je teško kada prevodimo na srpski jezik da vidimo kako to izgleda, ali objasnit ću vam kasnije na jednom od ovih slajdova. Naravno, šta je u igri? Kada pogledamo kako izgleda, znači, Kaplan-Meier za overall survival kod pacijenata koji su primali sve u ovom settingu, znači i overall i PFS, onda pogledajte koliko zapravo ova, ovde na slajdovima je ljubičasta, meni je plava, ova krivulja Kaplan-Meiera na amivantamabu odskače. Zašto odskače kod Exon 20 insercije? Stvar je vrlo jasna. Bispecifično je antitelo. Sa jedne strane ono targetuje common EGFR, ali sa desne strane bispecifikuma zapravo targetuje jednu od najvažnijih rezistencionih, neću da kažem mutacija jer nije mutacija, ali c-MET. i zbog toga amivantamab uspeva i ima veliku efikasnost. I pogledajte sada, znači, overall survival. Govorimo o settingu pacijenata u 4. stadijumu koji nose inserciju, koji su u frontline-u dobili platinum-based dublet, a znamo šta to znači za pacijenta, i imamo 2-godišnje preživljavanje koje je 50%. Znači, moja glavna poruka je amivantamab, čak i nakon te platine, koja znamo koliko je toksična i koliko se teško podnosi, i svi znamo u kakvom su nam stanju pacijenti nakon što prime frontline platinum dublet, ukoliko dobiju amivantamab monoterapiju, znači, nakon progresije 50% je živo nakon 2 godine. To su ipak rezultati koje čak ni u domenu EGFR-a, koji je savršen sa osimertinibom kao vodiljom, nismo videli do sada. I ovo je čisto jedan mali spider plot koji treba da vidite. Dakle, 42% pacijenata koji su u ovom settingu imaju ono što zovemo održivi klinički benefit. 13% je ostalo na amivantamabu čak i nakon 2 godine, što znači da je duration of response jako dobar kad to prevedemo u kliničku praksu. I dakle, ako imamo dobrog performera, ako imamo sam respons na početku, a znamo da je to pozitivni prediktivni faktor za uspeh terapije, i ako nemamo, ovo jedino ne možemo bez radmila, znači tu nam treba radmila i treba nam eksperimentalna laboratorija da bismo vidjeli da li imamo neki alternative bypass što se tiče rezistencije, dakle ako imamo RAS-RAF-MEK koji će dobro uraditi. I naravno sve je ovo rezultiralo, ovo je malo stari slajd gde još stoji MOBO više nema, MOBO forget about it, znači on je otišao, ostao nam je samo amivantamab kao registrovan lek za ovu indikaciju. I u ovom slučaju nemamo drugog izbora. Ako pogledate levu stranu, pa to uopšte, znači i nije tako loše, čak šta više, to je jako dobro, zato što imamo preko 40% overall response rate, ali meni je mnogo važniji ovaj donji deo koji nismo zaokružili. Kada pogledate overall survival, on stoji na 22 meseca, svi znate koliko ja mrzim medijane i dakle one statističke mere koje gledaju 50% populacije, ali ovde je vrlo interesantna medijana zato što gornja granica confidence intervala nije postignuta. Dakle, ovo će se još menjati, smanjivati se neće, ali će se samo povećavati kako budu išli readouti. Dakle, registrovan kao monoterapija u second line-u kod egzona 20. Šta je sa papilonom? Dakle, papilon je zapravo rezultat krizalisa, vrlo lepo je dizajniran i papilon je frontline. Frontline AMI hemioterapija versus samo hemioterapija kod pacijenata sa insercijom 20. Insercija u egzonu 20 nije EGFR driver mutacija. Dakle, nju moramo posmatrati kao potpuno poseban subset pacijenata i potpuno posebnu bolest. I evo ga šta se dešava. Jedno ogromno iznenađenje. Davorin vam je pokazao krive malo pre. Ovo su krive PFS-a, znači koje imaju hazard ratio 0.39. Znači, izvinjavam se što mešam jedan i drugi jezik, ne mogu jače od mene. Ako fiksiramo hazard na 40%, to je 60% manja šansa da dođe do progresije sa AMI combo frontline. Zašto? Zato što smo pokupili i common mutacije i sprečili rezistenciju sa C-metom, sa drugim krakom samog bispecifičnog antitela. Da li ima razlika u forest plotu što se tiče subpopulacija? Ako se sećate drugih studija koje su uzimale druge EGFR inhibitore 3. generacije, onda ćete se sećati da azijska populacija nije dobro prošla, da populacija pušača nije dobro prošla. Ovde imamo zapravo jednu clear cut situaciju u kojoj je sve na strani AMI-hemio kombinacije. Interim analiza ne može još uvek da se interpretira u punoj meri zato što je interim analiza, dakle nemamo zrele mature podatke, ali imat ćemo ih kroz vrlo skoro vreme, ja se nadam, i pogledajte kombo. Znači, nije postignuto. Mi još uvek nismo došli. Toliko je dobar odgovor i toliko je dobar signal za overall survival da nismo došli do medijane. Još uvek ne znamo od početka studije šta se desilo sa 50% pacijenata i očekujemo svi da će ovo biti zapravo vrlo pozitivna studija. Ono što je prava stvar u dizajnu, znači papilona, jeste činjenica da su dozvolili crossover. Dakle, oni pacijenti koji su bili na hemomono, odnosno na platinskom dubletu, ipak su na kraju mogli da dobiju amivantamab u onom momentu kada su progredirali na dosadašnji standard of care. I to možete i videti, znači, ovde koliko je pacijenata koji su bili samo na hemoterapiji otišlo. Pitanje koje svi često postavljamo sebi jeste, a šta ako dam najbolji lek odmah, šta ću uraditi posle? Pogledajte koliko je opcija. Ima ih zaista dosta. Reč je o personalizaciji i opet dolazimo u glitch situaciju u kojoj bez Radmile Janković eksperimentalne onkologije i dobrog NGS-a nećemo znati tačno šta treba da uradimo i to je ono na čemu treba da insistiramo u budućnosti. Ovde su mi i Urška i Katja koje imaju tu sreću da je pored njih NGS laboratorija u koju mogu da pošalju 3 kapi krvi i dobiju odgovor kako i šta dalje lege artis. Dakle, crossover, čisto da vidite šta se desilo sa pacijentima, znači koji su primili u kontrolnoj grupi doublet platine, a onda otišli, praktično rekreirali krizalis, jer ovo je u stvari grana koja je ista kao i krizalis, ali pogledajte, dakle, 12-mesečno preživljavanje 70%. Govorimo, dakle, o pacijentima koji su adenokarcinomi sa egzon 20 insercijom, koji su primili prokleti platinski dublet bez kog zapravo ne možemo i nećemo još uvek dugo moći, ali 70% je u front line-u, u second line-u i dalje živo. Dakle, zapravo, ami-hemio kombinacija je definitivno, dakle, registrovana za ovu grupu pacijenata koji nose egzon 20 inserciju. I još jednom poruka. Egzon 20 insercija je posebna bolest, to nisu EGFR pozitivni pacijenti, to su EGFR negativni pacijenti. To su pacijenti koji mogu biti lečeni samo amivantamabom u ovom momentu i ničim više. Ovim ja završavam i pozivam Milicu da se pridruži na sceni jer njeno predavanje je još zanimljivije. Hvala vam pažnje.
Dobro jutro svima i u moje ime. Da, što se tiče, vi ste već čuli o ovim uvodnim predavanjima, a i znate da je amivantamab nekako lako i čini mi se brzo postao dobra terapijska opcija za EGFR pacijente koji imaju insercije egzonovi 20, ali ne samo za njih, nego i za pacijente sa čestim mutacijama. Znamo koliko su impresivni rezultati i Mariposa studija, ali činjenica da kad govorimo o efikasnosti, danas smo puno o tome čuli, mnogi malo podignu obrve i kažu ali toksičnost. I to jeste, da kažem, jedna važna tema i nešto o čemu moramo dobro da prodiskutujemo. Da bismo razumeli mehanizme nastanka toksičnosti, moramo da razumemo mehanizam dejstva leka. Te dve stvari su povezane. Bojan je dosta toga već prokomentarisao. Suština ovog bispecifičnog monoklonskog antitela EGFR i MET je da targetuje dva osnovna mehanizma rezistencije na treću generaciju EGFR inhibitora. Ovaj slajd je po meni mnogo važan jer on upravo govori o mehanizmima dejstva amivantamaba. Prvi, koji je, da kažem, možda i najvažnije, Bojan je pomenuo, u pitanju je bispecifično antitelo koje deluje na receptore EGFR i MET koji se nalaze ekstracelularno. Dakle, sve što se dešava, a to su mutacije u tirozin kinaznom domenu, neće uticati na rezistenciju na amivantamab, to je mnogo bitno, a s druge strane zauzimaju te receptore, onemogućavaju ligandima da se vežu i da pokrenu mehanizam kancerogeneze. Druga stvar, kad tako dugo neki signalni put biva redukovan, onda vremenom dolazi do degradacije receptora koji mehanizmom endocitoze i apoptoze uništava tumorsku ćeliju. I treća stvar, tako je dizajnirano ovo antitelo da se s jedne strane vezuje za EGFR i MET, a s druge strane za ove imunoefektorske ćelije koje onda trigerovane ovim lekom, pokreću mehanizam koji se zove trogocitoza i dodatno dovodi do smrti tumorske ćelije. Pomenuta je danas i studija i Chrysalis i Papillon. Ono što je moj zadatak danas to je da prokomentarišem kakav je bio safety profile ovih studija i odmah da kažem da su neželjena dejstva bila česta, ali su bila niskog gradusa i to je ono što je možda i najvažnije. Najčešće su bila raš, paronihija i infuzijne reakcije. Naravno, očekivana su to neželjena dejstva s obzirom na mehanizam dejstva. Znamo da su u pitanju i GFR i MET, ciljena antitela. Dijareje nisu bile tako česte. To znamo da kod EGFR inhibitora se viđa. Ovde je bilo u 12% slučajeva, ali samo 4% pacijenata su imali gradus 3 i veći, tako da to i nije bio čest problem. Infuzijne reakcije, da. Dakle, to je nešto što se viđa relativno često, zapravo i često, možemo da kažemo, ali u prvoj dozi. Tako da tu je bitno da nekako sa oprezom priđemo pacijentima u toj prvoj dozi. Ista stvar važi i za Papillon studiju kad su u pitanju učestalosti neželjenih dejstva. Dakle, ponovo taj raš, paronihije i infuzijne reakcije, s tim što su ovde naravno neželjena dejstva bila neuporedivo češća, jer ne zaboravite, uz amivantamab je bila primjenjena i hemoterapija. Koliko je hemoterapija toksična i koliko neželjenih dejstva daje, to naravno svi znamo i to je doprinelo sasvim sigurno da su neželjena dejstva u ovoj studiji bila veća, odnosno češća i zapravo su uporedive ako pogledate kolonu gde pacijenta koji su primili samo hemoterapiju i koliko su često oni imali i neželjena dejstva i ozbiljna neželjena dejstva i neželjena dejstva gradusa 3 i veća. Dakle, sve je to bilo relativno slično kao i u kombinaciji kad se još dostali sa amivantamabom. U lečenju, izbrinjavanju neželjenih dejstava, naravno treba imati u vidu da su moguće redukcije doze, ali i odlaganje doze i ono što je posebno važno, mislim da nikad nije dovoljno puta ponovljeno, kad kažemo pogledajte preporuke u zbrinjavanju neželjenog dejstva, dakle ne treba intuitivno doktori da zbrinjavaju neželjena dejstva, nego da se drže gradusa i ono kako preporuke kažu. Ima i nekoliko zanimljivih dizajniranih studija, upravo možda to je i korak više od ovih protokola za zbrinjavanje neželjenih dejstava, a to je profilaksa. Bolje sprečiti nego lečiti. Skipper studija koja je dizajnirana tako da se pokuša da se izbegnu ova neželjena dejstva u vidu infuzionih reakcija. Neke 4 grupe pacijenata podeljene su u 4 grane. Jedni su dobijali dexametazon 4 mg per os 2 puta dnevno, drugi 8 mg 2 puta dnevno nekoliko dana uoči. Prve doze amivantamaba, montelukostin, metotreksat. Nemamo mnogo vremena, moramo da vodimo računa o tome, pa ne mogu da se udubljujem, ali ću reći samo to da je kriterijum za nastavak ove profilaktičke terapije bio samo da manje od 50% nema infuzijne reakcije, pa da onda može da se nastavi uključivanje novih pacijenata. I jedina ova grupa koja je primala dexametazon per os 2 puta dnevno, 2 dana pre, dan pre i sat vremena uoči prve doze amivantamaba je imala značajno redukovanu učestalost infuzionih reakcija u smislu da je manje od 50% pacijenata njih imalo. Podsjećam, prva doza je kritična. Posle toga se to retko dešava. I ova kombinacija lekova je dovela do toga da se za 3 puta smanji učestalost infuzionih reakcija ako se amivantamab daje ovako, dakle uz ovu profilaksu. Naravno, samo podsjećamo ono što znamo, uz to obavezno ide i antihistaminici i antipiretici prvog i drugog dana prvog ciklusa. Što se tiče neželjenih dejstava u vidu kožnih i promjena na noktima, a to su paronihija i raš, česti su. Mnogo je važno da to pacijentu unapred kažemo i naravno da doktori koji sprovode lečenje ovim lekom to imaju u vidu da nekako očekuju da će se to desiti, ali su najčešće niskog gradusa. Ovi gradus su 3, vidite, raš gradusa 3 je samo u 3% slučaja, a paronihija 1,8%. Dakle, retko se to dešava da nekog ozbiljnijeg gradusa, ali je takođe isto važno preventivne mere, ako su moguće. I ovo je moj poslednji slajd. Kokun studija koja se bavi isto preveniranjem ovog drugog neželjenog dejstva koje je najčešće, a to je raš, i koja je dizajnirana tako da se uz neku profilaktičku primjenu nekih lekova izbegne ovako velika učestalost raša. Ja ću samo ovde prokomentarisati jedno naše iskustvo koje možda baš me asocirao ovaj slajd na to. Dakle, pacijent koji je lečen amivantamabom je imao raš gradusa 2. Mi smo to, moram da priznam, zbrinjavali onako kako smo vidjeli da protokol nalaže. Drži se taj gradus 2 tako kako jeste, pacijent je motivisan, znao je šta ga čeka, ima dobar respons inicijalni osnovni, ali ipak da ne bi se to progrediralo u gradu Stri, u nekom trenutku smo ga poslali u ambulantu za zbrinjavanje na našoj kožnoj klinici, gde postoji ambulanta za zbrinjavanje neželjenih dejstava i inovativne onkološke terapije, što je stvarno jako vizionarski sa njihove strane. I kad nam se pacijent vratio sa izveštajem, videli smo da je on dobio upravo ono što na ovom slajdu stoji od strane profesora Škiljevića, dakle upravo ovaj enhanced derm prevention sa doksicilinom, sa Roche-Posay, Lipikar, lokalnom terapijom, klindamicinom, dakle sve onako kako stoji na slajdu, iako je to, da kažem, najnovija studija i koja, da kažem, tek treba da pokaže svoje pozitivne rezultate. Zaključak moj je ono što svi dobro znamo koliko je važan multidisciplinarni pristup, dakle moramo da imamo tim ljudi, ali dobrih konsultanata koji su stručnjaci, eksperti u ovoj oblasti i onda možemo slobodno da primenjujemo ovaj efikasan lek. Hvala na pažnji.
Ovo rano doba podstiče u ljudima tačnost, akuratnost u izlaganjima i ja se mnogo zahvaljujem na tome. Stvarno imamo predviđenih 5 minuta za diskusiju i zapravo to su ove ključne poruke kojih smo svi svesni i sve je to već rečeno, ali lepo je i ponoviti na kraju. Znači, Bojan je pokušao vrlo plastično da nam i tačno objasni koliko je zapravo ovo jedan enfant terrible u EGFR porodici, nestišljiv, terapijski neprilagođen, ne sluša vodiče za EGFR, nikako se ne uklapa i prosto ta rezistencija na sve dosadašnje trike jajeve nije davala preterano optimizma. Ono što imamo, to je platinski dublet u frontline-u za sada, jer platinski dublet ipak da neku, dakle, osnovu za dalju akciju. Ono što smo sada videli, što je standard of care u ESMO vodiču, to je da je monoamivantamab u drugoj liniji preporučen u najnovijem ESMO vodiču za drugu liniju i da nam ostaje, dakle, pitanje kombinacije koju nekako je to prirodni tok, M kombinacija, M frontline, zvuči jako poznato, ali sa egzonom 20, reklo bi se, ništa ne ide klasično, pa za sada, evo, i ovde sve ide dobro, osim te toksičnosti. Videli ste da je mnogo učinjeno na kupiranju i kožne toksičnosti i infuzione toksičnosti. Jedna od tih stvari koja je u ispitivanjima, to su subkutane formulacije leka, koje treba da, o njima će danas još biti reči, ali subkutane formulacije leka treba da smanje, dakle, frekvenciju i težinu neželjenih dejstava leka i ako nam je to negde potrebno, to je ovde slučaj. Evo, ja bih zamolio za komentar ovih stavova i da li imate neke završne poruke u vezi s ovim što je sad rečeno.
Ja ću se samo vrlo kratko nadovezati s obzirom na 2 minuta na tebe. Nekako mislim da je u našoj lokalnoj kliničkoj praksi jako važno da zaboravimo na priču o afatinibu kao leku za egzon 20 i za uncommon mutacije. Ne, nema ga. Afatinib ne postoji tu i Viciu Martis je dati afatinib kod egzon 20 insercije. Dakle, greška lekara koji je potpisao takvu jednu vrstu odluke. Platinum dublet je taj koji mora da ide u frontline-u. Prave, mature rezultate ćemo tek videti, ali ono što znamo da imamo etabliranu drugu liniju kod egzon 20 insercije. Toksičnost jeste vrlo značajna. Gledam ovde malo ispod bine i o njoj ćemo još mnogo razgovarati, ali mislim da je preventabilna i mislim da se u borbi sa tom toksičnošću ne moramo striktno držati onog što je napisano u kliničkim studijama. Mi smo onkolozi. Dakle, možemo malo i da primenimo svoje iskustvo koje imamo u borbi sa toksičnostima da bismo ih što više smanjili. Eto, toliko od mene.
Hvala.
Da, i evo samo par reči od mene za kraj. Da, pomenuli smo danas i naravno svi znate koliko loše zapravo insercije egzona 20 reaguju na standardne EGFR inhibitore. Da bi Ono što je mnogo važno, mislim da ne propustimo ove pacijente i da ih testiramo. Ovo kako ih trenutno testiramo, samo podsjećam da nije dovoljno dobro, da puno njih propuštamo time što ne radimo NGS i na taj način, da kažem, jedan određen broj pacijenata gubi dobru terapiju i onemogućeno im je dugoročnije preživljavanje. Tako da mislim da je to korak na kome bi morali u ovom trenutku da radimo.
Hvala. Znači, testirajmo sve pacijente, borimo se da nam uđe NGS, mislimo na perspektivu da je gotovo 50% pacijenata živo posle 2 godine terapije, što je, odnosno od početka terapije, ali ne moramo trampiti, dakle, život za toksičnost, nego čuvajmo život, a borimo se protiv toksičnosti. Hvala vam svima na pažnju u ove rane sate. Hvala komoderatorima. Good morning, everyone. Dear guests, dear colleagues, good morning once again. In my personal name, in the name of my co-chairs, co-moderators, Professor Zaric and Dr. Spasic, I would like to welcome you all to this second masterclass on lung cancer here in Belgrade. At the beginning, let me express my gratitude to our distinguished guests from European centers, Professor Sanjay Popat from Royal Marsden Hospital, London, Professor Rafał Dziadziuszko from Medical University Gdańsk, and Dr. Martin Igor Gomez Randolfe Rodriguez from Christie Hospital, Manchester, originally Gallego from Spain. Equally warmly, we welcome our friends from our region, Professor Marko Jakopovic from Zagreb, Professor Katja Mohorčić, and Professor Uška Janžić from Golnik, Slovenia. We cordially welcome you in Belgrade and want to thank you all so much for your willingness to come and to participate in this exciting lung cancer meeting. I cordially welcome also all the participants, and I do hope that you feel comfortable in this oversized, ESMO-sized room with a nice garden view. And please, let this masterclass organized alongside with 61st National Oncology Congress begin. I'm now inviting the first session moderators to take a seat and to start the session, please. If you want to say some words.
Just good morning and welcome, and if you have any needs or problems or anything, we're here, and we invite you all to have fruitful discussions because we have allocated enough time, so please don't be shy.
Before starting, just pour yourself lots of coffee because this is going to be a long session. Welcome. Marko, ti kreni. Okay, then we can start, not to waste any more time. I'm delighted to introduce you our first speaker, Dr. Vladimir Stojšić from the Institute for Pulmonary Diseases of Vojvodina here in Serbia, with a topic tickling a little bit about screening.
Hello, everyone. Welcome to the Lung Cancer Masterclass. First of all, I want to thank you, the organizers, for this opportunity to be here and to have an opening session. I will tell you something about why should lung cancer screening be implemented. This is a very important and interesting topic regarding screening and early detection of lung cancer. I have no conflict of interest regarding this topic. And I couldn't start this presentation with a different slide, but this one with the latest GloboCan results from 2022, which reflects our sad reality. So unfortunately, incidence of lung cancer continue to rise, and we currently have 2.5 million new cases every year with 1.8 million deaths. And when you look at the both categories, incidence and mortality, lung cancer is by far at the first place regarding other cancer localization. And if we want to do the comparison between other localization and lung, we can see that in comparison with incidence, there is not a big difference between first place and second place. But in terms of mortality, the difference is more than obvious. So lung cancer is an absolute #1 killer of all cancers. What are the 3 most important strategies in the battle with lung cancer? The first is smoking cessation, second one is lung cancer screening, which I will talk about, and third, also important, improved and more effective radical treatment of lung cancer. So unfortunately, too many patients we see every day in our practice that are present too late. The majority of them, almost 70 to 80% of patients, come to our hospital in late stage when chance for cure is minimal, almost zero. And that fact didn't change during the time. I show you on the right-hand side of the slide our cancer registry data from 2010 to 2020, our trends, and we, during a period of 10 years, observed a lot of changes within several categories, but unfortunately, one thing didn't change. It's distribution according to the stage. Unfortunately, we still have around 70 to 80% presented in stage 4 lung cancer at our clinic. But when we look at the early stage lung cancer, early stage disease, we see that if we can find them early, fit patient, resected, we can do very well. People can live for a long time, we know that. And we know also that every millimeter counts, and that's why we are using our staging manual. We know that there are differences between stage 1 and stage 3, it's obvious, but there is also a difference within stage 1, 1A1, 1A3, 15% difference in a mortality rate for the 5-year survival. That's important. So screening is important. We want to find cancer early. Lung cancer needs earlier diagnosis, so I pick up this quote somewhere: the aim of the game is to find them early. So what was the story about the lung cancer screening? So we all know, and back in 20, 30 years ago, people knew that earlier diagnosis means better prognosis, but at the beginning we failed. So initial studies were done, but they are mainly focused on sputum cytology and chest X-ray. They want to find the cancer earlier. And the National Cancer Institute Cooperative Lung Cancer Detection Program included more than 30,000 participants to annual chest X-ray versus sputum cytology and chest X-ray. And they found increased incidence and number of resection, but no survival benefit. But because they found a lot of new cases of cancer, they thought that the chest X-ray might be the answer for the screening. The largest one study in that period, the PLCO study, included more than 150,000 participants to annual chest X-ray versus usual care. So annual screening with chest X-ray over 4-year period of time did not significantly decrease lung cancer mortality, which is kind of a goal of screening. So we want to find early cancer, to treat them and to cure them. So the role of low-dose CT scan in detection of early-stage lung cancer, this was described between 90s and 2000. And there were some advantages of this procedure. No need for contrast, less radiation in comparison with regular CAT scan. And there were studies back then with low-dose CT, but at first time they were not focused on screening, but they're focused on just trying to find earlier lung cancer in comparison to chest X-ray. And there was that study, ELCAP clinical trial, which showed that low-dose CT can detect lung cancer earlier than chest X-ray, especially early-stage lung cancer, which is important for us. And there is new millennium. The interest in lung cancer screening continued to grow, and there's a lot of studies with low-dose CT. But there are some who changed the game. The first one, and maybe one of the most important, was the NLST style study, big American trial, over 50,000 participants who were screened to randomized to a low-dose CT versus chest X-ray, and the outcome of this study was 20% reduction in lung cancer death in CAT scan screening group. So it was the first time that we have randomized clinical evidence that low-dose CT reduces mortality and saves lives. In Europe, there was Nelson trial, which did basically the same. It was also a positive study with 24% reduction in lung cancer mortality with low-dose CT screening at 10 years. And the third big study, also from Italy, which maybe at the beginning was a little bit under the radar, because at the 5-year follow-up, this study was negative. And then the researchers decide to do a prolonged surveillance and to prolong the period of observation. At the 10 years, the study was positive. The 39% reduction in mortality in mild trial was a confirmation of the efficacy of low-dose CAT scan. So basically, we can maybe stop there in matters of evidence for lung cancer screening. We saw the results of 3 big randomized clinical trials that clearly show and demonstrate that low-dose CT scan screening can save lives and decrease mortality. But in lung cancer screening, it's not that simple. It's very complex. So basically, there are a couple of concerns we have with lung cancer screening, and the first one is are false positives. So we all know that the low-dose CT scan will find something in your lungs that it's not cancer. And for instance, if someone tells you that you have something in your lungs and even it turns out to be nothing, it's a stress, anxiety. Even if we continue to further investigate with imaging, biopsy, bronchoscopy, even surgery, and it turns out to be benign, it's still not good. The worst case scenario is to have a complication of those further investigation. So we need to decrease the rate of false positive findings. In larger study, I mentioned earlier, the rate of false positive findings were between 1 and 30%. 1, 2, 3, 4, 5%, maybe it's okay, but 30% it's unacceptable. So it's one of the 3 patients will have a false positive finding. But today we are better now with better algorithms for lung nodule management. The second concern is participation. So people we want to see in a screening program are those we often see late. So high-risk patient, high-risk people, older age, active smoking, usually with lower socioeconomical status. Those people we want to put into screening, and unfortunately, we often see them late. There are also practical barriers among those people with travels, with cost, with distance to the CAT scan, and also there are emotional barriers too. Now let's see who should we screen. So in lung cancer, I told you already that the screening program is very complex. So we cannot say let's screen all people over 50 years of age. So we need to be more precise. Age and smoking status are not enough. We need risk models, and we do have risk models that give us individual theoretical risk of developing lung cancer. And those with higher risk are those with higher benefit. And those are the people we want to put into screening program. How often should we screen? Some studies suggest annual versus biannual screening. No statistical difference in that matter. For instance, in Nelson, there was baseline scan. After that, they did a 1-year scan, then 2-year scan, then 2.5-year scan. And they saw that the last period of time, those 2.5 years was too long. They saw that significant drop of early stage disease in those periods and the increase of late stage. So I think that regarding how often should we screen, we need risk stratification plus lung nodule management. They will tell us, for instance, Langrad score will tell us, according to the previous CAT scan, how often and when we should do next one. Radiation exposure. Low-dose CT uses less radiation than regular CAT scan. Today we even have ultra low-dose CTs. What might be of concern is additional imaging test. And some risk models suggest that risk overcome benefit in non-smokers and younger people of 50 years. And last but not least, cost effectiveness. I'm basically don't know anything about economics, but I know that targeting high-risk subjects improve cost. But there's one problem there. If you try to super select the population and try to screen a super high-risk people, you will find a lot of cancer, but among less people. And you will have a lot of people missed who also might benefit from that screening. So last couple of slides I reserved for just our data. I will show you just some of our published data. We are young in this thing. The first pilot lung cancer screening in Serbia started in October 2020 in my institute, Institute for Pulmonary Diseases of Vojvodina. And this is our motto. I will translate it. So, požuri snimi, produži život means hurry up, do the low-dose CAT scan, and live longer. These are the inclusion criteria for our program. We'll try to find asymptomatic patient aged between 50 and 74 with smoking history, active smokers more than 30 pack years or 20 pack years plus one of comorbidities of COPD, recurrent pneumonia, previous cancer history, positive family history of cancer, professional exposure to cancerogenic substances, or ex-smokers with more than 30 pack years, but they're quit within the last 10 years. And these are some results which are published in European Respiratory Journal. During 2-year period, we screened 3,432 low-dose CT scans on 2,138 screening responders. The Langrad score was positive in 9.3%. The response rate to control after 12 months was 76.5%. The invasive diagnostics was performed in 2.3% and 0.5% refused further diagnostics. The lung cancer detection rate was 1.8%. And what is good, almost 60% of lung cancer were in stage 1 and stage 2. Among lung cancer patients, almost 90% was non-small cell lung cancer and 10% was small cell lung cancer. And to conclude, I think that today the evidence of lung cancer screening is stronger than ever. We saw 3 randomized clinical trials showing significant lung cancer mortality reduction and further evidence coming from smaller European trials. Screening is already live in some part of Europe, and we will hear that in a minute. In Croatia, in Poland, I know it's live. Still, we have some issues to overcome: resources, radiologists, standardized protocols, collaboration between primary care and specialist center. And at the end of the day, different countries have different systems and different needs. Thank you for your attention.
Thank you. It is my pleasure to introduce Marko. Marko is one of the leaders in screening program in Croatia, which is not alive and kicking, but also giving very, very good results. And I have to admit, we took their screening program and make it our pilot.
Thanks, Bon. Dobro jutro svima. I'll switch to English. Sorry, I have to say hello in Serbian or Croatian language, so everybody can understand me. So thanks for the invitation. And I will try to tell you at least some preliminary data and design of our nationwide screening program in Croatia, which was actually one of the top 2 in the world, which started, like first was South Korea, and in Europe, Croatia was the first. So, but we are much smaller than South Korea, that's easy to do it. Vladimir showed you the data about the importance of lung cancer, and what was the problem in Croatia? We are at the bottom of the economics. If in the European community, we are really high in lung cancer mortality incidence of ratio between incidence and mortality. And that's why we decided to think about a lung cancer screening program in Croatia. What was the problem is that this is one of the mottos at least from our lung cancer screening program: the stage is a destiny. If you have early stage, then you have a much higher chance to get cured. There was a former motto like tissue is the issue. We will talk about it later on in the predictive biomarker session and the targeted treatments, but this is something which is really important. So stage is a destiny. What was the problem? We saw that this slide is NLST data. It was published like more than 10 years ago now, and actually nothing happened really. We were discussing for the 10 years much more about the harms of the screening than the benefits of lung cancer screening. And then what was the problem in the US still? I think the response rate is below 5% of selected population or high-risk population. So this is something going wrong, at least in Europe and US, with the response to the lung cancer screening. I will try to show you what we did in Croatia. So what changed everything, at least in Europe, is the Nelson data. What was the problem with the Nelson data? They designed the study only for the males, and then in the between they put women inside, and they have just around 16% of women, and they have much more better data with the lung cancer screening in females than males, but that's what it is. So we started nationwide lung cancer screening program in the middle of COVID era, so it started a little bit slow, and then speed up much in the last couple of years with a response to the inclusion of the patient, not the patients, population to the lung cancer screening program. Our head of program is my boss, Miroslav Samaržija. It was first national lung cancer screening program in Europe, and it's fully reimbursed by National Health Insurance Funds, so it's free for the all participants. And then we designed it to include smoking cessation program, at least at the beginning. We a little bit slowed down because of the COVID era, because we couldn't do it in person. But we know from all of the trials that all the lung cancer screening programs, which included smoking cessation schools or programs, are having much better results in the outcomes and mortality. So these were our 10 pillars, how we try to design the lung cancer screening. First, this is the inclusion criteria. It was pretty much similar, 50 to 75 years of age, heavy smoker or ex-heavy smokers. So it's pretty much the same. Remember, this was designed in 1918 and 1920, before 1920. So that was a little bit different now, and we are going to the extension of the program because it's over this year for the first 4 years, and then we'll decide to, include probably a little bit more non-smokers and put it lower age limit to 45 maybe, but we'll see what will happen. So we did a lot of education, that was one thing, and that's especially the radiologists, because the small nodules are something which is really different, so we try to decrease the number of false positive results. So because of the low response rates, because all the people in Nelson trial and LSD trial are getting letters to the home address, and then if you're, I don't know, 75-year-old COPD patient, and you had a bunch of inclusion and exclusion criteria, nobody will go anywhere, right? So we decided to put a general practitioner in the middle of the invitation of our population. So our GPs are supposed to talk to go to the database. It will be great in UK because GPs are in the middle of everything in UK, right? But still, if you go to the GP should talk and go to his or her database to see who is smoking or not smoking, who is not having any other disease, which is exclusion criteria, and then send this person to the low-dose CT to get the results back, and then depending on the results, do nothing, just put it back in the screening or send it to lung nodule clinic, which we developed, right? The other thing is that we're also looking for the thyroid gland, coronary artery, calcium score, some interstitial lung disease, emphysema and everything, so they can send those patients then to some other specialist if it's needed. So what we did at the beginning, we started with 16 centers across the Croatia because we are like banana-shaped country, so it's far from Osijek to Dubrovnik, but we did it in 16 centers. Now we have 21 centers. We need at least 128 CT scanners. We have to do the low dose or ultra low dose protocol with less than 1 millisievert radiation exposure, and we did it. I'll show you that a little bit later. We are doing these low dose CTs without a contrast, and we have these 6 lung nodule clinics, so in larger hospitals which are having everything from diagnostics to thoracic radiotherapy to thoracic surgery and to all the interventional radiology, pathology, and all the other tests. So this report was structured, but what was the biggest issue that we are not using Lang-Ratz protocol. We modified this IELCA protocol just for the Croatia with the help of people from Mount Sinai Hospital, Claudia Henschke, David Yankelevich, who were pioneers and still are pioneers in lung cancer screening. So this is really complicated, but nevertheless, the idea is to do the baseline CT scan, then after 1 year, if everything is okay, and then every 2 years later on. So we have 3 different results: negative, semi-positive, and positive results. Depends on the two parameters. First was the diameter, below 6.5 millimeters and above 15.5 millimeters, and this is like positive and negative. In the middle is semi-positive, but we also included volume, so we did a volumetry, so this is something which is completely different. And then what is really important is this volume doubling time. If it's below 400 days, then it's for sure, probably it's 99% it's malignant. If it's larger than 600 days, it's probably benign. In the middle is again semi-positive, so we are doing a lot of different analysis, not just diameter like in LSD trial, so we are doing volumetry. What is the problem? That we need to have completely different education for the volumetry and the small nodules, and then we are included also artificial intelligence. It was like primitive artificial intelligence back then, like 5 years ago. Now we are introducing a much more advanced artificial intelligence program who can be like something like Sybil, which was done in MIT, who can predict probably the lung cancer probability after just initial first scan. So we are doing continuous education. We are having external experts, quality control. We are trying to decrease those every year because we have a lot of physicists in our team who are measuring all of those radiation exposure, and we are just improving and decreasing the dose. And then, of course, we're having these MDTs in these lung nodule clinics to decide what to do with, I don't know, with a nodule which is large, I don't know, 5 millimeters. So Vladimir told you that if you are having a nodule which is like semi-positive, it's like 8 millimeters, and somebody tells you, come on and go for the next CT in 3 months. I would be, I don't know, scared as death to wait another 3 months for such a small nodule. So it's free for all participants, which I always said. So I will just briefly go to the results because they're not published yet. This is something which was done in the first 3 years. We scanned more than 25,000 persons back then. We did at the beginning 32 scans. But what is the problem? We have pretty much the same ratio of males and females, which is great, which is not so typical for other lung cancer screening programs. They are pretty much younger, and we found 1.4 lung cancer in that group of patients. So the vast majority of those patients were in stage 1 and 2, but still we found 40% of inoperable lung cancer patients. So this is something which is I'm in concordance to, I would say, with the other results of the other trials with a percentage of lung cancer between 1 and 2%. What's the problem is that if you look at the data from Thailand, in females who are not smokers, they're having incidence of lung cancers, which is even higher, almost 3%. So that's why we were thinking to include non-smokers. So we're going to do veterans, because we had a war in this region like 40 years ago, so there's a lot of veterans, and we know they are also at higher risk of lung cancer, so we'll include them also, including non-smokers, to see what's going on with the non-smokers, because when we were talking with the public, everybody said, I'm a non-smoker, I'm living healthy, and I'm not allowed to go to screening. And then you are screened the persons who are living unhealthy, having, I don't know, 3 packs of cigarettes a day, and that's not fair. But then the explanation is there is no data that lung cancer screening is good for non-smokers. We will see. Probably it is with this extreme low dose CT scanners now. And this is the current status, that we screened more than 35,000 people, more than 47 CT scans were performed, and we are in the middle of processing the data, so I think the data will be presented in the beginning of next year in much more details. We also noticed the stage shift, so we have, at the beginning we had, I don't know, 60% of stage 4 lung cancers, now we are having less than 30% of stage 4 lung cancers, so we're having much more earlier cancers in our program, so I think that our goal is to decrease the mortality in the first 5 years for 20% of lung cancer. I'm not sure we will manage to do that, but we will see the results pretty soon. Thank you very much for your attention.
Davorin, Rafal, can we join on the stage for the discussion? We have some 15 minutes for the discussion too. And I'd like to kickstart while the guys are taking their positions. The ultimate goal of the screening is actually curability. So we want to decrease the mortality and increase the detection rate. But we are dealing, and both Marko and Vladimir showed, with aged population, with smokers who have a lot of comorbidities, mostly COPD, mostly emphysema, and who are technically resectable, right? But the question is, are those people operable? So besides the surgery, we might need a very, very much experienced radiation oncologist and SBRT to deal with the lesions which are discovered and probably or possibly confirmed to be lung cancer. What is the comment?
If I can comment on that, we have an experience for the last 20 years in our SBRT program, which is very nicely coupled now to our experience in the screening, which we have for more than 15 years. We had screened 2 cohorts of participants with almost 20,000 people involved. And SBRT is a good option now for these patients. Even 1 fraction, 30 grays for patients with comorbidities is an excellent, provides an excellent local control. So obviously for those who need to implement lung cancer screening program, comprehensive lung cancer clinic should include radiation oncologists as alternative to surgery. And clinical trials, the first set of clinical trials, surgery versus SBRT, didn't really show much because of the lack of accrual. However, there are still ongoing clinical trials on exactly this question. So high-risk operable patients, SBRT versus surgery, a trial run in Texas, but also other studies. So obviously this is a very good option for some individuals, and these patients should be discussed by the MDT, which is specialized in the screening program. And our biggest problem actually is to have enough experienced colleagues to manage these patients. The resources, the human resources, not only on radiology side, but also on MDT side. It's a huge problem.
Thank you. This masterclass is for the audience, not for us. So before we kickstart, any questions from the audience? Can we have the mic in the audience, or no? No.
So Marko, you were saying, and you started on the subject of other populations who are maybe will need screening without, not just the standard criteria. Can we discuss a little bit about air pollution and areas with high air pollution, and whether in certain countries the screening criteria should change?
If you go to China, it's like that, right?
Well, it's horrible in Serbia as well. I'm sure it's horrible in Croatia. Do you think that, or any of you, do you think that in the future we will have to change, at least for some countries, the criteria with regards to air pollution?
So we are in the middle of the process of doing that, because, for example, if you're in Serbia and you're doing in a bar and you're like waiter and you're not a smoker, you smoke like a half or pack of cigarettes every day, because everybody smokes in cafes. At least in Croatia also, so at least not in restaurants in Croatia, but that's one thing. So we are trying to include people with a professional exposure to something. Like we had a lot of those asbestos exposure previously when we had like shipyards. Now probably the parts of the countries with the air pollution, we'll think about including at least females with a heavy history of lung cancer also, and then we are going to the non-smokers, so this war veteran population, so we'll see what will happen. But you're absolutely right. If you're living, I don't know, in Beijing, then it's, I don't know, you don't have to smoke. I mean, your lungs are very affected with the pollution, so it's not, this is something which we need to do. I mean, there's a lot of data coming out that it's working, that lung cancer screening works in those not previously thought just heavy smoker population, right? Just to answer to the first question, we are using SBRT in those patients who are medically inoperable, of course. But the other thing is that we have a lot of big problem in Croatia, because there's 10%, at least 10% of patients, because it's not a clinical trial, right? This is real world data. We have, I don't know, 10% of patients who are coming to the screening who shouldn't be coming there because they have some other medical illness, doing CTs for something else, right? So this is a little bit different, which is probably biased, because if you have, I don't know, heavy COPD patient with emphysema, that's the patient who should be doing CT, I don't know, every couple of years anyway, right? So it's not probably for the healthy smoker, right? For example, who are supposed to come to the screening. And then if you have patients with the IPF who's going to the screening, he or she is also doing CT scan, right? So that's a little bit issue, at least in the moment, because waiting list for the CT scan for this program is shorter than the regular CT in some cities, and the GPs are then using this niche of getting quicker to the CT scan, right? But nevertheless, that's less than 10% probably. We'll see when we do all the analysis of the data.
Well, sometimes I think that we're lucky because the population of Serbia and Croatia is less than population of London. So there is a lot of people who are at risk. Davorin?
It's 10 million people
Altogether.
Altogether. Yeah. We are at the very beginning in Serbia regarding screening process, and we had some pilot in Vojvodina, and now it's starting in Belgrade also, pilot project. And we try to learn from abroad. But I think that it should be the screening program along with the generally measures. Smoking cessation is a great problem in Serbia. Some older data, but I think that they are still valid. Around 40% of adults are former or current smokers, especially younger women and so. So general measures, public campaigns, and then we should come to early detection. The terrain should be arranged for screening program. It's expensive for poor countries. I think we are again a developing countries. One we was in higher economical level, but okay. So everything is okay. Screening, CTs, experienced radiologists also. We have obstacles in mammography also, problem with experienced and available radiologists. I suppose that the radiologists in screening program in Serbia will be also a greater problem than in mammography. But the situation is such that medical oncologists are great promoters of screening programs, not so epidemiologists and social medicine specialists, but we are dealing with the very advanced patients. We every day are seeing the 30% of patients that are for palliative care only at the first MDT. We have MDT in all Serbia. It's one of the strengths of our system. We established the Consilia, as we saw it in 60s. The first Consilia was established in 1961 in Belgrade. So it's not a problem in MDT. The problem is the late diagnosis. So that's why we put screening at the start of this masterclass.
There's two questions from the audience.
Okay, thank you very much. I'll be quick. Davorin, you mentioned smoking cessation is a problem in Serbia and probably all around the world. But we know that if you implement a smoking cessation program in a screening program, then it's much more successful. Can you please comment from Croatia and Vojvodina side? Do you have any such programs implemented in your screenings?
Yeah, I showed it, but we are having that, but we stopped like when the COVID era started because we couldn't do the in-person these programs because it's not allowed, and now we are doing this again. So we'll start again doing this, but I'm not sure how many of these smoking cessation schools are spread throughout Croatia. I mean, 40% of 30% of all scans are done in Zagreb, so we will do that in Zagreb at least, but there are a lot of those schools in bigger cities. I'm not sure about the smaller cities in Croatia, but we are having that included in the program, and it's free for the participants.
It's completely the same in Serbia. So the smoking cessation programs are within the GPs, and unfortunately I don't think that those programs are actually anything more than just a word on a paper. Sanjay.
Well, first of all, congratulations to both of you in setting up these programs, because undoubtedly they are saving lives. And I think it's one of the most important things that we as healthcare professionals can do is to embed these programs and ensure that they're a success. And certainly the metrics that we've seen today are internationally benchmarked for the rate of positivity that you've identified, and huge congratulations. My question is really about how we can increase the uptake, because often the problem is that those at highest risk do not recognize they're at highest risk. And certainly our experience in the UK is that those are in the lower socioeconomic classes with increased tobacco exposure are often nihilistic about the future, therefore do not uptake in screening invitations. So what are your plans in your countries for increasing uptake? Because it's a real challenge.
So when we started, we did a lot of those TV and radio commercials. We are doing a lot of those, posters and put it all around. But I think it didn't work a lot, right? I think this was just good for the Ministry of Health to see what's going on, right? The best thing that we did is to include the GPs who are in the center of everything. So actually, the person can see the commercial and see I'm high-risk population. Then he or she should go to the GP to get the slot for the CT scan. So I think this is the best thing that we was to include GPs, because the response. I think we plan to screen around 50,000 people. That was like estimated population at high risk, and then we did it like more than 35. It would be like close to 40, so it's like really good uptake, right? And then what we saw is that persons who are talking to the GPs, response was almost 90%. And because GP is doing, information, conversation, and it's like persuading those people to come to the CT scan. So this is I think the best thing that we could do. If you're driving in subway in the US, you see a bunch of those commercials, go to clinical trials, go to whatever, but I'm not sure that it will work at least in Croatia. Maybe in US, but in Croatia definitely not. So we are doing again another round of TV commercials and everything, but I'm not sure. I think this GP is something which helped a lot.
Yeah, and we've been learning a lot from Croatians. So once we saw what they're doing and how does it actually affect the reach to the patients, we decided to do two things. One was to educate the GPs, because we figured out that the GPs are not informed enough, because the lung cancer screening story is mostly the story which was reserved for the lung cancer conferences and meetings, and the GPs were not so aware of the size and the magnitude of the problem. So we started, and we called it an education caravan. So we started educating GPs around Vojvodina. The territory of Vojvodina is a part of northern Serbia. It's a small territory of 2 million people, but a lot of secondary centers in which we could influence both GPs and local pulmonologists. And then during some time we figured out that a very nice type of pressure would be to pressurize millennials to pressurize their parents. So we started Shiny, little podcasts and TikTok stories and the Facebook stories, which were tickling the millennials to tell the parents, look, you have like more than 55 years, maybe you should go to your GP and go to screening. So
but they're smoking much more than their parents now. It's at least in Croatia,
yeah,
the millennials,
unfortunately.
right?
Yeah, unfortunately, but it has a reverse effect. So that's what we are trying to do.
If I can tell a little bit about the Polish experience, we actually have in Gdańsk an experience in screening since 2007 already, when we started. Now, thanks to my surgical colleague, Professor Witold Rzyman, we have completed a nationwide pilot project in 6 regions of Poland with a common database for scans and with a program that is currently evaluated before nationwide screening decision takes place. One of the biggest hurdles actually is really to see the overall mortality benefit. We have seen nice figures about lung cancer screening mortality benefit. You should, however, remember that overall mortality is the ultimate goal of the screening. So undoubtedly, it has to be linked to effective smoking cessation program in order to maximize the mortality, the overall mortality benefit. Because there is no question this is the way to go. We have seen the data from the Far East on the populational basis already, not only in terms of how many cancers can we find out during screening, but overall mortality by addressing so-called big 4, the main killers in this population, would be much more effective to be coupled with screening. And this is the way we are hopefully be addressing this problem in the future. Let's see, but the point of enough resources is a huge point in terms of scanners, in terms of additional points, because we are overloaded with experimental explosion of radiologists' workload. One of the biggest projects for the near future is to have AI implementation in this field. For the moment, we have failed to have AI being enough good with diagnostic accuracy. The point is now to provide such an AI algorithm that could really tell who is nodule free. So at least to get rid of completely negative scans, to facilitate the reading only on those who have any kind of nodule by radiologist, is the current situation which we hope to address.
Thank you very much. Lots of work ahead of us, but part 1 masterclass is over and we're getting to the part 2. Thank you very much.
Davorin, you're a moderator with me, so I don't know why you're escaping. Yeah, with me. So we're going to part 2. So we will talk about the advances in early stage of non-oncogene addicted non-small cell lung cancer. An intro will be done by Dr. Georgievich, and then we will go to see what's going on in this field. This is good continuation of screening program because in lot of those patients we should implement some sort of treatment, not just surgery. Feja.
Thank you, Marco. Good morning, everyone. It's a great pleasure and honor to be here with you. I would like to thank the organizing committee for opportunity to speak about this rapidly evolving and I would say exciting field of lung cancer. I will give an intro about moving therapy into early stage. Okay, here. Okay. So this is my disclosures. As we know, early stage non-small cell lung cancer will be presented and diagnosed in approximately 20 to 25% of the patients. We are in the curative setting and the cornerstone of the therapy is surgery, and it could be followed or preceded by systemic therapy and radiotherapy. But despite this, a majority of patients will relapse. You see that incidence of relapse is going higher as the patient is presented in advanced stage. And I would say the morphology of the relapse will be 70% distant, so patient will be presented as metastatic disease. In the last 20 years, former standard of care was surgery. And we actually wanted to help with neoadjuvant chemotherapy with 5% overall benefit with 5-year overall survival. So hazard ratio was 0.87. With neoadjuvant, we gave also adjuvant therapy with the same benefit of 5% in 5-year overall survival. Even when we actually try to compare this neoadjuvant and adjuvant approach, it was practically the same. Result was the same. So we were thinking, how can we do better? And what we learned from the metastatic disease. And now I will show you improvement in 5-year overall survival with targeted and immunotherapy. What we learned from the ALK world for the beginning, these patients are still alive after 5 years, 70% of them, who are ALK positive and who are receiving ALK inhibitors. From the EGFR world, we have more than 50% of patients who are alive after 5 years and who are receiving EGFR inhibitors. But this topic is not about oncogen addicted and non-oncogen addicted, but still for them we have a large benefit in survival. 1/3 of them will be still alive after 5 years. And can these achievements in metastatic disease can be translated to the early stage? What we know. First, we have one biological rationale for all of this. I will start with neoadjuvant immunotherapy. We still have tumor in situ, and with immunotherapy, we will activate many of different T cells, and then when the surgeon removes the tumor lesion, many more will come, and many more diverse T cells will search for tumor cells. And in the adjuvant setting, where the tumor is actually removed, immunotherapy will activate a few different T cells, but the still answer will be there. So we have a biological rationale for all of this. And that was, I would say, the rationale for all of studies that were now, here I presented phase 3 studies that are all positive, and it's different in different approaches. In neoadjuvant approach, we have CheckMate 816. In perioperative approach, we have these 4 studies, and in pure adjuvant setting, we have these 2 studies. I will briefly show you the results and the best representative of all approaches. When you're talking about adjuvant immunotherapy, we have IMpower 101 and Keynote 191. The difference is not big. I would say in IMpower 101, patients went to surgery, then received chemotherapy, and then after that, immunotherapy. And chemotherapy here was, I would say, mandatory, but it was not mandatory in study Keynote 091, but results were actually the same. DFS was positive for all the studies. So we have a standard, I would say. Then, even better, in neoadjuvant approach, we actually enrolled patients with stadium 1B to 3A, and randomized 1-to-1. Patients received 3 cycles of nivolumab with chemotherapy and compared with just chemotherapy. And the primary endpoint was complete pathological response and event-free survival, which is typical for neoadjuvant study. And you can see the results, magnificent. So even we have data for overall survival, 3 years overall survival. So we have positive results in adjuvant setting, we have positive results in neoadjuvant setting. And can we do something between, or some kind of sandwich approach, I would say? Okay, we have Keynote 6.1 study. We go give immuno and chemo before surgery, then surgery, and then again immunotherapy. And even for this study, we have overall response data, and this study was totally actually give something different in the treatment of our patients. And I will not conclude that. I will actually raise the questions and some dilemmas that we have from this whole journey of the patients. First, I would like to, and I hope that I will hear about surrogate endpoints and biomarkers for event-free survival and overall survival. I do hope that we will discuss about any biomarkers in this setting, PD-L1, tumor mutational burden, and circulating DNA. We will see that maybe the difference between neoadjuvant immunohemio versus adjuvant immuno, and we will see who are the patients who need adjuvant after neoadjuvant. We will see the duration of neoadjuvant therapy and duration of adjuvant therapy. And at the end, patients who are oncogen addicted, do we need immunotherapy in perioperative setting? Thank you.
Okay, thanks, Veja. We are moving on. Jelena, Dr. Spasic, she will talk about these endpoints that you mentioned, Veja. So we'll see what's going on in this field.
Morning again from me. So this is not an easy topic, but I will try to tackle it to the best of my abilities. These are my disclosures. And first, I think, is it going? No, it's not. Okay, here it is. So when we start talking about the efficacy of a treatment, any treatment, I think the first thing we have to decide and define is how can we assess the benefit of a treatment or any treatment. And we have two ways. One is, does it prolong life? And that translates to improvement in overall survival. And the other one is, does it make life better, or does it offer improvement in the quality of life? And both these endpoints are equally important. They're completely different. One is quantitative, one is qualitative, but they should be assessed. Then the other question is, if we're talking about endpoints, are they all appropriate for different stages of disease, or are they different in early stage versus metastatic disease? Is one endpoint appropriate for all types of treatment regarding their mechanism of action, and of course regarding the goals of treatment and the phase of clinical trials. Overall survival has been the gold standard for years. It is defined as time from randomization or treatment start to death from any cause. So that's the important thing. And of course, it has many benefits to it. It is completely relevant, of course, because it measures the ability of a treatment to prolong life. It's very objective because we know the end of the period. The end of the period is death. You can't really be subjective about that. It's really easy to measure, therefore. It's powerful, and it has a long-term effect because it demonstrates the long-term efficacy of a treatment. However, because it's a long-term effect, it takes a long time to measure, and therefore it takes a large sample size, and therefore some treatments that are maybe very efficacious will not get to the clinical practice very quickly or in time. Then it is affected by crossover or the subsequent therapies, and of course by the competing risk of death, because as I said, it's death from any cause. So can we do something else? Are there any alternatives to overall survival? If we look at the table of these very important early stage clinical trials, which I've given here, and if you look at the primary endpoints which I've circled, OS is not really there. OS is a secondary endpoint of all of these trials. We have DFS or EFS, disease-free survival or event-free survival. We have the pathological endpoints such as complete pathological response or major pathological response, and then we have some subgroups in some of these studies. So we have, if we talk about these early endpoints, we have two kinds of them. We have these early time to endpoints, which is event-free survival and disease-free survival, which are basically the same but not completely the same because they have a different start. So disease-free survival is from start of surgery when the patient is assumed to be disease-free, And event-free survival is the time from primary treatment, which is usually neoadjuvant, some sort of neoadjuvant therapy. The end is the same. It's a complication from cancer or some sort of event, disease progression, recurrence, treatment discontinuation, or whatever. And of course, they have their advantages and their disadvantages. They are, of course, relevant because they measure the ability of a treatment to delay recurrence of progression. They are easy to measure. They are early. And they can give an idea of the aggressiveness of disease, so they have a prognostic value. They're not affected by further treatment, and in some countries and in some diseases, they have a regulatory acceptability, or regulators have stated that they are acceptable for reimbursing the treatment. However, maybe these endpoints will or will not translate into survival, or they are not surrogates for survival. We have different definitions between clinical trial, and then the event can be subjective. It's not death as in overall survival. It is something else, so it can be subjective. The other type of early endpoints are the pathological endpoints, which are very nicely defined here by the IASLC. And it is important to state that these definitions should be used across all clinical trials when we are talking about these early endpoints, because only then we'll have a uniform, we can make a uniform conclusion about their acceptability in further studies. So, can these early and pathologic endpoints be surrogates for overall survival? First of all, what is a surrogate endpoint? It is a predictor that is expected to more rapidly show efficacy of a treatment. And this is based on the Prentice criteria, which have been stated in 1989, so 40 years ago. But basically what the Prentice criteria say that if an endpoint is to be a surrogate, it should be reflective of the effect of treatment. The extent of the endpoint should strongly correlate with improved survival, and the degree of improvement of the endpoint of the surrogate should be associated with the degree of benefit of survival. So if the benefit in EFS is, for example, 20%, it should be about 20% in overall survival. So do we have data for surrogacy of these endpoints in clinical trials? So before immunotherapy, this is a meta-analysis of several trials which included neoadjuvant chemo and radiation therapy in resectable non-small cell lung cancer, and using a very complex statistical analysis which is called regression effect random effect meta-regression. I will not go into that, of course. This analysis showed that there is a strong association between treatment effects for EFS and for OS, and that the improvement in EFS is likely to be predictive of improvement in overall survival. And it was also done in a real-world data analysis from the SEER database of 221 patients, and again we saw a significant correlation between EFS and OS. So this is chemo or chemoradiotherapy, not immunotherapy. Can EFS be surrogate for immunotherapy? At the moment, there is insufficient data because at the moment we only have KEYNOTE-671 that has really mature data for OS. So as the data from the early stage clinical trials with immunotherapy improve and mature, maybe we will have more information. What about the pathologic endpoints, PCR? This is again chemotime, pre-IO, neoadjuvant chemo, or chemoradiotherapy, and the meta-analysis of individual patient data for 24 studies, and you see a lot of patients, and we can see the red lines are patients who had PCR, and the blue lines are patients who did not have PCR, and we see that the difference in 5-year overall survival rate was 63% with PCR and 39% without PCR, and you can see that the EFS also correlates with overall survival, and this is again another a meta-analysis which was published just this year, basically saying the same thing, that if you achieve pathologic complete response, it should translate to benefit in overall survival. I'm not saying will, because this is still not completely decided. However, if we talk about chemotherapy and chemoradiotherapy, the percentage of pathological complete response is very low, 4 to 8%, maybe 15% in some chemoradio studies, but it is very low. So if we now move into the immunotherapy era and immunotherapy studies, This is, again, a meta-analysis or a pooled analysis of 29 clinical trials across tumor types, which tried to see whether the radiological response, pathological response, and relapse-free survival will benefit or could be surrogates for overall survival. And if you see on the top, it's in the whole or across tumor types, you see the hazard ratio is 0.13. So so if a patient achieves PCR, it should translate to overall survival. And on the bottom, in non-small cell lung cancer, which included 9 randomized studies from non-small cell lung cancer, again, we can clearly see benefit. If we look very briefly at the studies, which we have already mentioned and will be mentioned a lot of times during this session, in CheckMate 186, we see that we very clearly see the difference in EFS and in OS in patients who achieved PCR, in those who didn't achieve PCR, and you can see that it is the same even with chemotherapy only, so in the control arm. And the PCR rates are much higher, 24% in this study. Again, Keynote 671, the same idea. If PCR is achieved, EFS should be prolonged and is significantly prolonged. Aegean, again, these two graphs are on the left side is immunotherapy or the treatment arm, on the right side is the control arm. But if you superimpose these two, you can see that if PCR is achieved, then definitely EFS should be prolonged. Again, this all looks the same, but the data is the same, that PCR seems to be able to predict benefit in EFS and OS. Again, these are not randomized studies. This is a one-arm study, NADIM and NADIM2, but still the main point is the same. All these curves look pretty much similar. And does this translate to other tumor types? Melanoma, which is, of course, we cannot not talk about melanoma when we talk about immunotherapy. You can see the difference if there is 100% pathological response with regards to 50%, which is the bottom line. Then again, triple-negative breast cancer, which is a horrible disease, Keynote 522. Again, if PCR is there, then the survival is much longer. Of note, the FDA, when we're talking about breast cancer, the FDA in 2012 and again in 2020 reiterated the fact and approved neoadjuvant or stated that neoadjuvant treatment in breast cancer can be approved based on pathological complete response. This is just for breast cancer, but still it does have regulatory acceptability in certain types. But if pathological response is not achieved, then we have percentage of residual viable tumor, which is how much tumor is left and how much is necrosis and other tissue. And in 2014, Hellman and colleagues proposed did this very nice study and proposed that if there is less than 10% residual tumor tissue in resected lung and lymph node tissues, it should be considered a surrogate for overall survival because of these, because the hazard ratios definitely follow the percentage of residual tumor disease, and they term this surrogate metric major pathological response or MPR. So do we have data about MPR? Again, the same pooled analysis of 29 clinical trials. On the top is MPR in across tumor types. On the bottom is in a non-small cell lung cancer, and we can see that MPR also can be predictive of overall survival. This is all non-small cell lung cancer review, a meta-analysis of 6 randomized studies with neoadjuvant chemo and immuno and immunochemotherapy. And you can see from the forest plots that overall survival, EFS, PFS, DFS, they all are dependent on major pathological response. And we have first data from CheckMate 816 and Keynote 671 with this. And again, you can see the curves look the same. There is definitely a prolongation in EFS if MPR is achieved. And even more, we have a very nice exploratory analysis from Checkmate 816, where you can see that if you have residual viable tumor from 0 to 10% on the left, only in the primary tumor, on the right, in the primary tumor and lymph nodes, which is very important because it may not be the same. You can see that if you go up in the percentage of residual viable tumor, the curves go down. So EFS is shorter. Again, in the Keynote 671, this is a bit different because they did a slightly different grouping of the RVTs, so they went 0 to 5%, 5 to 30, 30 to 60, and over 60. And definitely, if you go over 60% of residual viable tumor cells, it is not good. The EFS is going to be much shorter. So, can we reach a conclusion? As I said, it's not going to be a definite conclusion because data is not still mature, but we're getting there. All these endpoints that I've talked about can be achieved early. Therefore, they do give a sense of efficacy of a treatment, and potentially they could provide earlier availability of active treatments. But can they be used as prognostic markers and as surrogates for overall survival, which we all want? Data seems to suggest yes, but we will see. This is the very important question, and the following talk will be about this. Can any of these be used for guiding adjuvant treatment? Because maybe not all patients will need adjuvant treatment after neoadjuvant and surgery. What we need to do is standardize the definitions of these early endpoints so there is no difference between clinical trials, and definitely we need longer follow-up in order to establish surrogacy. And I'm very much looking forward to the discussion of this and to hearing your thoughts. So thank you.
We are going further to the lecture of Professor Popat about the decision-making process in early stage non-oncogene addicted non-small cell lung cancer, neoadjuvant versus perioperative. Very interesting task for you, Professor.
Thank you very much. Thank you for the superb invitation. And we've got lots of questions in this field. We've got many, many different questions. I'm not sure I have many answers, to be completely honest with you, but we can place all these data sets in clinical context and then have a discussion afterwards. So these are the disclosures. So we've heard previously about how perioperative treatments in the chemotherapy era have at least given us the same survival outcomes. And I think the Spanish lung cancer group trial of pre versus post-operative chemotherapy is very important because it actually benchmark what standards we should be expecting. It's actually benchmarked that the path-CR rate with chemotherapy is 10%, that if you randomize your patient to neoadjuvant treatment, that 97% of your patients will actually get it, as opposed to 66% of your patients having any form of adjuvant therapy. And we see deaths in each arm that occurs, but importantly, that 9% of patients in the neoadjuvant arm do not get surgery, and 4% of patients in the adjuvant arm do not get surgery. So these are meaningful benchmarks that we have to interpret. And over the recent years, we've had the chemotherapy era. In the more modern era, we now have the checkpoint inhibitor therapy area and actually the targeted therapy area. The most important outcome for all of this is that all patients now must get some form of genotyping at diagnosis. You can argue about the squames, but certainly in the non-squames, genotyping is fundamental and mandatory to make decisions. The big question is really, do we give a neoadjuvant approach, do we give an adjuvant approach, or do we give both? And which do we use in which scenario? So there are pros and cons in this scenario. So with the neoadjuvant approach, you actually get to test whether your systemic therapy or SACT is actually effective. And in many studies have shown that it's more tolerable pre-surgery. You're more likely to get your systemic therapy, as our Spanish colleagues have demonstrated. It gets on top of your micrometastatic disease much earlier. You perhaps need less chemotherapy. You can argue about the immunotherapy component, but it does risk not proceeding to surgery, which is by far the most important outcome for these patients. Adjuvant approach, well, our patients love it because they want surgery ASAP, right? Our surgeons love it, they want surgery ASAP, right? So that's great, that's fantastic. but we don't really know whether the drugs are going to work. You probably need to give drugs for longer, and there are poorer uptake of chemotherapy-based regimes. And if your systemic strategy is based around chemotherapy, then you might be in a bit of trouble. Perhaps we should think about merging all these approaches and have the sandwich approach, the perioperative approach, have the best of both worlds, test your systemic chemotherapy, get your immunotherapy in, manage your micrometastatic disease, but we don't really know who needs the adjuvant component, and you still have the risk of not proceeding to surgery. So which is better? Is it adjuvant? Is it neoadjuvant? Is it all three of them, all two of them? Which is the right approach? You've seen this slide before, and I think it's one of the most critical biological slides that we have, because it does demonstrate that in the bottom panel, if you have the neoadjuvant approach with neoadjuvant immunotherapy, you do activate a broader repertoire of T cells. And the broader repertoire of T cells that we activate, the greater the duration of activation of these T cells are, and they imprimed in the T cell memory. So therefore, they're always available for tumor micrometastases should the patients microscopically relapse. And in the adjuvant setting, because the tumor's out before they get checkpoint inhibitor exposure, we do have a lower amount of autoreactive T cells that are produced. We actually have preclinical evidence to suggest that the neoadjuvant approach is perhaps the better approach. This is a mouse model in a triple-negative breast cancer xenograft, and these mice, I should say, underwent surgery, and they were randomized to have preoperative immunotherapy or postoperative immunotherapy. Compared to the left-hand line, which is the mice that got no immunotherapy, the adjuvant therapy in green does a little bit better, but the mice that had the preoperative neoadjuvant immunotherapy do even better, suggesting that the preclinical data that we had identified is actually clinically meaningful when at least it comes to mice. Now, we've heard from Yelena and others that the area of residual viable tumor is also really critically important. And so perhaps we need to start thinking broadly about how we actually maximize the area of residual viable tumor to try and get the best outcomes for our patients. And of course, if we look in melanoma, my melanoma colleagues in the clinic next door, and I often think that whatever happens in melanoma comes to lung cancer a few years later. And already we know in melanoma we have a randomized trial of operable melanoma randomized to preoperative pembrolizumab or postoperative pembrolizumab. You can argue whether pembrolizumab is the right drug or not in this situation, but at least it's the same drug in both arms, and it clearly demonstrates a huge improvement in event-free survival, suggesting that early adoption of checkpoint inhibitors for T-cell priming is critical for immune surveillance. Well, where are we in lung cancer? So we have the adjuvant immunotherapy studies, and we have all these different adjuvant immunotherapy studies, which are the large randomized phase 3 studies, of which we've heard of three of them so far, 2 of which are positive and 1 of which is negative. And if we look at them in a bit of detail, we have IMpower 10, which was the first one to be presented. Actually, it was mainly a stage 3 study. And in the hierarchical statistical analysis, we do have a DFS benefit limited to the 2 to 3A population. But actually, when you look at it in a bit more detail, what we find is that the benefit is driven by the TPS more than 50%. And really, that is the group that benefits. And if we look up the overall survival outcomes, we see in the left-hand panel that the survival advantage is driven by the TPS more than 50%. 1 to 49% really has no real difference in survival advantage. And the bit that they didn't show you in the presentation, and you have to look in the paper to find out, is the right-hand panel, which is the PD-L1 negative with evidence of harm, inferior survival in patients that are PD-L1 negative. US has approved this at more than 1% TPS, and Europe have approved it at more than 50% TPS. And if you want to join into this ESMO Virtual Journal Club, it's online. We discuss this paper in a lot of detail. Now, in terms of the 5-year overall survival, this trial has just validated what it's demonstrated in terms of the 3-year DFS and OS benefit, which is essentially it's driven mainly by the TPS more than 50%. So for me, TPS more than 50% is really where the evidence base is, and not really in less than that. We do have the rather confusing Pearls Keynote 091 trial, which randomized patients with optional chemotherapy to pembro or not and the adjuvant setting. And in the overall population, there was a DFS benefit, a small but important DFS benefit. And in the more than 50% population, there wasn't, probably driven by overperformance of the control arm. But the problem with this is that it means that the subsets that we then come to look at become even more complicated to interpret, because if we can't interpret the subset which is meant to perform, how can we interpret the other subsets which are more exploratory in nature? Nevertheless, Europe have approved this regime in all patients that require chemotherapy post-operatively. We recently heard the BR31 trial outcome with no advantage at all in terms of disease-free survival for durvalumab, and again, putative overperformance of the control arm. So where does this leave us with the adjuvant strategy? Well, we know for atezo that there's a benefit in the more than 50%. We know in pembro we can't really tell which subset's driving the benefit. We have an approval in all patients. With durvalumab, we have no benefit. Nivo, we have an ongoing randomized phase 3 trial. I'm surprised we haven't heard the trial data as yet, because this trial has been going on for a long time. And with all of these trials, adjuvant chemotherapy is mandatory. But of course, we have a large, significant population that are not suitable or fit for adjuvant chemotherapy. So what do we do with that population? ETOP has a trial coming for this population. So if you're a trialist, do contact the ETOP group about this trial in patients unsuitable for chemotherapy. And what about those patients with PD-L1 0 to 49%? Well, they might have been suitable for preoperative, where you would be considering IO. So this means that the preoperative decision-making for pathological staging and your decision to operate or not is really important and driven, I think, by your PD-L1 status as well. The ISLC have a consensus document, and in the consensus document they summarize PD-L1 negative, discourage adjuvant chemotherapy, 1 to 49 consider. I would say I don't think it's particularly useful, and more than 50% recommended. Now, in the neoadjuvant approach, we started off with data on 2 doses of neoadjuvant nivolumab from the Hopkins group, demonstrating 2 things. Number one, all you need is 2 doses for a pathological response. And the second thing is that radiology and pathology are totally dissociated. So it doesn't really matter what your scan shows, just go and operate, because you may actually have a pretty good response. We actually had the 5-year survival outcomes of that trial, and in the blue swimmers lane are the patients that had a major pathological response, and all but one of those were alive at 5 years. And this is a mainly stage 3 population, demonstrating with only 2 cycles of neoadjuvant IO, you have a very strong effect. We've heard from our colleagues about screening, and of course we're now inundated with stage 1 cancers from screening, which is fantastic. But should we be thinking about checkpoint inhibitors for this group of patients? Our Japanese colleagues have already done a trial in high-risk stage 1, which was presented at ESMO, with 3 doses of 2-weekly nivolumab, demonstrating a reasonable path-CR rate of 25%, which is, you know, a very appreciable path-CR rate. So I think we need to start thinking about these stage 1A tumours as well, which we're seeing more and more of. Prior to the chemo-IO era, we had a lot of IO trials, and what that demonstrated to us is that the path-CR rate is about 10%, so, you know, a bit better than chemo, but not as high as we need. So it's really when our Spanish lung cancer group colleagues presented this trial, Nadim-1, that we really identified the path-CR rate of 63%, and this is with preoperative chemo and nivolumab in an N2 positive stage 3 population. Dr. Prevencio recently presented the 5-year survival outcomes for this group, and I never thought I'd see a 65% progression-free survival rate at 5 years, which is the most mature data set we have with preoperative chemo-IO in this population, telling us where we're going to go with the commercial phase 3 trials. Now, when we look at our commercial phase 3 trials, we have multiple commercial phase 3 trials, and 5 of them have read out, and 5 of them have been positive for their early endpoints. And the early endpoints are a conglomerate of either PathCR or event-free survival. So which of these do we use and how do we decide? So when we quickly look at these, we have the only trial which has looked at the chemo IO neoadjuvant only, which is CheckMate 816, demonstrated 25% PathCR rate, very appreciable event-free survival. We already have 3-year survival data on this. This is one of the most mature commercial phase 3 trials, but we do not have a statistical significant overall survival advantage as yet, and it's unclear whether we actually will. Is that important? That's something we can debate. The neoadjuvant and adjuvant nivolumab trial, CheckMate 770, very similar event-free survival, perhaps slightly stronger event-free survival for the perioperative approach, and you've seen the benefit from PathCR and non-PathCR. Keynote 671, very similar data for the perioperative approach. But again, this is the only trial that actually has a statistically significant survival advantage. None of the others do as yet. Is that important? Perhaps we can discuss. Aegean with durvalumab, again, we have an event-free survival advantage. We have very early overall survival data. It doesn't really look like it's tracking to become statistically significant, I have to say. And we have 2 Asian data sets, a toripalimab data set and a additional data set, the Rational 315 data set. With tislelizumab, again, very similar data. So where does this leave us? Patients that need surgery have adjuvant chemotherapy. We can have adjuvant immunotherapy for a year. We have a variety of data sets, a variety of TPS telling us what we can potentially do from a regulatory status. We may just think about 3 cycles of neoadjuvant chemoimmunotherapy, which I personally think is entirely reasonable. And we can see the approvals and the TPS strata that we have here. Or you might decide that your patient's going to go all in, and we have 3 trials supporting that approach and the associated regulatory standards and hazard ratios that we can see. If we look at the hazard ratios, which I think are a reasonable way forward, actually the hazard ratios for the perioperative approach are slightly fractionally better than just the neoadjuvant approach, and that is about the only real hard data that we have. So what do the ISLC say about this? Well, we have the ISLC consensus recommendation, and they say certainly for stage 3, recommendation number 7, neoadjuvant is the way to go. And that is definitely the way forward, regardless of PD-L1 level. In stage 2, things become more complex, and the consensus among experts leans towards neoadjuvant, but the consensus amongst the open group that this was sent out to is sitting on the fence. 50% think straight to surgery, 50% say neoadjuvant approach. So how should we be thinking about this? Well, we need to think about our patients a little bit better. So our stage 3 disease isn't a homogeneous disease. It's a wide distribution of different types of disease, perhaps like the different fruit that we have and vegetables in our market. So should we be thinking about these slightly differently? Do we manage a T4N1 with TPS 10% that may need a pneumonectomy differently to how we manage a N2-3A PD-L1 100%, differently to a never smoker who's 3A? Probably we manage these very differently. So should a node-negative tumour undergo neoadjuvant? Well, you can think about whether they should or not on their a priori benefits that they might get from checkpoint inhibitors, but we have to think about the probability of them getting to surgery in the first place. If we look at the probability of patients getting to surgery in each of these trials, we can see that in the inductions trials, the probability of getting to surgery is 80%. I can guarantee in the real world that's going to go down. Certainly our experience is we've been upset by a few patients that haven't made it to surgery in our world. How do we predict PathCR? I mean, PathCR is really what we're aiming at, but I always get a bit upset when the surgeons take out a PathCR because I think, well, why do you undergo surgery in the first place? You've undergone what I would call a futile thoracotomy. So how do we predict which patients get PathCR? Even in the PD-L1 negative population, 15% of patients are getting a PathCR. So for me, PD-L1 negativity is not an exclusion for the neoadjuvant approach. I'm not sure we can easily predict PathCR at this stage. Who needs adjuvant after neoadjuvant? Is 3 cycles enough? If you're a nivolumab believer, you have the choice of 4 cycles or 3 cycles, depending on which regime you want to use. Certainly, we've seen a very adequate approach after 3 cycles. Is that extra 1 cycle really giving anything? Who needs adjuvant if you've had a PathCR? And if you've had a non-PathCR, does the adjuvant really help? If you've had a non-PathCR and your residual viable tumour is 5%, that's one question. If your residual viable tumour is 95%, that's a separate question. We don't really know. We can talk about ctDNA. I'm not sure that ctDNA actually helps in this situation. Where are we going with all of this? Clearly, the duration and the depth of pathological response matters, as we've seen in melanoma. So how do we predict and increase the PathCR rate? Do we need to start giving radiation alongside? We have a SABRE trial data set which suggested it might do so, but the overall survival actually wasn't improved. In rectal cancer, our Dutch colleagues have been selecting their patients. This is the famous Chalabi plot. So we've achieved this in rectal cancer by super selecting the patients most likely to benefit from the neoadjuvant approach with MMR deficiency. Can you do that in lung cancer? Well, MMR doesn't really exist. It's super rare in adenos. At the very least, you might think about the PD-L1 status. So in the metastatic setting, we know the extent in smokers of PD-L1 sensitivity can impact, and maybe that's one way we can do it. Maybe we need to add more drugs. So if we look at our German colleagues, they've been adding relatlimab in addition to nivolumab. This is their NeoPredict trial. They do have perhaps a slightly increased PathCR rate with the addition of relatlimab, but this is at a lower dose. I'm not sure it really is a big improvement. And at World Lung, we had the addition of ivonescimab. Ivonescimab is the big new disruptor in checkpoint inhibition, demonstrating a slightly increased PathCR rate for a combination of ivonescimab. So ivonescimab use versus not. And we need to see how this pans out in the current ongoing trials that are ongoing. AstraZeneca have their NeoCOAST platform where they're evaluating a variety of different checkpoint inhibitors together with Dato-DXd. And if you look at the PathCR rate for oleclumab, monalizumab, and Dato-DXd clearly has the greatest PathCR rate, 34%, compared to about 25%, which was what they're going. So do we need to add more chemo to our neoadjuvant approach rather than changing the checkpoint inhibitor? I don't know. We'll need to see how that goes. One thing is for certain, the FDA have got very strong views on this. So if you're bored, you can dial into YouTube and look at the ODAC review of Aegean. It's a very interesting half an hour to an hour of your time, but I've summarized it for you to save you not getting bored. They decided to approve Aegean, which is important, but they actually said the design of all these studies that we have are rubbish, and they will not accept new studies which do not separate the neoadjuvant and the adjuvant components moving forward, which is a huge relief to all of us in clinical practice, because they're getting inundated with trial designs, adding new agents in across the shop. So what they have said is that they will only now accept a 4-arm trial design on the left or a 3-arm trial design on the right, which is going to be then testing whether your new agent is going to be working, because that helps to separate really what is benefiting the patients, the neoadjuvant strategy, the adjuvant strategy, or the perioperative strategy with the control arm of the perioperative regime, which the FDA would regard as standard, and that was passed unanimously. So I'm going to close and say that adjuvant is a standard for non-small cell lung cancer, but I would say perhaps only at the TPS more than 50%. Neoadjuvant is certainly an extremely good approach, but there are real issues about patient selection in that we don't really know who needs the perioperative approach or not. How do you identify patients for each strategy is an ongoing problem, and add-on therapy trials are all coming around the corner, and they're going to be bigger trials, so industry are going to have to be very strong supporters of that for a strong effect, given the size and cost of that trial coming through. And with that, I'd like to thank you for your attention.
Thank you. Thank you very much for the excellent talk. And now we are moving to the last presentation before the discussion and before the coffee break, right? Bojan Zarić will talk about a stage 3 disease beyond Pacific. So we are moving to inoperable stage 3, actually, right? When?
Thank you very much. I'm going to tackle the stage 3, which was a huge problem before the Pacific tsunami. And after the Pacific tsunami, the stage 3 became even a greater problem. So Davorin, thank you for giving me this topic. So these are my disclosures, and this is actually how the geostrategical situation in the Pacific looks like. There's a lot of a bunch of people beyond the Pacific which are surrounding Pacific because there simply are there, and there's a lot of players which are actually Atlanteans, you know, originating from the Atlantic, like the French, the Brits, the Portuguese, and Dutch, who are still in the Pacific. So at the end of the day, it's going to be my favorite PlayStation 2 game. It's going to be the battle over Pacific, and it's going to be all about the warplanes and the carriers. So what is the problem of the stage 3? It is something what Sanjay beautifully showed with apples and oranges, and it's the huge diversity in the N2. And I do believe that all of these N2 categories are actually distinct diseases, and we should individualize approach to each one of them. And this is the ERTC consensus data, and I really enjoy and adore these pink ones, which are telling potentially resectable. What is potentially resectable? Can we define potentially resectable or not? But the most beautiful one is the unclear, which is the N2 bulky. So it is potentially resectable, potentially unresectable. Is it unclear, or is it clearly unresectable or clearly resectable? And if we put that in the context of the entire TNM9, then the Pacific tsunami moves on and floods almost 2/3 of the TNM classification. So we do not have a problem with the low stages or with the metastatic stage. We are stuck on the stage 3, A, B, C, N2A, N2B. So the Europeans are quite simple and quite clear. So the Europeans will simply tell us you have an unresectable stage 3, but hell, we have a potentially resectable and unclear also. So, okay, we know what's going on with the unresectable. So we'll have chemo-radio, either sequential or concurrent. We'll have no progression or stable disease, and we'll go to durvalumab. And then we have the Americans with the ASCO guidelines, which are diving deeper into the details. I will not for the sake of time, but basically saying and giving us the same message and giving us the same proposal what to do. But here's the problem. Because everything under the red line is flooded with the Pacific, and everything above the red line is already told and spoke about by Sanjay. So I'll not go in the upper part, but in the lower part, as you can see. So the 3B here, also the part of the 3A, which is not medically fit, concurrent chemo-radio, Pacific. Then we have a stage 3B, which is, exceptionally, I also have to go down because I cannot see there. So if we are taking into consideration what's going on here, the guys are telling us pathologically confirmed, ipsilateral or contralateral mediastinal lymph nodes. That means that your lung cancer unit needs to have an EBUS and needs to spend at least 1.5 hours for sampling both sides of positions 2, 4, 7 at least, and then have a ROSE, and then have a rapid answer what's going on. So that's only few of us who can actually handle it, and then it's too expensive when I'm trying to do it. My hospital administration is probably going to kill me after 7 patients, and I'm not going to be working there anymore. So forget about it. Forget about the evaluation of surgical candidacy. Then again, we gotta have a very, very strong multidisciplinary tumor board with the knowledge of everything what is in the stage 3, and with the fight to the Pacific, or not fight, just swimming on the tsunami of the Pacific. And just to remind you, so after the concurrent chemoradiotherapy, and within the 1 to 42 days, and with a dose of 60 to 66 grays, you can go with the durvalumab mono or placebo, and this was one of the greatest trials of our time, actually giving us an answer to at least one slight portion of the stage 3 in which we know what to do, because the hazard ratio 0.61, meaning the 40% decrease in the overall survival probability, is something what is the cause of the tsunami. And I don't believe that any of the warplanes coming in the area of the Pacific will be actually able to reach this. Why? Because the situation is getting too much complicated. Are we making it complicated? Yes. Because if we look the further avenues, besides the consolidation, so concurrent chemoradiotherapy followed by immunotherapy, now we have sequential chemotherapy, radiotherapy, immunotherapy, and that's gemstones. The red ones I will try to show you quite shortly for the sake of time. Then there is immunotherapy consolidation intensification. Oh my goodness gracious, great balls of fire. What does it mean? So that's concurrent chemoradiotherapy followed by IO-IO combination. Come on, people, is that even survivable at the end of the day? We can get good results, but so there's Pacifics 9 and 8, and AstraZeneca is probably going to make Pacific 22 in a distant future. But there's a skyscraper coming by with a tiragolumab, with an anti-TIGIT guys playing in, I will show them. Then there is concurrent immuno with a concurrent chemoradiotherapy. So immunotherapy, chemotherapy, radiotherapy, followed by immunotherapy. Wow. So the Keynote 799, I will show it to you, deterred Nicholas, Pacific 2 again, induction chemo, followed by the immuno, so chemo, immuno, followed by chemo radio, followed by immuno, and look at the last one, I cannot even go through it. Of course, the special populations are also at stake. What to do with the ECOG performance status 2 patients? Will we just simply leave them down the road, or will we stuck, because we're here for the patients and for the ultimate survival of those patients, not giving a lot of and more drugs? So these are the players, you know, surrounding the Pacific and entering the Pacific, including the Atlanteans. Only it's not the Atlanteans, it's mostly Chinese. So it's durvalumab, pembro, nivo, atezo, sugemalimab, which are PD-PD-L1. There is monalizumab, beautiful name. The NK cells actually catching the NKG2A. There is also tiragolumab, our old player. We know about skyscraper programs. We know how they crumbled down and how they're waking up again. So that's an anti-TIGIT. Ipilimumab, an old friend for the CTLA-4. Oleclumab, which is actually anti-CD73 antibody. Senakinumab, anti-interleukin-1. So all of them can be theoretically combined with all of the other immunotherapeutics with chemo or chemoradiotherapy. But what's the point? Will they end up in actually improving the overall survival or at least the PFS of the patients? So this is what's going on. The fancy names from the breast cancers are actually entering the area of the lung cancer. So we have an induction and we have maintenance therapy, which will cool differently. So look at where we are. So this is the last combination you saw on one of the previous slides, which combines everything to everything. But there are additional inclusion criteria, and the readouts, the end of active treatment and start of follow-up, are coming in a year, in 15 months, in Pacific that was in 18 months, and so on, so on. So there is a lot of apples and oranges here. Can we really draw any true conclusion? And this is a crowded slide, but it was my favorite slide when I was making them. So consolidation immunotherapy after concurrent or sequential radiotherapy. There's Pacific, the first one. There's specific real-world data which confirms. There's pembrolizumab, sugemalimab, and durvalumab in Pacific 6. And the only hazard ratio for now we have is for the Gemstone 301. It's 0.64, very close to 0.61 in the general readout of durvalumab. So that's the real player which might be considered as the threat to the Pacific tsunami and getting it somewhere else. But look at the phases. It's mainly phases 2. These are not the phases 3, so we are drawing the conclusions from the phase 2 trials. And we did it many times, and we did it wrong many times. We did it with sotorasib in KRAS G12C. So after some time we saw that it's simply not good. We did it with mobocertinib, with exon 20 insertion. And after we get it approval from the FDA, then we said, oh gosh, that's not working, so let's pull it back. So let's not rush into the phase 2 trials. But what I want also point out, look at the durations. 1 year, 2 years, 6 months. It's the same situation we got in the neoadjuvant and adjuvant therapy 25 years ago, when we have different chemo protocols, different radiotherapy protocols, everything different. And when we get at the end of the day LACE analysis, the LACE analysis said, gosh, it's only 5% influence on the overall survival at the end of the day. So I'm afraid, and I wouldn't like these trials to go in that direction. So consolidation, intensification, these are phase 3. We are waiting for the readouts. We have the interim analysis, we have the press releases, but let's not catch on the press releases of the companies and interim analysis results. That's not a good thing to do. So PACIFIC-8, which will actually give durvalumab, domvanalimab, in combination against, look at the control arms. Control arms in all 4 are PACIFIC arms. So everybody's competing against PACIFIC. There's a Roche project that's Skyscrapers with durvalumab, which is actually also targeting anti-TIGIT. There's PACIFIC-9, very, very ambitious project by AstraZeneca. So it's durvalumab and oleclumab. It's durvalumab, monalizumab, again against PACIFIC. And the Nivo is our old friend, you know, going to the arm A, arm B, arm C. And I was looking at the YouTube lecture, and it was very interesting. A lot of things to learn also in regard to that, because the concept is pretty much the same. Do we have a preliminary results? We do. And if we take the Keynote 799, which is concurrent immunotherapy with concurrent chemoradiotherapy consolidation, so you see how it goes. And then there is something quite strange in the design. So the cohort A says squamous and non-squamous and gives pembro, pacli, carbo, then combines it all with the radiotherapy. Really? Non-squamous without pemetrexed, the backbone, and the one arm? Well, okay. And then goes the adenos, the non-squamous, fancy said, and the same, but the PEM is there. So it's going to be interesting to see the real difference between the cohorts A and B. For now, at the cutoff of 12 months, there's no huge difference, but we know that we have a 5-year survival of durvalumab. I'm not quite interested, except for seeing the signal at 1 year, but I want to see it longer. I want to see 2 years. And then look at the toxicities. They're down here. I don't know how you can actually see it, but cohort A, grade 3 to 5, 64%. Cohort B, 50%. Toxicities grade 3 and more. So these are the high toxicities. And killing O12, the Pembro try. The Pembro matching olaparib placebo for 12 months, the Pembro plus olaparib and PACIFIC arm. And again, the KeyVibe 006, a very clever one, vibostolimab, pembrolizumab fixed combination. So anti-TIGIT, anti-PD-L1 fixed. So it's a nice try, especially if they make it subcutaneous. It's going to be quite cozy. But again, 3 cycles, why? 12 months, why? So I have much more questions than I have the real answers, except the one I know what is with the PACIFIC. What is beyond PACIFIC? I am not quite sure. Why did PACIFIC-2 fail? Nobody knows, because we do not have the biologics in their true sense. Only thing we know is that it did not achieve statistical significance. Was it because of a different patient population, or detrimental effect of durvalumab concurrently with the radiotherapy. Because what we know is that when we are giving immunoconcurrently with radio, the radiotherapy will simply blast the T cells. We will lose the T cells. We will lose the soldiers which need to be armed. And we are giving the immunotherapy which is arming something what we already lost. So I'm not sure is the concept quite okay. And the Pacific 6, and I tried to pull out the frail patients. This is actually the slide of Jelena Spasic. So I took it from one of her former presentations, but this cohort has 3 patients. Is there any conclusion except the adverse events, which are actually very, very high and very different? So I'm short. These are my key messages. The Pacific definitely paved the way for the stage 3 immunotherapy, and it's going to stay there quite long. Before we change any current clinical practice, we need to have mature phase 3 trial results. Only then we can make decisions. The current duration of 1 year of consolidation after anything concurrent is debatable. Is there a biological rationale? I'm wondering to see nivolumab 6 months and 24 months pembrolizumab trials. I really want to see them, because only then I will know how long will I treat the patient. Maybe 1 cycle is enough. The half-life of pembro with the T cell connected is 260 days. So maybe just 1 is okay. What about the radiological tools? Do we really have the true radiological tools to differentiate what is immune-related and what is radiotherapy-related pneumonitis? No. We need radiomics. We need radiation oncologists in the team thinking with us all of the time and making new biomarkers. The huge limitation of all of these trials is the fact that they're not biomarker-driven, and they cannot be, but they really should be. We should be working on those biomarkers to find them. Resectability, it doesn't take into account anything about the biological characteristics of the tumors. Is really, we are now talking that adenocarcinoma with a certain mutations is a completely different disease, EGFR from the non-oncogene driven. Come on, this is also apples and oranges. And we need to identify the subsets of patients to whom we're going to give the therapy. So I really believe the Pacific will stay a beautiful place to take vacation in, and that for a quite long time we would be wanting to stay on the Pacific. Thank you.
Thank you, Professor Zaric. Voltaire once said that it's not so dangerous to be ill, but to be treated. It's much more dangerous. Everything now seems very complicated, but I kindly ask our panelists to make this situation much smoother and much clinically usable. Please, Professor Popat, and also Rafal, Igor, please, Jelena, Bojan, si tu? Tu, da. Malo smo, možeš, malo smo sparsi sa stolicama, da. Oh. So,
musical chairs, one chair is missing.
the master is missing. I have no clue except to speak about real-world data, because if we stand on clinical data, Sanjeev, very elegant, passed by, so British, so but clear. But could we use real-world data to have some practical conclusion for young doctors, for experts, for industry? Yes.
Yeah, I think real-world data is really important. Actually, we don't have a huge amount of it at this stage, which is the big challenge. But one of the issues is we're never going to get a lot of the granularity that we need from the trials because the trials just didn't capture a lot of this data in their trial databases. Because of course when the trials were being set up, and if you're setting up the trial database, you don't necessarily capture a lot of the fields that we necessarily need to know, like the extent of nodal involvement, the comorbidities that the patients have, the TLCO that the patient has. So, for example, in the 10 to 15% of patients that never make surgery in the neoadjuvant trials, the trials cannot tell us why, because none of that was actually captured. So what we really need is some good quality real-world data from each of our institutions on exactly these granular details in patients that are undergoing neoadjuvant and their outcomes to help us really work out which patients aren't getting to surgery, which patients are bad selections for the neoadjuvant approach, what is the outcome from the neoadjuvant approach, and then if they have adjuvant, what is the outcome that we have there? Because only in that way will we get some of the granularity that are totally opaque and missing from these trials.
But I suppose that we could easily agree that it's rising number of patients who are going to neoadjuvant treatment. So it will be difficult to find the patients for adjuvant treatment soon.
I disagree. I mean, I think really there are lots of patients who do not want to have neoadjuvant treatment that will demand to have surgery. There are lots of surgeons that do not want their patients to have neoadjuvant treatment who will ensure that that patient gets adjuvant treatment. I think there are still open questions about stage 2 disease in patients that may have comorbidities that may not be a great candidate for neoadjuvant, where adjuvant will still be a very reasonable way forward. And so I think we will have many different standards of care. We will certainly have a neoadjuvant approach for many of our patients, which I think is the correct and right approach for the vast majority of patients. But we will still have lots of patients for whom they end up getting primary surgery for a variety of reasons, and then will end up being candidates for adjuvant. And then we can answer those questions. Where we won't easily be able to answer the question is, can we stop after neoadjuvant, and who do we need to carry on to give the sandwich perioperative adjuvant? And that is the real question that all of us have.
It's unsolved. It's unsolved. Igor, what's the practice in Manchester?
So I think that especially after the adjuvant durvalumab trial, we would push for neoadjuvant or perioperative treatment, because as Sanjay said, we have 3 trials in the adjuvant space. One of them is positive, one of them positive but somewhat confusing, and the other one negative, which was the largest trial. So we push for neoadjuvant actually, Checkmate 816, although we also have the perioperative pembrolizumab regimen at the moment. And
do the 3 cycles enough?
I don't have the answer, but
no one has the answer. But intuitively, we may say yes, I suppose. Rafael?
Yes, so I think I would make a couple of points for neoadjuvant. First of all, I'm also, as Sanjay, believer in the neoadjuvant setting versus adjuvant. The trial results are consistent. It fits very nicely to our hypothesis of primary priming for the biggest problem in these patients, which is systemic relapses. The adjuvant studies are not so consistent with the recent BR31 and with somehow not yet shown data for Nivo, which again, in my mind, warrants some attention. Why? With saying that, from our practical perspective, there are certain critical points to implement this strategy. One is to have complete biomarker testing in patients upon diagnosis. Typically, we didn't do it before. Now we have good reason to do it, but practically it's not so straightforward. Second, when we have the neoadjuvant strategy, this is really a team effort. That means that the surgeons must be very critical in getting only resectable patients to undergo this treatment, especially at the very beginning of the learning curve. So resectability and operability issues upfront. Second, the task for a medical oncologist team is to get the patient safely through the first 3 cycles or 4 cycles, we prefer 3, of neoadjuvant therapy in such a shape to minimize dropout rate for surgeon. And this is my task as medical clinical oncologist on stage, to present the patient as fit as possible with CT scans to thoracic surgeons on MDT before surgery. And the third, the task for surgeon, is to make sure that the operation is done according to the plans. There are, of course, some issues about higher rates of problems for neoadjuvant treated patients than upfront treatments, but these are minor according to our surgeon's perspective. But we need to specify how to really technically approach this neoadjuvant setting to learn as much as possible from the current stage of development.
There's only one short comment.
Yeah.
The real question is how far can a patient in neoadjuvant setting get to surgery? And Sanjay had a very good slide about it. So because of the mobilization of the T cells and everything else. But the real answer will be only derived from the real-world data, actually not from a real-world data, from the investigator-initiated trials. We need to figure out that all of us need to be united and then to really pressurize the industry to give us the drugs and to make a true investigator-initiated trials and to answer 1 cycle, 2 cycles, 5 cycles, 3 cycles. We will have to do the answer.
But operations are every day, even now and tomorrow, so we need some guideline. Maybe, how convincing are the data about new endpoints? Briefly.
They seem to suggest that new endpoints work, but then another, Rafael was saying, we have this and this and this problem, and then there is another problem of adequate pathology, because pathology's job is getting more complicated than it was before, and the pathologists also have to follow certain very specific guidelines. And it is a learning curve also because it's not the same neoadjuvant chemo, IO. So that's another thing. And also, will the pathological endpoints guide us in further treatment, whether all the patients, because I'm always thinking, if you've given neoadjuvant treatment and there is no or very limited pathological response, is there a point in giving the same treatment in the adjuvant setting? I think that's one of the...
Only for the next step for today, huh?
Yeah, just a few comments on everything that we've said. So personally, I think 3 cycles is entirely adequate. I'm not sure that a 4th cycle of preoperative adds a huge amount, but we have to go according to the regimes that we have. As Rafael had said, setting up a neoadjuvant program is really difficult actually, because we have lots of different moving concepts we have to get right. We have to get the medical oncology right, we have to get the radiology right, we have to get the surgery right, we have to start on the straightforward cases, we have to get a few people through the cases. Our pathologists need a lot of education. The cut-up for a neoadjuvant case is totally different for a neoadjuvant chemo IO. Not everybody is using the standardized ISLC pathology station. The definition of residual viable disease is totally different across all of the different trials, whether you measure the primary tumor and the lymph nodes, both or only the primary tumor. For me, the only viable endpoint here is PathCR, because all of the other metrics are so subject to bias. Even PathCR is subject to bias. Yeah. So we have to be very, very careful in, if I have a patient and my pathologist says it's a PathCR and I have the option of IO and I decide whether to use it or not, do I really believe, number one, the surgeon's cut everything out? Number two, the pathologist has sampled everything properly? And number three, they've really called it a PathCR?
Yeah, the strength of, if we have any strength, we have a nice organized multidisciplinary tumor board in tertiary institutions, as all tertiary institutions have their own pathology and their own surgeons under one roof. So it is advantage. Yes, please.
So in Manchester, apart from having a joint clinic with radiologists, surgeons, we also have a rehabilitation program. So patients eligible for neoadjuvant treatment immediately start that rehabilitation program, which is basically exercise, and we find that quite helpful to make the patients fitter for surgery. So I think that's important.
That's important, huh?
Time.
One
question.
burning, ona goruća, jako goruća vatre koje se rasponsavaju. Đorđević.
Okay, ladies first.
Ladies first.
Okay, I can speak loudly.
Yeah.
As we got a GN approach in a patient program in Slovenia, we're now facing patients who have tumors like 5 centimeters, PD-L1 0 or positive, and we have an issue what to do with them. Before, when we had like neoadjuvant approach, only checkmates, you needed to have a tumor larger than 5 centimeters and PD-L1 %. But now there are much more patients eligible for neoadjuvant, for perioperative approaches. So what is your clinical decision in your clinical practice? What do you do with those patients? Offer surgery first or go to perioperative approach? Thank you.
I mean, for me, I'm a real believer in the neoadjuvant approach, even for PD-L1 negative patients. You know, there's a 15% chance of path-CR if you get them the right. And of course, if they're a never smoking PD-L1 negative patient, that's a slightly different biological type. But assuming it's a smoking PD-L1 negative patient, I would definitely offer them a neoadjuvant approach. And then post-operatively, you can decide whether you want to carry on with more immunotherapy thereafter, depending on the magnitude of benefit. But, you know, as Rafael has said, the effect size that we've seen with the adjuvant studies has been a bit, I would say, disappointing to me compared to the huge benefits we've seen with neoadjuvant. So for me, neoadjuvant all the time.
Okay, for Professor Rafael, a question. Is there a role for radiotherapy? Because what we saw from the 816, that the concept of relapses was different. It was more locally relapsed disease after that. Again, a role for Dr. Rodriguez, a role of in oncogen addicted, do we have a role for adjuvant or neoadjuvant immunochemio? And again, for Professor Popat, what do you think about chemotherapy? Which is better, carbo or cis? Because it was different in the studies. Thank you.
To answer quickly to question 1A, first, radiotherapy is being studied as an SBRT to primary tumor only, with induction chemo immunotherapy. Data from phase 2 study from China are available in Lancet Respiratory Medicine. Phase 3 has been started to optimize local control and to boost the immune system. Whether that will work or not, we shall see. Probably immunotherapy only for neoadjuvant setting with SBRT is not a way to go. Secondly, for those patients who have residual disease post-surgery and post-induction treatment, we need to consider radiotherapy for R1, R2 resections, which happen especially if the patients are too advanced and included in this protocol, despite the clear recommendation to have only resectable patients. Now, this is the trend among surgeons, how to make unresectable resectable. I don't think we are there yet.
What was the question for Professor Popat?
Yes. So short answer, immunotherapy is not effective in oncogen-addicted disease, but a long answer, it's not the same a KRAS-mutated patient than an EGFR, ALK, ROS1 patient. So we should get those results up front so we can make the right decision, but we know that the response rate to immunotherapy when it comes to ALK-positive patients, for instance, is about 0%. So it doesn't make any sense to add immunotherapy in those cases.
And cisplatin, carboplatin, yes. We use carboplatin. We've almost deleted cisplatin from our radical paradigm many years ago.
Thoracic oncology lovers and coffee lovers, the floor is yours. Sorry, we are late, but it was live discussion, so it
Mislim da otvoriš i ja...
Marka i Uršku, ti mene javljaš Uršku, a posle ti ova 3.
Lahko, može tako.
I think maybe we should go on. It's 11 o'clock, so we're right on time. We are on time. So welcome back. I hope you had a nice coffee break. So now we're moving on, Marco. Now we're moving on to a completely different disease, as we kept on saying. So we're moving on to oncogen-addicted non-small cell lung cancer. And Marko Jakopovic is going to give us a little bit of an introduction into the standard of care.
Coffee is important than science. It's usually like that, right? So I will try to, in the next 10 minutes, just give a brief introduction, because I can speak about this like for, I don't know, half an hour. These are my disclosures. I will first talk about EGFR pathway, which is really important. I won't talk about it much, but what we must know, that there are common mutations and there are uncommon mutations. They're completely different. And then this is the learning curve. We realized, this is what, 20 years now, when Lynch and guys discovered that EGFR mutations are patients with EGFR tumor cells with EGFR mutations are much more prone to respond to EGFR TKIs. And then nothing really actually happened for a couple of years. Then we realized that there are, besides these common and uncommon mutations, with development of diagnostics, NGS and everything, we have a bunch of rare mutations, and then the first of the rare mutations was T7ITM, which was discovered as an acquired resistance mechanism, the most common one to EGFR TKI, which were administered in the first line. And what was lucky for the company, the AstraZeneca, they did a trial which is called IPAS, and then they knew about the EGFR mutations, but they didn't study prospectively with EGFR mutations, but luckily they did a trial in East Asia, and they included the females with adenocarcinoma, which are never smokers, and then suddenly they have a huge number of EGFR mutations, and then in exploratory analysis, the study was actually negative. Gefitinib versus chemotherapy in unselected population in first line was negative. But in exploratory analysis, retrospectively, they found out that EGFR mutations patients are much prone to respond to EGFR TKIs, and that's the beginning of, I would say, precision medicine in lung cancer with EGFR mutations. Now we have much more of those mutations. This is the NCCN guidelines, which are much quicker than ESMO guidelines, but nevertheless, there are few drugs which are recommended nowadays. The story started with the FLORA trial with osimertinib, which is excellent thing because osimertinib was compared to EGFR TKIs, not like gefitinib, afatinib, and erlotinib with the chemotherapy. So this is significant improvement in progression-free survival. But what was seen for the first time is that the overall survival benefit was seen in a patient treated with EGFR TKIs, comparing to EGFR TKIs with first and second generation. In this trial, only first generation. And that was the biggest complaint of the concern of this trial, that only erlotinib and gefitinib weren't compared, not afatinib back then, but nevertheless, standard of care in the last couple of years is osimertinib in that group of patients. But then, recently, addition of chemotherapy to osimertinib improved further progression-free survival. 20 years ago, when we used EGFR TKIs with chemotherapy in unselected population, there was no benefit, there was even harm, and then we said that targeted agents cannot be combined with the chemotherapy, and then suddenly changed everything, the FLORA-2 trial, so we have a combination of OSI plus chemotherapy with improvement in PFS compared to OSI alone, but at what price? Increased side effects. And then what was recently published is Mariposa trial, again, first-line setting, amivantamab plus lazertinib versus osimertinib. It seems that PFS is on a side of combination therapy compared to osimertinib, but we will see what will happen in the future. So this is the first part of my talk. I will just open some questions of what is the appropriate first-line treatment. If you get a NCCN guidelines, prefer this osimertinib alone, but we have option with the OSI plus chemotherapy, and this amivantamab plus lazertinib is also one of the preferred options. I mean, most preferred is osimertinib, but other options, and then nobody's talking about erlotinib, gefitinib, and the dacomitinib again at all. What should we consider? Only efficacy? Is it PFS or is it OS benefit? Is it safety? Is it treatment application, just the pills, or we have to go with the IV or subcutaneous treatment like amivantamab? And what about the financial toxicity? So what we'll do after progression of first line, if you go with the OC, what we'll do, go in second line? And is there a role of IO in EGFR positive patients? So we'll hopefully hear the answers for these questions in the next presentation. So this is the ALK positive patients. What is the great thing that we discovered? ALK translocation in adenocarcinoma patients, lung adenocarcinoma patients, 2007, and 4 years later we had approved drug which was called crizotinib, which was compared with the chemotherapy, and it was much better with that. But what is the great thing that we have 4% or 5% of patients with adenocarcinoma who are having ALK translocations, at least at the beginning. And then we have already 5 or 6 approved drugs for the treatment of ALK positive patients. This is the retrospective data from the France, and that was before the era of the, lorlatinib, just the three lines of, crizotinib, ceritinib, and other drugs, alectinib, brigatinib, and the patients who received the 3 or more drugs lived almost 10 years, 9 years, whatever. So adenocarcinoma patients who are ALK positive are usually younger, never smokers, females, and then maybe if they received so many drugs, we can prolong their life and turn the lung cancer into chronic disease. So again, this is the NCCN. I'm not talking about the ESMO guidelines. Again, we have 3 preferred drugs. And if you look at the data, you usually have PFS. All of those drugs are extremely effective compared to crizotinib. But there is no head-to-head comparison. If you look at the curves, you see that they're highly separated. Hazard ratios are pretty much similar. What is also really important, extremely well intracranial activity, even the patients with the brain mets at the present, or in preventing the development of brain mets. But what happened is that at this year's ASCO, 5-year follow-up of lorlatinib was presented, and then what you see is that extremely well 5-year survival, even the median PFS, what Bojan hates, was not reached. But if you look at the curve, this is really what is something really important. And then probably, if you look at this PFS, it's much better than the other trials, but it would be great to see head-to-head comparison, which will never be done, probably, at least not from the company's point of view. And then if you look at the brain mets, this is something, it looks like either you have a brain mets at the beginning or you don't have. If you didn't have the brain mets at the beginning, it seems in the 5 years, it's like statistical error to develop brain mets with the lorlatinib. So this is one thing. And then what we are doing with the diagnosis of ALK positive patients is immunohistochemistry or immunocytochemistry in some institutions if you don't have enough tissue. And we thought that's enough, but it's not like that anymore. So we have with the most common translocation, EML4 with the ALK. There are 3 variants which are having different prognosis, different responses to the ALK inhibitors. And what is the other issue is the progression of the disease, and then to have the bunch of secondary mutations who are responsible for resistance. And then we'll probably hear something about that. So the situation is getting really complicated in ALK story. And then how can we choose the first line treatment with the 3 drugs which are preferred according to the guidelines? What should we consider again? Is it PFS, OS? We don't have OS data yet in vast majority of those patients because everybody's getting everything if you're a positive patient. Should we care about the CNS meds? All 3 drugs are effective with the patients with the CMEDs. And what should we do with the progression on each line of treatment? That are the answers, I think, that we all should consider. Thank you very much.
Thank you, Marco. And now we're moving on to new treatment options for advanced EGFR positive non-small cell lung cancer. And I welcome my dear friend and colleague Urška Janžić from Ljubljana to tell us about this.
Thank you for the warm welcome. Thank you for the invitation, putting us on the program. I will talk about some new treatment options for EGFR mutated non-small cell lung cancer, which Marco already showed you a bit, but I'm going to go into a little more details. So here are my disclosures. We know by now that EGFR is not only one disease, that EGFR mutated patients can have a lot of different rearrangements actually, and in this paper in Nature it is wonderfully shown why some drugs work in some settings, in some mutations, and some don't. I will not go into the form of loop or helixes and everything else, but if you read it and see the structures, you can understand. So we will go through common EGFR mutations, which are deletion 19, L858R. And by now, the standard of care, as you saw, is osimertinib first line, which is mostly used in the European Union. By FLAURA trial, which showed not only PFS gain, but also OS gain with a hazard ratio of 0.8 versus other EGFR TKIs, which was also not done before in this extent, and overall survival benefits were not shown. So the question is, can we do even better than FLAURA? And as we know, we try to avoid actually giving chemotherapy to patients that are EGFR or ALK driven, but nevertheless, FLAURA2 came along and it did exactly that. It combined osimertinib with platinum-based chemotherapy in first line versus osimertinib alone. We saw firstly that the tumor response rates were pretty much similar. It was a bit higher numerically in the combination arm, but nevertheless it was around 80%. And then progression-free survival results came, which showed that progression-free survival benefit is quite extensive with hazard ratio of 0.6. So you have about 40% less chance of progressing if you give your patients that are EGFR positive the combination treatment. And on the forest plots, all the dots are actually to the left. So it is across most of the groups of patients. Which was even more surprising was that actually patients with brain metastasis have a lot of benefit combining osimertinib with chemotherapy, which we cannot actually explain quite good at the moment, because what we knew until now was that EGFR TKIs and ALK TKIs have great penetration in the blood through the blood-brain barrier, but we thought for the most of the time that platinum-based chemotherapy does not. This kind of changes the situation, and the question is, are those patients only EGFR common mutation positive, or do they have more aggressive disease? Do they have other commutations? Is something else actually going on? So we'll know that in the future. I do not have a complete answer by now, but just so you know, patients with CNS metastases do have a benefit with combined therapy. So the other trial that was already mentioned is Mariposa, that combined actually amivantamab, which is a dual inhibitor, EGFR and MET, with lazertinib, of course with the idea of, again, prolonging PFS and also OS because of this dual inhibition, because many patients actually develop resistant mutations that are MET or EGFR based after progression on first-line TKI, and in this Chrysalis study, responses were quite durable. The 20 patients involved all had response, and the responses were mainly quite durable. So the phase 3 study actually compared amivantamab plus lazertinib versus OSI versus lazertinib, which is also an EGFR TKI. And the results of progression-free survival were again better with the combination treatment of amivantamab lazertinib versus osimertinib versus lazertinib, which had numerically quite similar PFS results of about a year and a half, which we already saw and knew. So the PFS with the combination is again around 2 years with a hazard ratio about 0.7. So if we look at the brain mets subpopulations, the patients that had or did not have brain metastasis, and of course I'm not comparing trials, but just so you remember the curves from before. So patients without CNS metastasis have a PFS of about 20 months with osimertinib, that we knew already. So patients treated with the combination of OSI plus platinum-based chemotherapy gain about 6 months, the same with the combination of amivantamab and lazertinib. Patients with history of brain metastasis have a much higher benefit with the combination of chemotherapy plus osimertinib than it was shown to have with the combination of amivantamab plus lazertinib. The patient numbers are quite small, and we have to wait for further results, but just to keep in mind for further treatment. So, as said before, patients receiving dual MET and EGFR based therapy have different resistance mutations upon progression of disease, and it was shown with the molecular profiling of patients after they received amivantamab plus lazertinib in first line, that they had a 3-fold lower EGFR-based resistance and an 8-fold lower, no, it was the other way around, a 3.3-fold lower MET-based resistance and 8-fold lower secondary EGFR resistance upon progression. Of course, the safety profile of these drugs is a bit different. Of course, if we combine drugs, we get more toxicity usually. And with amivantamab, as you heard in the morning, we have a whole set of new and old toxicities that we need to address. One is rash, for which we are already doing some prophylactic measurements. Also, a whole trial was designed around that to give prophylactic treatment and also then treatment of adverse events. Then we have a lot of infusion-related reactions during cycle 1, day 1. Another 2 trials were designed around that. So SKIP-ERR gives premedication, and the arm with 2 days of dexamethasone prior to infusion gave results of about, you have about 66%, so 2/3 of patients have infusion-related reaction on the first cycle, day 1. And if you give premedication with dexamethasone, that goes down by about 40%, so only 20% of patients will have infusion-related reactions. And in the PALOMA-3 trial, they gave the subcutaneous formulation and kind of compared it with intravenous formulation with the thought of first proving non-inferiority of subcutaneous formulation, but also, which was proven, by the way, and also we saw that the infusion-related reactions go down by another 10%, so you only have about 10% of infusion-related reactions, which is way better than 2/3 of patients. And then another thing, if you combine lazertinib and amivantamab, you can have venous thromboembolic events. So prophylactic doses of anticoagulative therapy is now recommended for the first 4 months of treatment with this combination. Okay, so after the first line treatment, our patients usually go into a progressive disease in about 1.5 or 2 years. And this progression can be quite different. It can be EGFR dependent, EGFR independent, the whole histology can change. So the patients need some other therapy. In case they received EGFR TKI only in the first line therapy, MARIPOSA-2 trial showed that giving amivantamab plus chemotherapy, plus minus lazertinib, can benefit these patients. And these results were shown first last year and showed the benefit of both combination only amivantamab plus chemotherapy, and also if you add lazertinib on top of that too. Hazard ratios are about 0.4, 0.5, so 50% less patients progress in this time. Of course, another concern is, again, treatment-related adverse events, and during the trial, in the arm that received chemotherapy plus amivantamab plus lazertinib, hematological adverse events were quite severe. And that is why the study was modified to start lazertinib after the completion of carboplatin therapy. Other adverse events that we already talked about, so rash and VTE, also ILD, are more common in this combination as well. So this year, with a longer follow-up, we saw that overall survival in MARIPOSA-2 trial was also improved. It was significant. About 25% less people have chance of dying with this combination in this time frame. And also all of the other co-primary endpoints, so time to symptomatic progression, treatment discontinuation, subsequent therapy, all was improved with addition of amivantamab in second-line therapy. Okay. So what else do we have? There's a whole story about ADCs going on now, and every story with ADC is complicated in its own way. Basically, you have an antibody combined with some sort of cytotoxic drug that penetrates a certain cell. First, it's really beneficial if you find a target that the drug is targeting that can then internalize the drug and work there. There is a role of HER3 receptor in EGFR TKI resistant patients, and we know that HER3 expression actually increases with acquired EGFR TKIs. As you can see on these columns, the expression before and after treatment with EGFR TKI is different and is much higher after resistance to now standard of care EGFR TKIs. So this is one of the trials, HERTHENA-Lung 1. It's a phase 2 study of patritumab deruxtecan. They all have such lovely names. In actually EGFR mutated non-small cell lung cancer, where it was shown that response rates are about 30%, but then another 40% of patients have also stable disease. So the control rate of the disease is about 70% in pre-treated patients that were already treated with at least one, but most of them with 2 or 3 lines of therapy. The ongoing phase 3 trial is now on the way, actually comparing HER3-DXd versus platinum-based chemotherapy that is still kind of the standard of care in second-line therapy. The ADCs, of course, opened a whole new chapter of adverse events that some of them we knew. Of course, we knew the chemotherapy adverse events and the hematological adverse events, but also some of the grade 3, 4, 5 adverse events that are happening should be of concern, and we should learn more about them and how to handle them, especially in heavily pretreated patients, which are basically very rarely perform on 0 or 1 to be admitted to the intensive care unit as well. So some of the ongoing trials with other ADCs, I will not read them all out loud because you can break your tongue doing it, but basically you have a response rate of about 30 to 60% with bispecific ADCs, which show actually quite good results in second, third, and further lines of therapy. There is also a trial combining ADC with osimertinib. This is only the phase 1 trial, but still the companies are actually thinking about doing that as well. So probably combining them and pushing them in the first lines of therapy. Okay, I will be brief with the conclusion. We already have a lot of actually effective therapy driven against EGFR mutated receptors. So progression after first, second, third, whichever line of therapy is inevitable. So most of our targeted patients will go into progression, and it's really nice to have something to offer them. So new treatment option and of course inclusion and access to clinical trials, if possible, is very much recommended. So that will be all from me, and we will discuss later.
Urška, thank you very much for your talk. And I would like to invite all the youngs who are here. This is masterclass, so we are really looking forward to your questions at the end of the session. You can think of any question that arises in your clinical practice and ask the experts. Okay, and now I would like to invite Igor Gomez Randulfo Rodriguez, I hope it's okay, to talk about advances in other rare mutations beyond EGFR and ALK. Please, Igor.
Well, thanks for the kind invitation, first of all, although the topic is slightly broad, as you will see. So I'm Igor Randulfo, I'm a medical oncologist working at the Christie in Manchester, and I'll talk about other mutations. So first of all, these are my disclosures. So let's start with some concepts about these other alterations. My preferred term is actionable genomic alterations because that encompasses all these different alterations, mutations, fusions, amplifications that can be treated in lung cancer or in other tumors. They can affect both intracellular proteins or transmembrane proteins, and that's important from a therapeutic point of view. The tyrosine kinase domain is always intracellular, and that means that most, but not all, our molecules are small molecules that can go across the cell membrane. As I said, this is a growing landscape. Most of these mutations are rare, but if you put them together, it's not rare anymore. We are talking about more than half of those patients with a non-small cell lung cancer if we include KRAS mutations. And as you can see on your right-hand side, the ESMO guidelines already outdated show that there is an increasing amount of options. As we were saying before, this is a heterogeneous group, and some of these alterations are sensitive to immune checkpoint inhibitors, like those in the MAP kinase pathway. Some of those are not sensitive at all, especially the fusions are usually not responsive to immune checkpoint inhibitors. And for those alterations, we must remember that the efficacy of chemotherapy is quite limited, with response rates between 20 and 30%, and an overall survival shorter than a year. So this is important to keep in mind when we see data from phase 1, phase 2 trials. So let's start with the fusions, and let's start with ROS1, which is a paradigmatic example of drug development in precision oncology. So 1 to 2% of patients with advanced non-small cell lung cancer have this alteration. And more than a decade ago, the results of Profile 1001, a phase 1 clinical trial with a small number of patients, were published, showing in mostly a pretreated population a response rate about 72%. Remember, not more than 30% with chemotherapy, and a median PFS longer than a year and a half, and that led to the approval of this regimen, and some retrospective real-world studies confirmed the efficacy of crizotinib. So that was the first drug approved in this space. What was the next step? Well, entrectinib aimed to improve the efficacy in this population, especially the intracranial efficacy. It again showed an interesting response rate of about 70%. The median PFS was quite similar compared to crizotinib, but the intracranial response rate was about 80%. It's true that this is a slightly more toxic compound, but the efficacy, especially when it comes to CNS mets, is clearly higher. But we didn't stop there. The next drug was repotrectinib, a next generation TKI. It is also active against other mutations like ALK and TRAC. And more importantly, it can overcome some of the resistant mutations in ROS1. So Trident-1 was a phase 1/2 clinical trial with several cohorts. In the treatment, the TKI naive cohort, which included patients pretreated with chemotherapy or naive, the response rate was 80%, and the median PFS was notably 35.7 months, so much longer compared to the previous drugs. Even in patients pretreated with crizotinib or other TKIs, the response rate was about 40%. The next drug, which is not approved yet, but it's probably coming into the clinic in the short term, is taletrectinib. It's again an inhibitor of ROS1, ALK, and TRAC, again with a high activity, high intracranial efficacy. It can overcome that resistant mutation, but apart from that, it has a reduced toxicity because it's more selective. So this is the summary of the 4 drugs we have discussed. So we basically increased the efficacy, especially the intracranial efficacy. We overcame the resistant mutations, prolonging the median PFS, and we reduced the toxicity with the latest drugs, trying to be more selective. Let's move to a different fusion, RET, again 1 to 2% of patients. And we have 2 drugs approved in this space, or which have demonstrated an interesting activity. The first one, pralsetinib, was tested in a phase 1/2 clinical trial, ARROW, again a multi-cohort trial with a high response rate, 60 to 70%, and a median PFS over 1 year. Selpercatinib, quite a similar drug with a high response rate and a median PFS both in treatment-naive and in platinum-pretreated patients of almost 2 years. Due to some pressure from the regulatory agencies, both companies decided to go ahead with global phase 3 clinical trials, and the selpercatinib trial was reported last year, Libretto 431, showing again the median PFS is remarkably similar compared to the previous phase 1/2 trial. But more importantly, when we compared selpercatinib with the standard of care, either chemotherapy or chemoimmunotherapy or only patients treated with chemoimmunotherapy, the hazard ratio is 0.46. So it's significantly better than the standard of care, which is not surprising looking at the previous results. Again, more importantly, some patients had baseline brain metastasis in that phase 3 clinical trial, and those treated with selpercatinib had a response rate over 80%, while those treated with the standard of care had a lower response rate, as you can see in these beautiful waterfall plots. All right, so let's move on. We will talk now about receptor tyrosine kinase mutations, and due to time constraints, I'm only going to speak about MET. So first of all, we have to understand that MET is one gene, but it can have several alterations. We will talk about MET exon 14 skipping mutations, but patients can also have de novo MET amplifications, 1 to 5%, MET overexpression, which is highly variable depending on the antibody used for the immunohistochemistry and the cutoff. And we can even see some MET fusions, but they are rare events. So as I was saying, we will talk about MET exon 14 skipping mutations. So importantly, these are older patients compared to the previous alterations, usually with a smoking history, and patients with a sarcomatoid histology have a pretest probability of 20% of having these alterations. So if you see in your pathology report the word sarcomatoid, think about MET exon 14 skipping. We have many drugs that can target MET. Most of them are non-selective, like crizotinib, savolitinib, or other drugs. Some of them are selective, like imatinib and tepotinib. And as the protein has an extracellular domain, we can even target it with some antibodies, like amivantamab. But as you can see in this beautiful graph, with the response rate in the x-axis and the median PFS in the y-axis, the most active drugs are tepotinib and capmatinib, therefore the selective inhibitors. So capmatinib was tested in a phase 2 multi-cohort trial, Geometry, and it showed a response rate of 40% in pretreated patients, 68% in treatment-naive patients. And if you look at the treatment-naive cohort, the median PFS was just over 1 year, and the median OS almost 2 years. Tepotinib is quite a similar compound, and it also showed, again in a phase 1-2 clinical trial, an interesting response rate. And again, the median PFS and median OS in the treatment-naive cohort are remarkably similar compared to capmatinib. Maybe in the previously treated cohort, it was a bit longer, but that may be due to the different populations included in both trials and the small number of patients. So both capmatinib and tepotinib can be used in patients with these alterations, and when it comes to MET amplification patients, we know that TKIs have some activity, although they are not approved, and their response rates are lower than in MET exon 14 skipping mutations. So let's move forward. We are going to talk now about purely intracellular proteins in the MAP kinase pathway, which, as you know, transduce the signal from the receptor tyrosine kinases. Let's start with BRAF, very well known by our melanoma colleagues. There are different classes of BRAF mutations, and this is important to take into account when you look at your NGS report. The one which we are interested in at the moment is the class 1 mutations, which are proteins with high kinase activity and active as monomers. There are some drugs being tested in the class 2 mutation space, but we don't have enough results so far. So V600 mutations are class 1 mutations, and in fact in melanoma the inhibitors, BRAF plus MEK inhibitors, have been tested in BRAF V600E, but also V600K and other mutations. But in non-small cell lung cancer, this phase 2 multi-cohort clinical trial tested dabrafenib and trametinib, the BRAF and MEK inhibitor, only in patients with BRAF V600E mutations, and this is important from a regulatory point of view, at least in the UK and other countries. Again, 2 cohorts, treatment-naive and pretreated. Interestingly, the response rate, median PFS and median OS were quite similar in both cohorts. So response rates over 60%, median PFS of 10 months or so, and the median OS of 1.5 years. So definitely better than chemotherapy, or it looks like it, but it's not like an ALK or ROS mutation. More recently, the results of the PHAROS trial, a phase 2 clinical trial, were presented. Encorafenib plus binimetinib again with an interesting response rate. The numbers are somehow a bit different compared to the previous trial, but again, a small number of patients, so I would take this with a grain of salt, and we know from the melanoma space that these combinations are usually quite similar in terms of efficacy. Remember from one of the first slides that patients with BRAF mutations can be sensitive to immune checkpoint inhibitors. So the jury is still out about the best option for first-line treatment. There are some real-world studies like this one presented by Alessandro Di Federico this year at ESMO, showing that or suggesting that maybe in some patients with a high smoking history, high PD-L1, immunotherapy plus minus chemotherapy may be better than these inhibitors as an upfront treatment. And again, from the melanoma space, we know that the sequence of immune checkpoint inhibitors followed by BRAF plus MEK inhibitors is better in terms of overall survival compared to the opposite. So keep this in mind and please individualize when you see a patient with this mutation. And finally, and very quickly, because KRAS is a completely different beast, a different world, we could talk about for hours about this. Just take into account that this is a globular drug, intracellular. It was considered undruggable for many decades. But fortunately, in the last few years, we are seeing a blossoming of options of different therapeutic approaches, which are showing interesting results. The first ones to come into clinic were the KRAS G12C off inhibitors, which lock the KRAS GDP form, which is the inactive form, avoiding its activation. So sotorasib showed interesting results in the phase 1-2 trials, and that's the reason why the company went ahead with this phase 3 clinical trial against docetaxel, so after chemoimmunotherapy, showing modest benefits in terms of PFS, no difference in terms of OS, and this trial has been criticized. But again, this is the first drug showing some activity in the KRAS G12C space after many decades of failure, so that's the importance of this trial. Adagrasib is a very similar drug with, again, some modest benefit in terms of median PFS, but not many differences in terms of efficacy compared to sotorasib. But more recently, the results of divarasib have been presented. This is still a KRAS G12C off inhibitor as sotorasib and adagrasib, but we have higher potency and selectivity, at least theoretically. And the results, the high response rate, over 50%, are quite promising. And in fact, the company is running a randomized phase 3 clinical trial against either sotorasib or adagrasib. So it will be interesting to see those results. There are other compounds, KRAS G12C on inhibitors, pan-RAS inhibitors that are coming into the clinic, so this space is going to change a lot in the next decade, but this is what we have so far, and my key messages would be that actionable genomic alterations are a heterogeneous group of mutations. This is an evolving landscape. The paradigmatic example of drug development is to look for drugs with better efficacy in terms especially of CNS penetrance, which are active against resistance mutation and therefore prolong disease control, and with an increased selectivity, which means a decreased toxicity. But then again, we can only treat those patients if we find them. So the main message is that we have to test, test, and test, otherwise we will miss those patients. And that's it. Thank you.
Thank you very much. It was really a lot to cover. And now I would like to welcome again Professor Poppa to tell us about therapy sequencing and acquired resistant.
Thank you very much. Thank you, dear colleagues. So to speak to you about sequencing our drugs and acquired resistance. Okay, so let's get the presentation up. Thank you. So these are my disclosures. So we know quite a lot about precision medicine in lung cancer. Actually, I would always say that it's a sort of poster child for how we should be managing kinase inhibition and also genomics in the clinic. And really that's come throughout our sequencing understanding of the biology of not only our transmembrane protein kinases, but also our cytoplasmic protein tyrosine kinase as well, through the initial sequencing efforts that we had to understand the gene sequence of these kinases. At the same time, we've also understand the sequence homology, so we now understand how kinase sequences are related to each other. We have this thing called the sequence dendrogram. And that allows us to understand that clean drugs are actually quite dirty. So for example, if we look at gefitinib and erlotinib, we think they're just very good EGFR inhibitors. They also actually hit quite a few other kinases as well. If we look at the kinase dendrogram, and if we look at some of our more modern drugs, we see even more dirtiness. So for example, pralsetinib, as we're hearing from, causes hypertension and also myelosuppression. Why does it do that? Because it hits VEGF and also JAK2. So we have to understand not only what the on-target effects of the drugs that we use are, but what the off-target effects are as well. Because often when we use higher doses in vivo compared to the animal models, we get more of the off-target effects coming through. Now, we know that gene sequencing is really important in lung cancer because at least in adenocarcinoma, it can classify our patients into these multiple oncogene-addicted subgroups, and we can take our patients with heavy burden of disease, as you can see there, give them a kinase inhibitor, and then within a few days often, let alone weeks, they are much better. And this is perhaps the most pleasing aspect of being a lung oncologist that we have these days. But we also know that if we follow them up after several years, we get the opposite occurring, and this is occurring due to acquired resistance. So what are the biological mechanisms of acquired resistance, and how do we overcome them, and how does that impact into our clinical treatment strategies? Well, we have multiple resistance mechanisms. We have our pharmacological resistance mechanisms. So in the left-hand panel, some patients just find the drugs too toxic and they don't take them, or we have to reduce the dose to subtherapeutic effects. It's a big problem. We have to remember drug-drug interactions. We have to remember pharmacological interactions. Are our patients taking drugs with antacids or drugs such as omeprazole, which change the gastric acidity? Are they taking them with a glass of Coca-Cola, which impacts on the absorption in the stomach? The biggest issue we have is penetration within the CNS, and intracranial penetration is a big issue when it comes to durability of our drug efficacy. So we heard from Igor that in the ALK space that the next generation ALK inhibitors are way better than crizotinib. And if you look at the original ALEX data, which is the randomized phase 3 clinical trial of alectinib versus crizotinib, you will look at the cumulative incidence of CNS progression and show that alectinib is way better than crizotinib in preventing CNS metastases. I mean, that's taken for granted now, many years after the publication. But those of you that actually bother downloading the manuscript and looking at the supplemental data will also find this figure, which demonstrates that the non-brain progression rate, the extracranial progression rate, is exactly the same for crizotinib than alectinib. So all the benefit we are seeing from alectinib is driven by the intracranial benefit that we see. And whether this occurs in the other kinase inhibitors, we can argue or not, but highlighting the importance of intracranial brain penetration for the durability of activity with our patients. At the biological level, we can see on and off-target acquired resistance mechanisms, so we can see after a period of time, both in vivo and in human beings, that if you keep giving the same kinase inhibitor, we change the drug target. Well, either we develop new mutations within the drug target, or we develop copy number change within the drug target as well. We can also upregulate different bypass tracks within the same cellular system as well. MET, for example, is the commonest example of this. And for reasons that we don't understand, the histology of the tumor can also change. And for example, neuroendocrine differentiation or small cell transformation can occur as well. So what are the different genetic mechanisms of drug resistance that we see? So I'm not going to list them, but I'm telling you about a therapy class. We see these things called gatekeepers and solvent front mutations. These are exactly the same types of mutations that we see, because we have, at least in terms of the receptor tyrosine kinase domains, we see the same sort of homology. So we see gatekeeper mutations. These are acquired resistance mutations. These are mutations at the innermost part of the ATP binding pocket, which determine the hydrophobic pocket, which stop the drug from binding, and therefore ATP can actually bind in preference to the drug itself. We also see a different class of mutations called solvent front mutations. These are usually glycine. These are mutations that result in a glycine, which are at the entrance of the ATP binding pocket, which the TKIs actually have to get through to get into the binding pocket. And so they can't get there, and so therefore ATP binds preferentially. And we see a third class of mutations called XDG F motif mutations, which are at the initiation point of the segment of the TKIs, and the different mutations are in the X. And these we often see in the fusion RTKs such as NTRK and RET as well. So these are the list of the different types of gatekeeper mutations on the left and the solvent front mutations on the right that you just need to learn and have understood as pattern recognition. So the classical ones in EGFR, the gatekeeper mutations T790M, the gatekeeper mutation in ALK L1196M, and in the right-hand side, for example, G1202R and G2032R, which are the solvent front mutations which occur in ALK and ROS respectively to prevent the drugs from binding. And you can see them in the wide variety of different drug targets that we have. But of course, now we have newer generation drugs to overcome these inhibitors. So these are smaller drugs which get through that steric hindrance, get into that binding pocket to prevent ATP from binding, okay? So this is all medicinal chemists coming up with better drugs. And so here's an example of a variety of different drugs. This is in the NTRK space. So we have a wide variety of next generation NTRK inhibitors which are being developed, or perhaps have been developed, against patients with NTRK fusions, which are designed to overcome the variety of gatekeeper XDGF mutations and solvent front mutations that occur on acquired resistance to larotrectinib or entrectinib in patients with TRK fusion non-small cell lung cancer. And of course, we might want to be using these on acquired resistance, but what about using these up front? That's the big question that we have to ask. Now, in the RET space, we have quite a lot going on in acquired RET resistance. The lead compound at the moment, in my opinion, is EP0031, which is a selective RET inhibitor, which is designed to overcome solvent front and gatekeeper mutations. We have limited data on this compound. The most up-to-date data were presented in a poster at ASCO, demonstrating in a limited number of patients with both solvent front and gatekeeper mutations that we do see some responses, and certainly in terms of ctDNA responses, we do see those responses coming through. Now, when we're looking at the RET space, the lead compound for many a year has actually been LOXO260, which was designed to actually cover the RET G810X solvent front mutation, also the V804 gatekeeper mutation, together with combinations, and there's a variety of other RET inhibitors which have been in development. But over the last 12 months, many of these have ceased development. And the question is, why have they ceased development? And what does this mean for our strategic decision on whether we keep these drugs as drugs for salvage or whether we should be thinking about using them up front? So what do we know? Well, if you follow biopharma, we actually know quite a lot. So, for example, we know in the top left-hand panel that Eli Lilly have said that they're no longer developing LOXO260. And at the Triple meeting very recently, they presented their data and they summarized that, yes, it's active and it's got a manageable safety profile, but actually it's just not commercially viable to develop further. It's not commercially viable to develop further because the rarity of on-target solvent front mutations is really quite low, so the prevalence is low. So it doesn't make any commercial sense for them to develop it in the resistant setting. And as you've heard from Igor, first-line selpercatinib has a PFS of 25 months in a rare indication. So how on earth are you going to develop a drug in that setting? It's commercially not viable, particularly if the European regulator then says you have to do a randomized phase 3 trial. So we have big issues in how we develop drugs in rare indications and big issues in how we develop drugs for acquired resistance. TPX0046, the press release says that it was discontinued because of tolerability issues. Blueprint have a number of drugs, fourth generation EGFR inhibitors that are being developed against C797X, atypical mutations and exon 20 insertions. However, they reviewed their entire program and said strategically the activity was good but not so good, and actually it doesn't make any commercial sense to continue to develop these further. We're axing our entire EGFR fourth generation program. So how do we then develop next generation drugs when we already have highly potent active drugs with limited lifespans? This becomes economically challenging when the regulatory environment is very, very difficult. And ex-US, the commercial reimbursement environment is even more brutal. For it doesn't make a lot of sense for pharma to continue to develop these drugs. Maybe we need to think about our drugs in a slightly different way. So my good friend Ignatius Hu, based in California, said, let's think about our ALK inhibitors not in the left-hand panel as we currently think about them, first-generation inhibitors, second-generation inhibitors, third-generation inhibitors. Let's think about them functionally as brain non-penetrant, crizotinib, brain-penetrant single mutation active, such as alectinib, brigatinib, lorlatinib, or multi-resistant, multi-mutation sensitive ALK inhibitors such as TPX0131, which is no longer being developed, and NVL655. In fact, when we look at the NVL655 data, which is the newest kid on the block in the ALK space, which is being developed and has activity, you can see on this waterfall plot, the orange dots indicate patients with solvent frontal gatekeeper mutations, or multiple or single mutations. It is highly active in lorlatinib-resistant on-target cases. So, of course, this may well get regulatory approval, but in Europe, how are we going to get European approval if the European regulator may require a randomized phase 3 trial? And how is it going to get reimbursement when the comparator is going to be potentially chemotherapy in that situation? Should we be reserving these cases for later down the line once they've failed all treatments, or actually should we be using them up front? I think we should be using these drugs up front. So we've seen from the CROWN trial data that you can take a drug designed, not for upfront use, but it was designed to overcome G1202R, and because it's designed to overcome G1202R, the IC50 for G1202R is quite high. That's why it's designed at 100 milligrams at the standard dose. When you use it up front, you don't necessarily need that dose, and you can clearly get very durable benefits and use it up front rather than waiting for the resistant setting. So should we be using our drug-resistant drugs up front or waiting till they get salvaged? My view is use them up front. Where's the other excellent example of this? Of course, it's osimertinib, right? Designed to overcome a gatekeeper mutation, T790M. Who uses it now in that setting? Nobody. We all use it up front. So the message is use your best drug up front and don't wait until relapse. But you'll say to me, well, what about bypass tracks? Okay, what happens if I've got bypass track signaling? Shouldn't I be hitting MET? Well, yeah, you could argue that. MET activation we see across a wide variety of oncogene addictions. The question I've got for you is how do you find MET activation? And this is a big issue. Because if you look at the biology of MET activation, we see MET high polysomy as a subset of activation within the EGFR population on the left. But within that is MET amplification, which is clonal MET amplification. And within that, we see a lot of spatial heterogeneity. And of course, the issue with MET activation is it's often subclonal and heterogeneous. And the bit that you're biopsying may not necessarily have the MET amplification in it, and the bit that's causing the problems with the patient may not be the bit that is MET amplified. So of course, if you are going to be drugging with MET, you need to continue the suppression of the parent oncogene, because that's giving your broader inhibition already, and add in the MET inhibitor. How do we know that that actually works in vivo? So we know that because Merck's KGaA did the INSIGHT 2 trial where they had patients with osimertinib failure and then decided either to switch to tepotinib or add in tepotinib. This is the arm that nobody talks about, where they switch to tepotinib, stop osimertinib, and switch to tepotinib. Response rate's 8.3%. Right, because everybody else, you lose control of the clones which are already under osimertinib suppression, and patients progress. However, when you combine and add it in, you do get a response rate of about 50%, which leads us to the biological models of why we think acquired resistance is occurring. We sort of used to think that you have pre-existing resistant clones, which then grows out, but we're now thinking that there's a persistent evolution model where you have a class of cells called the drug persister cells, which create a microenvironment to then create these resistant cells breaking through, but you probably have a mixed model in that setting. So what about non-genetic resistance mechanisms? We actually have quite a few non-genetic resistance mechanisms that we know about. And we know about this from basic biology. So if you're a Drosophila enthusiast, you'll know about this model. This is a model where you invoke a UBX mutation within a Drosophila and it gives it an extra pair of wings. However, you can create the same extra pair of wings, but not by genetic modification, giving the fly ether vapor. The ether vapor changes the transcription profiling to turn on the actual extra set of wings. So do we see this same phenomenon occurring in human beings? Yes, we do. And this is in neuroendocrine transdifferentiation in EGFR mutant and some cases of ALK-positive lung cancer, which are all on the background of TP53 and RB1 mutation, because that results in stem cell plasticity, upregulation of a variety of different transcription factors, which then switches on the neuroendocrine phenotype under the selection pressure of the oncogene addiction. And so we have this concept where we have drug-tolerant persister cells after a period of time, which creates this milieu of how the cells then evolve under the selection pressure, whether they're going to develop a new gatekeeper or solvent front mutation, or whether they're going to end up with a different transcription factor selection to turn into a neuroendocrine differentiation. So these drug-tolerant persister cells are really critical in us understanding their biology to be able to drug them as best as possible. And there's quite a bit of work going on in this space, and there's quite a bit of work going on in profiling these drug transcription, these drug-tolerant persister cells. And the latest work tends to suggest that these cells are driven by a variety of different targets, and certainly BRD4 and TEAD inhibition are looking at like the key candidates, and there's a number of companies with BRD and TEAD inhibitors which are looking at this space. Of course, when it comes to overcoming resistance, we have a number of options. We can use our good old-fashioned platinum therapy-based options. We can use our MET options if we think that might be important, and we can use our ADCs or our chemo-light options, as I call them. So I'm going to close and say acquired resistance mechanisms are simple, but actually in real life quite complex. Understanding resistance mechanisms we used to think is simple actually, but it's really quite complex. CNS penetration is really key to durable benefit. Sequencing can be useful, but I always say use the best and most brain penetrant drug up front. And thank you for your attention.
Thank you very much, and I would like to invite Davorin to show us how we moved targeted treatment to earlier stages of lung cancer, so adjuvant treatment of EGFR and ALK-positive non-small cell lung cancer.
Okay, after all, Marsden medicine, now we are again in Belgrade about the adjuvant treatment of ALK and EGFR positive patients. Yes, we are truly unsatisfied with the result of early lung cancer, I think everywhere, especially in Serbia. We have up to 30% of resectable patients here, but the overall 5-year survival rate don't exceed 50%, and especially disappointing is survival in stage 3, which rarely is above 40%. LACE analysis is here in every presentation to witness how modest was the addition to survival, 5% at 5 years, 11% of reduction risk of death for combined platinum-based chemo. Targeted therapy started as a revolution, and then almost or more than 10 years ago, everyone realized that targeted therapy do improve overall survival. So, and the first proof of the principle was in the EGFR space. So we now have osimertinib. It's many times mentioned here today in EGFR metastatic mutant lung cancer. We have almost 40 months overall survival with osimertinib. So it was a logical step or a logical transition to curative intent to perform ADAURA study that compared After a resection and after adjuvant chemotherapy, also patients were certified to receive osimertinib 80 milligrams daily or placebo, 3 years for osimertinib. And we know also the ADAURA results and also the updated results from last year. It's over 5 years of median DFS. So, but also many times mentioned CNS activity in addicted patients. So also a very, very nice CNS activity of drug given upfront and also given as an adjuvant treatment. Also, overall survival was equally improved in stage 1B, not very numerous, but also in stage 2 and stage 3, giving more than 60% of reduction in risk of death. Which is of special interest was the conclusion that overall survival was not affected generally with chemotherapy applied. So with or without chemotherapy, the reduction of risk of death was almost equal. Also, adverse event for very long usage of osimertinib was the majority of adverse events were recorded firstly in first 12 months, and after that there was no evidence of late emergent adverse event. Also due to prolonged exposition to the drug in arm A, so the duration of adverse event were longer than in placebo arm. But also there are many challenges after that study. We did not solve the situation totally. So there are some open questions. What about small tumors? We will have ADAURA-2 results, I hope soon, for very early disease, 1A, 2 or 3 stage, upon 8 classification. Also, what about uncommon mutations? Because osimertinib was approved only for common mutations. Do we have as a solution amivantamab plus lazertinib? A duration of treatment is a constant the matter of discussion, not to make it shorter, but to prolong maybe. We have a target study that will give osimertinib for 5 years, but we should, as in every therapy in medicine or in oncology or in thoracic oncology, to balance between compliance, safety, and economical toxicity. Also, patient selection, as everyone in medicine, should we routinely perform tests for minimal residual disease, and should it use for patient selection and the treatment that will be proposed to our patients? Adjuvant chemotherapy, is it still necessary? And what about adjuvant immunotherapy for those EGFR mutated resected patients? Regarding treatment duration, it was seen that the Kaplan-Meier curves for DFS began to converge after TKI discontinuation. And also in ADAURA trial, both CNS and extracranial progressions occurred after osimertinib completion or discontinuation. Also, only 2/3 of patients completed 3 years of treatment. Also, in the Far East, 2 years of adjuvant icotinib were better than 1 year. Regarding the treatment dose, in advanced disease, there was no clear dose-response relationship for OSI in phase 1 dose escalation study, but the treatment toxicity really increased with doses above 80 milligrams. How to avoid overtreatment? Because we certainly know that some patients are cured or are going to be cured without adjuvant osimertinib. DFS, 5-year DFS was 37% in placebo arm. Should we detect for all patients circulating DNA after surgery? In one study from Asia last year in JTO, it was revealed that it is significantly higher 3-year DFS in ctDNA negative patients at baseline, which may contribute to the statement that ctDNA is independent risk factor for DFS along with the stage. Is there a minimal residual disease a prognostic factor in early disease? Or should we identify high-risk candidate for disease recurrence and give only to those patients TKI? But to answer to this question, we should also improve or minimize the false negative rate of ctDNA assay and to improve the sensitivity and specificity on ctDNA in detection of MRD. One of the universal answers in thoracic oncology is please do a plasma NGS, because in that situation is better for detecting EGFR at baseline, but similar to drop the digital PCR in clearance of EGFR. Regarding adjuvant chemo, 60% of patients in study received it. It was mostly younger patients and those in stage 2 or 3A. And generally, DFS and OS benefit was revealed regarding of adjuvant chemotherapy use. But if you analyze 5-year survival in those stages, it was a little bit better. In OSI arm, 87 versus 80%, and also in placebo arm. So it may suggest a potential survival benefit with adjuvant chemo. So nowadays, like in immunotherapy trials, the only argument for omitting adjuvant chemo will be the patients unfit for the treatment. Regarding partner to cisplatin or carboplatin, it's in a Japanese study, pemetrexed performed much better in terms of safety compared to vinorelbine. Yes, adjuvant chemotherapy as a monotherapy is not indicated in EGFR mutant non-small cell lung cancer patients, regardless of PD-L1 expression. There were some positive signals from IMpower and KEYNOTE-91 study, but also we know that PD-L1 positive patients have a higher rate of TP53 mutation and also a poor prognosis in Asian patients. And also we could consider what to do with patients with primary resistance to TKI. ADAURA will continue with respect to overall survival, to translational analysis, and also 3 already mentioned studies, NEO-ADAURA in neoadjuvant setting, in very early disease, and also a target study regarding the duration or the prolongation of OSI adjuvant treatment. Regarding the ALK space after crizotinib, we are faced with the clinically relevant higher affinity for ALK, also a brother inhibitory efficacy against secondarily mutated proteins, and also a more effective penetration of the blood-brain barrier. And after Alex's study with impressive results of 5-year survival, it was expected also that such drugs has prompted the consideration of transitioning TKI to this curative content. Here in ALINA, there was no pre-chemo after resection, but after resection, patients were randomized to receive alectinib for 2 years or platinum-based chemo 4 cycles. And the results are also the symphony of success. So the DFS was impressive, more than 75% of reduction of progression, and 88% of patients were free of progression after 3 years. Also by stage, impressive results in A1B and also 2 and 3A. Especially impressive was CNS activity, where the patients were CNS disease-free, and 95% of them after 3 years. And also the sites of recurrence showed that much less distant mets were demonstrated. For example, 14 brain mets in chemo, only 4 in alectinib arm, or 8 bone mets in chemo, only 1 in alectinib arms, together with less local and loco-regional recurrences. At the very end of this presentation, we have the ADAURA, which give us the proof of concept data, and ALINA going with the same steps. But we are the reality also that nowadays we have salcatinib in libretto study in adjuvant red-range patients. So we are reality of incorporating additional biological therapy in adjuvant treatment. So we should reevaluate also the current treatment paradigm, having much more therapies in adjuvant treatment. Also, the role of adjuvant chemo is one remaining pebble in the show of thoracic oncologists, allowed in ADAURA, omitted in ALINA, but still should the paid to cure should include some patient who should receive platinum-based chemo, or are chemo-free approach safe and universally could be applied across all stages in early disease. The most effective duration of TKI treatment should be longer for some patients, should be over-treatment for some. The role of ctDNA, and above all, is how to make a priority to NGS in our country, and I think everywhere, to perform NGS for all patients with resected non-small cell lung cancer, and also in neoadjuvant setting. Thank you very much for your attention.
Okay, thank you all, and thanks for keeping up with the time. And now I will invite all the panelists, to join me on the stage. So who is not here? Davorin, Ruška, Igor, everyone's here. And actually, I think we've all you understand that we can talk amongst ourselves for as long as we want to, and we could, but I would like to see if there's any questions from the audience. Do we have any burning questions to ask in the audience, or should I? Okay, we have one over there. Can we get the microphone over here?
I have a question for Mr. Popat. I suppose that you routinely use upfront NGS testing. Have you ever detected co-occurrence of EGFR and KRAS mutations? I know that co-occurrence of major driver mutations is not expected, but theoretically it could be possible, maybe in terms that mutations can occur in different SAM clones. I'm asking this question because I found this in literature in sporadic case. What could be the therapy approach in this case?
Thank you. Yes, we do find these co-drivers in NGS. Your specific case was EGFR and KRAS, so we on occasion do find them. We do find EGFR and BRAF, for example. We find ALK and BRAF. So name me any pairing, we found it. The problem is what you do with it. That becomes a problem. Sometimes you can try and work out what the dominant genotype is. You might be able to do that if you have some information, for example, from ctDNA, when you can quantify the variant allele fraction of the particular mutation. It becomes more problematic in tissue biopsy because then, of course, you have the interfering non-malignant cells which reduce the variant allele frequency as well. It becomes even more complex when you're talking about a fusion co-occurring with a single nucleotide variant such as mutation, because you can't easily quantify the extent of the fusion that's present within your specimen with a quantitative mechanism in the same way as you can do with a mutation. So the answer was to what you do is I don't know, but you have to make a judgment decision as to which is the dominant driver in that setting and treat the dominant driver, but essentially counsel the patient that you're not going to get a durable benefit as you may expect otherwise, because those non-resistant clones will grow out. Of course, if you're thinking about a chemo EGFR strategy, then that will overcome your baseline approach.
Thank you.
I have a question for Igor. Okay, you mentioned a lot of other driver mutations, and you know that we have some. You have mentioned like MET skipping mutation, and you mentioned that they occur more frequently in older patients, and some patients are not fit for chemo or chemoimmuno upfront. And we have issues in regular clinical practice what to do to give capmatinib, which is not approved for first line, or just give no treatment at all. And the same actually question arises in KRAS G12C positive patients when we have sotorasib, but only approved in next lines of treatments. So what is your approach in your clinical practice?
So, yeah, I think that especially in those unfit old patients, we need academic trials, maybe single-arm trials to show the efficacy of those drugs in that specific setting. But then there is up to the regulatory agencies in each country to let us use or not those drugs. And the UK is more strict, for instance, than Spain. I don't know how the environment is here. From my point of view, it makes sense to use, of course, those drugs.
You are restricted to use it in UK, so you don't do it.
Sotorasib, for instance, cannot be used in first line.
Mm-hmm.
And
do you have any other possibilities to give? Maybe, I don't know, some money from outside, like donations or something like that?
I mean, the UK system is quite regulated, as Igor knows. The government provides regulatory approval and also reimbursement as well, which is the issue. When it comes to first-line MET inhibition, we know that capmatinib does not have European label for first-line, but tepotinib does. I mean, my views on it is that the drugs are interchangeable in terms of efficacy and toxicity. So personally, if capmatinib is not reimbursed, and you have if IO is not reimbursed, but you have access to capmatinib or tepotinib, in the frontline setting, I have no issue with using a frontline MET inhibitor. That's what I do routinely in clinical practice, and we do it because the UK is actually one of the few areas in the world which has first-line regulatory and reimbursement access to tepotinib. So we can do that officially. When it comes to KRAS G12C, the frontline data for KRAS G12C in fit patients is actually not too bad. We have an ongoing cohort in combination with platinum doublet chemotherapy in fit patients with within the CodeBreak program, but also a Japanese trial as well. Should we be giving sotorasib to a PS2 patient or a PS3 patient? I think that's a difficult question to answer if it were available, because one has to think about what the other alternatives are. These patients often derive good benefit from checkpoint inhibitors, although the more frailer they are, the less the benefit they get from checkpoint inhibitors. So it's a balance between what you have available, what is funded, and what you expect your drug to be able to deliver. Certainly, sotorasib is a tougher drug to give post-checkpoint inhibitors than pre-checkpoint inhibitors.
So do you routinely do a break between the IO and the KRAS inhibitors in second line, and how long do you give like the leader?
So the issue with sotorasib is that it triggers checkpoint inhibitor hepatotoxicity, and generally what I always tell my fellows in the clinic is if you know the patient is slowly starting to progress on chemo IO, then you can stop the IO bit, just carry on the chemo for maybe a couple of cycles, give a bit of a washout, and then switch over to your sotorasib. That massively reduces your hepatotoxicity. But actually, the other key issue is, do you need 960 at all? Right? If you look at the comparative dose comparison data, 240 functions as well as 960, much cheaper on the state than 960 is. There are less GI and liver toxicities as well. So I generally would suggest 240 is a much better dose.
And then you would not increase the dose, start at 240 and go all the way. Yeah, makes sense. And if we continue talking about adverse events, which is one of my other favorite topics, can we talk a little bit about amivantamab and the infusion reactions? And have you started, we don't have amivantamab here in Serbia, but have any of you started the Skipper pre-medication, and does it work in real life?
Yeah, it does actually. You know, we were not particularly impressed by
fond of amivantamab.
Fond of amivantamab because of all the adverse events, but actually there are the data is quite nice, and also we started using that like routinely in our practice, and the infusion-related adverse events actually go down. Also with all the prophylactic treatment for the rash, you know, it's a lot of work for the patient. It's a lot of work to even give this cycle 1, day 1, day 2, day 8, day 15, all the days of the treatment, but the patients derive a lot of benefit from it. So yeah, that's what we do.
So UK agrees, yeah?
You know, I think for us, infusion-related reactions were not an issue. I mean, the nurses were a bit scared of them, maybe the patients, but it's easily manageable with the appropriate measures. From my point of view, the main issue with amivantamab is the skin-related toxicities, especially the scalp toxicity.
Yeah, I heard.
We have a lot of travel to keep that under control, and I think that we don't really know actually there is a recent study published in lung cancer showing that beta blockers could be effective in that scalp rash, which is interesting because it means that we were not understanding it properly. Yeah.
We all saw that a few days ago, actually, 10 milligrams.
What do you do as preventive for skin toxicity?
Yeah, so we usually start tetracyclines, like doxycycline, minocycline, and then, of course, steroid creams, and we are quite aggressive when it comes to the management of the scalp toxicity, with some input also from nurse specialists.
Okay, can I have a question for Davorin? I'm sorry, you should be on the stage. You know, you showed us data for adjuvant treatment with ALKs and EGFRs, and now we're also expecting data with targets that are not so frequent. How do you, I mean, for adjuvant treatment, how do you think we will find enough patients to be included in those trials? How we will get the data for other rare mutations in adjuvant setting?
Yes, we will need NGS, but we don't routinely perform NGS. So we are now obliged to test EGFR resected patients, and now we have a donation also for ALINA study for alectinib, but for other, we are still in dark age. NGS, and then we will be, I think, but we have no clinical studies, if you mean this. We have no available clinical studies for adjuvant treatment in Serbia, as far as I know.
I don't know how can we do the phase 3 rats in early stage clinical trial in adjuvant setting. I mean, it's not possible to do it in a metastatic setting also.
So I think it's probably like you were saying, Sanjay,
I mean, we
need
couldn't do it.
trial designs.
We didn't do
to-
it the
to
ROS
these
1
things.
actually trial
Yeah.
for after 10 years after phase 2 trial. So I don't know.
Yeah, there is a phase
There,
3
there will be maybe
for,
basket trial. I mean, for all the rare mutations, and then comparing to the
Yeah,
I don't know
I mean,
standard chemo. That's but
The challenge is from the regulatory development viewpoint, the companies aren't going to do basket trials, right? So the only way this is going to work is if we have national systems set up where from a nation viewpoint, we have NGS set up. So, you know, I would always encourage the influential members in the room to engage with government, because this is actually a government life science policy issue. Because for governments to be able to engage with the life sciences sector to bring in commercial income at the government level, we have to have government embedded and government funded NGS, because that's the only way we're going to encourage our governments to ensure that we bring in science and we raise the standards through clinical practice.
Yeah.
Actually, data are smart to indicate that NGS is a must. For the government, they said, you know, it's much cheaper to do NGS for all your patients and exclude patients from costly immunotherapy. That will actually save money to your system.
Yeah, good point. And I will end with a really quick question, which does not have a really quick answer, and that is, do we need more than 2 or 3 years of adjuvant TKIs? Because we've seen that there are studies going on with 5 years of adjuvant osimertinib. Any of you can answer, do we need or do we not need longer than that? Is 2 years enough? Is 3 years enough? Or do we need more?
I mean, 2 wasn't enough for the gefitinib in adjuvant setting. They had to move it to 3 years in
I mean,
osimertinib.
if we think about breast cancer, they started with 5 years adjuvant trastuzumab. I've forgotten the name. You know, the hormone therapy, and then nowadays we know that
Tamoxifen.
10 is tamoxifen. And thank you. And now we know that 10 is better than 5. So.
Yeah, I think this is a really tricky area, and I think one has to be personalized to your risk of relapse. So in stage 3, I'm very uncomfortable at stopping at 3 years, even in the government sector I have to. And I hope that the 5-year target trial will show us that will help. In the 1Bs and the 2s, right, I think you can make an argument to stop at 3, right? Because do you really need to treat these patients? Many were cured, right, in the control arm. At that time point. So I think the one thing that we learned from the ctDNA data from ADAURA is that those patients that were positive definitely needed to have the EGFR inhibitor. And I wonder whether we're moving towards an era where we can perhaps stop and then monitor on ctDNA, and then when it turns positive, then do that. But that's a big regulatory, financial, data empty area at the moment. That we'll need to think about, but I suspect we'll head in that era.
Okay, so thank you all. Thanks to our speakers. And now we have a short break. We are a little bit behind, but not too long. So if we have a 10-minute break and re-adjourn here at 20 to 1, please.
Ladies and gentlemen, welcome after this short break. We saved the best for the last, so the small cell lung cancer session starts now, and I would like to invite Jelena to give the intro presentation for this Save the Best for Last session.
Thank you. Thank you, Bojan. So this is just a little intro to guide the discussion and to guide you in the small cell world. So we all know about this, and we know the epidemiological data, and we know the efficacy data of various drugs, and we know the 5-year survival. And we really know that small cell lung cancer is initially sensitive to chemotherapy with high response rates, but then the responses are very transient, and we have quick relapses, and the patients just do not live long. I heard this somewhere, that small cell lung cancer is a born-to-be-bad tumor, and I really like that because it is the truth. And we know, even though it has a high doubling time, even though tobacco abuse accounts for up to 80% of cases, and we do have a very high number of genetic alterations, which is due to the tobacco exposure. However, most of these genetic alterations are not drivers for one, and so therefore they are not targetable. And therein lies the biggest problem with small cell lung cancer. Then again, we have very limited tissues. We have poor performance status of these patients and a very complex biology, and we do not know a lot about mechanisms of resistance. If we go back only 30 years, and this is a paper published in The Lancet in 1992, and I've highlighted this, which says no standard treatment for small cell lung cancer exists. It wasn't completely the truth, but we were not far off from that. This is I think for me, this is these are the main curves that we have in small cell lung cancer. If you look at the mortality trends in non-small cell lung cancer, where you can see that the 2-year survival is constantly increasing when we have all these new treatments. In small cell lung cancer, and this is up to 2020, 2-year overall survival was the same as it was 20, 30, 50 years ago. Why? Because we had the same standard for over 30 years. We had chemoradiation in limited disease, where we know that chemoradiation is better than chemo alone, but still 5-year-old survivals are not great. And we know that in stage 4, whatever chemotherapy we give, the survival is going to be the same, the outcome is going to be the same, and we hardly have any long-term survivals. 3-year overall survival in chemo time was under 5%. And now we, of course, do have some progress with the addition of immunotherapy to chemotherapy, which has become the new standard of care based on Empower 133 and Caspian studies, and we all know about these studies. The most important thing for me in these studies is that if you look, of course, these curves are separated, there is statistical significance, but if you look at the absolute numbers, the differences are 2 months. When we're talking about non-small cell lung cancer, we're not talking about 2 months, and we would say that 2 months is really completely insignificant clinically and, of course, statistically. In small cell lung cancer, this was not only statistically significant, this was clinically significant or beneficial for our patients, because that was the first thing or the only thing that really showed any sort of progress in small cell lung cancer. So, okay, we did a little bit better. So all these immunotherapies have made it into the ESMO, NCCN, and all the other practice guidelines. But the problem is, if we give mono-IO to chemotherapy, have we reached the survival plateau? I've listed these studies here. They are all the same in design. And all these curves look pretty much the same. And if you look at the PFS, at the OS, at the hazard ratio, there's nothing really to choose between them. They do look the same. Why? Because we do have durable benefit. Nowadays, we have the 5-year survival data from the umbrella extension of the Empower 133. So we do know that there are some patients who will live and make it to 5 years or even longer. But they are a minority. That's maybe 10, maybe 15%. So what can we do to raise the curve? What can we do to prime the other 90 or 80% for better immunotherapy response? Relapsed or refractory small cell lung cancer is a completely different story, and Katja will tell you about some of the advances in relapsed and refractory small cell lung cancer. But we do know that clinical trial inclusion is strongly recommended for any patient with relapsed extensive stage small cell lung cancer. And now we have expanded the role of immunotherapy, as we've seen in non-small cell lung cancer, to limited disease or to stage 1 to 3 with the Adriatic LU005 and KEYLYNK 013. The Adriatic study has read out, and Katja will probably say something about that. And this is my final slide, because that's where we are. This timeline stops at 2017, but that's when we started giving immunotherapy. So are we in the second golden age? Have we made enough progress in small cell lung cancer? And Katja will tell us the difference, so thank you very much.
Okay, moving forward, Rafael, what about the radiotherapy? How are we standing there?
Well, first of all, many thanks for having the opportunity to be with you here today. It's a pleasure. We have spoke with Davorin for 20 years that we should meet in Belgrade finally. It's the opportunity to join you because you do so wonderful job in terms of oncological treatments, despite perhaps not the most easy environment in terms of public finances and so on. So my talk is on radiotherapy for small cell lung cancer. We tend to think still in the limited disease and extensive disease way of thinking. The simplest way to think this way, that limited disease is the disease that is amenable to radiotherapy field. And staging of small cell lung cancer still remains very important. The question for today is really whether we need a PET scan on top of all other examinations for staging. The data from the clinical trials in limited stage disease tell us that not necessarily. However, from my practice as a clinical oncologist, if I have the opportunity to have a PET-CT scan done fast, I like to have it also for proper delineation of structures when planning radiation. So if you have this opportunity, obviously, please consider, but again, it's a question of a PET-CT scan availability. We also learned that TNM classification is very important, that for very early disease, T1, T2, and zeros, you can consider surgery, but the data on surgery versus radiotherapy in this setting, in the randomized way, do not exist. We also know that we can avoid prophylactic cranial irradiation in very early small cell lung cancer. The conclusions, to start with the conclusion of the current standard of care, with radiotherapy, we observed over the last 20 years small yet significant benefits in terms of survival. And the golden era of radiotherapy is already, I think, a little bit behind. Early radiotherapy is more effective than late, so we typically deliver radiation with the first or second cycle of chemotherapy, if only possible. We also know that concomitant strategy is more effective than sequential, which we try to avoid, but sometimes it's not possible. And of course, it happens at the expense of increased toxicity. Hyperfractionated radiotherapy, according to Turisi's schedule, is superior to conventional radiotherapy in the original Turisi trial. However, please keep in mind that the control arm of this trial was simply 45 grays, and it was not biologically equivalent. So the current data from the CONVERT study will tell us that with 60 to 60 grays, one daily fractionation is an alternative to 45 grays BID, with slight preference in many centers for BID scheduling. The optimal volume, also over the last 20 years, we learned that in small cell lung cancer, we can use involved field radiotherapy similarly to non-small cell lung cancer, and the chemotherapy schedule is still etoposide cisplatin as the backbone. And we also know that the radiotherapy should be delivered in such a way that the dose intensity of chemotherapy is not compromised, a very important feature. There is also an important issue of prophylactic cranial irradiation. The rationale for prophylactic cranial irradiation is given here. We know that brain mets are very common in small cell lung cancer. The insufficient chemo supply to the brain makes it a sanctuary site, and there will be relative increase of brain relapses in long-term survivors. The response rate to whole brain radiotherapy in brain-only relapses is also not sufficient. Therefore, stereotactic radiotherapy is used more and more for those patients with just few brain metastases upon relapse. The PCI was studied extensively in both limited and extensive stage small cell lung cancer, showing that PCI administration leads to reduction in the incidence of brain mets, which was the main endpoint of these studies. However, the potential for late toxicity of PCI is quite significant. Ataxia, seizures, dementia, impaired cognitive functions, and so on. These toxicities are particularly relevant for patients who are elderly, above 70, 75 years, have cerebral vascular diseases, which is typically the case for heavy smokers as patients in small cell lung cancer. The PCI intergroup study was examining the role of 25 grays in 10 fractions versus higher dose, because at some point of time we believe higher dose will be necessary to keep brain metastasis incidence lower. You can see on the left side that really there is no difference in terms of brain incidence after PCI 25 grays, 36 grays, and interestingly, survival seems to be better for 25 grays for unknown reason. So that's why the standard of PCI is 25 grays in 10 fractions in most of the institution. It has also been studied in extensive disease already 15 years ago, showing that not only you can limit the rate of brain mets substantially with 25 grays, 10 fractions, but you can also lead to improved survival. In this study, there was no really impact of PCI on quality of life, but again, I would stress when I talk to my patients and we are discussing the issue of PCI, I also discuss the fact that in about 10 to 15% of patients, the damage may be functionally detrimental in terms of early dementia and factors of that. Whereas for most patients, especially younger patients, the effect is relatively minimal, but again, may be more substantial with the duration, increased duration of life, which we are observing right now. So the current recommendation is that PCI should still be part of standard of care for all patients, maybe with the exception of patients with the CNS, cardiovascular and vascular disease and the elderly. And it still should be an important factor to be included in future studies in these patients with the standard of dose of 25 grays in 10 fractions. There are two controversies. One controversy, which I'm not showing for the lack of time, is the Japanese study showing that the MRI surveillance, if you do it pre-treatment and post-treatment, may lead to acceptable rates of overall survival as compared to PCI strategy. And the second important point, that with the new advance in systemic therapy of small cell lung cancer, which we'll hear about in a minute from Katja, we see less brain metastasis with PCI, without PCI than we have seen without these systemic treatments. Here you can see, for example, from IMpower 133 study with Atezo, that the rate of brain mets with atezolizumab for patients who were not treated with PCI remains on the 20%, on the 10% with PCI and 20% without PCI. So this is slightly less than we would observe in the old studies with PCI. That's why in the EORTC we are now conducting PCI versus active surveillance by MRI, a direct randomized study to see that if in patients who responded to initial treatment, both in limited and extensive stage small cell lung cancer, with use of immunotherapy or not, according to stratification, the PCI or surveillance strategy is leading to different overall and progression-free survival. So the paradigm shifts in the management of limited disease small cell lung cancer are quite significant with radiotherapy over the last 2 decades. You can see here the incremental benefits with concurrent chemo versus sequential, with Turisi versus standard 45 grays, with early concurrent versus delayed concurrent, and with use of prophylactic cranial irradiation, which in limited stage led to, again, increase in 5% of overall survival. Now the CONVERT study, the very important study that changed our way of thinking in limited disease, properly staged small cell lung cancer, run by Professor Fenn and many colleagues from different groups, and investigating properly 45 grays, 30 fractions versus conventional 66 grays in 33 fractions, with most of patients treated with PCI afterwards. You can see here the baseline characteristics of the patients. And importantly, about half of these patients were staged with PET-CT, and half of these patients didn't have PET-CT staging. You can see most patients with stage 2, stage 3 disease, typically the population of small cell lung cancer patients, with overall survival not different between arms, hint of slightly better outcome for patients treated with twice daily radiotherapy. But what is most important, the 5-year survival figure here with proper staging and dedicated treatment delivery, which was more or less involved field with the debate of what to do with the in-between nodal stations, the 5-year survival of more than 30 years, 30%, substantial advantage to historical control. More importantly, however, BID treatment with radiotherapy seemed to be more harmful, especially in terms of esophagitis and pneumonitis. It's not the case according to the CONVERT study. The rates of these toxicities, esophagitis and pneumonitis, is rather acceptable. Pneumonitis exactly the same, esophagitis exactly the same. Pneumonitis very low with modern radiotherapy, esophagitis grade 3 to 5, only 18%, which is something we can really accept. So that is also an important information. Late toxicity, not different, maybe some more tendency for esophagitis with once daily schedule, but that's really not significant. So CONVERT BID or once daily is currently the standard of care. Another study which was looking for mediastinal irradiation in extensive disease, small cell lung cancer, which is the CREST study, showed trend toward better survival in patients treated this way. However, we don't really do it routinely for every patient. Maybe the patients with mediastinal predominant disease will consider that. So what can we expect in the future? I think the future progress in small cell lung cancer will likely come from novel systemic therapies, and we have reached some plateau with radiotherapy. The higher dose of radiotherapy for mediastinum, given BID, for example, seems to produce some small benefit. However, we are not using that routinely. This progress will come from addition of immunotherapy. I agree that the benefit for Atezo or Durva is not really great. It's 2 months prolongation, 3 months prolongation of median survival. We need to have something more. From my perspective, this is 1/5 of patients who benefit for the long term, and this is leading to plateau on the survival curve, where our 4 patients out of 5 will not benefit. So the question really is how to identify those patients. The Adriatic study, we'll hear about it. It's a great benefit for consolidation Durva with limited disease, small cell lung cancer, as an example, how we can further improve from median survival of CONVERT to better results. And novel agents, I was working with tarlatamab, which is a bispecific antibody linking small cell lung cancer cells with DLL3 antigen and lymphocytes, and thus exploring the direct communication between those cells and not MHC1 class dependent, which is often lacking in small cell cytotoxicity, which is in my eyes an example of the study that paves the way for further better systemic approaches. In our phase 1 study, we have seen overall survival of pretreated patients of 14 months, which is something we typically see in extensive disease first-line setting. So this is the way forward. With that, I would like to stop with giving you some recommended reading. If there are any residents in the audience, for example, radiation therapy for small cell lung cancer, an ESTRO practice guideline that is freely available in the internet, already quoted Marie Dingemann's ESMO guidelines on small cell lung cancer with radiotherapy component. I would like to thank you, Professor Corinne Verfin, who is a long-term friend of mine, who kindly provided slides on CONVERT. I would like still to mention that effective anti-tobacco campaign is very needed in our countries with high incidence, also from the perspective of small cell lung cancer, and give you a postcard of my new hospital in Gdańsk, where we proudly serve also for the number of Ukrainian cancer patients that are in need for effective treatment these difficult days. Thank you for your attention.
Thank you very much, Professor Dziaduszko. Now the person with all the answers for small cell lung cancer, Katja Mohorčić. My pleasure.
Thank you for staying with me. I'll just try to keep you alive and not asleep during the last session. And sorry, I don't have superpowers to cover it all what they mentioned. Okay. I will focus my talk on advances in systemic treatment in small cell lung cancer. And I will focus my talk on some targeted treatments that are coming up, so some new kids on the block that are coming. And here is the first slide. I think it's quite important. Those targeted agents, targets that can be either on the surface of the cell or on the inside the cell, so actually in the nucleus. On the surface of the cells are some markers or some proteins that you already know, so the targets can be immune targets like PD-L1, then neuroendocrine signaling targets like DLL3, and receptor tyrosine kinases that mainly are responsible for angiogenesis like VEGFR, FGFR, and all others. But there are even more targets inside the cell, and target things like epigenetic regulators, DNA damage repair proteins, apoptotic regulators, cell cycle checkpoints, and transcriptional factors. But in the terms of immunotherapy, I can bypass Adriatic trial, which is actually the great improvement showed a great improvement in survival, but in limited stage small cell lung cancer. And the trial, phase 3 trial, was presented in this year's ASCO. This is the design of the trial. So it's in patients with limited disease who were available to get, who had the stage to get the chemoradiation and actually completed it, and then were randomized to receive either 2 years of durvalumab or placebo. And the primary endpoint was overall survival apart from progression-free survival. So it's like Pacific trial, but in small cells. So maybe you will move from Pacific to Adriatic Sea after this talk.
It's a sea after all.
It's a sea after all, and a little bit closer. Here are the survival curves, and you can see that they separate really nicely. So the right one, on the right one, we have got overall survival. It gained, so the treatment with durvalumab actually gained 2 years survival for patients. It's really, really long time. And in 3 years' time, about 10% more patients are alive when treated with durvalumab. So they concluded that it will be a new standard of care for patients with limited stage who have not progressed after chemoradiation. And I'm happy to hear from Astra that we will get, in Slovenia at least, compassionate use program in about 2 weeks. So we'll start treating the patients with this protocol. And of course, we cannot go past toxicity of this trial. It has quite a nice profile of toxicity profile with only a few more pneumonitis, but I think that we, as our pulmonology clinic in the first place, we will be quite are able to manage them too. Okay, now we'll start with the more targeted agents. First are DNA damage repair proteins, like olaparib, like PARP inhibitors, VEE1 inhibitors, and all others. Actually, you know, the small cell lung cancer has a lot of mutations, and that causes DNA damage, and that is why they also express high levels of DDR proteins to try to repair these damages, of course. And when we give inhibitors like PARP inhibitors, maybe we can stop this damage repair and cause the cell to die earlier. And the first trial, it was a phase 2 trial with temozolomide that was combined with velaparib or placebo. It was phase 2 trial, and the primary endpoint was PFS, but this trial was completely negative. But then a post hoc exploratory analysis showed that patients who had SLFN11 expression positive had median overall survival improved for about 3 months. And it's actually a marker for DNA damage repair and marker for protein expression of inflammatory genes. And now all the trials that are going on actually choose patients, those patients who are SLFN11 positive. Another trial without the selection of patients also showed that temozolomide and olaparib combination showed a really great, about 50% overall response rate with the combination is phase 1/2 trial in platinum-sensitive patients. The other target is target for transcription inhibition. You have probably heard about lurbinectedin, which is actually an alkylating agent, and it's the only drug apart from topotecan which gained accelerated approval through FDA and also orphan drug status by EMA, and it's called Zepzelca, really nice name. It actually blocks polymerase II, which tries to do the transcription of the DNA, and that causes the cell to die. And you see in the phase 2 trial, basket trial, a great response rates of almost 50%, so 45% in platinum-sensitive patients. Then lurbinectedin was also explored in phase 3 trial. It's an Atlantis trial, but they combined it with chemotherapy. They chose doxorubicin, but they chose lurbinectedin a little bit lower dose. In the phase 2, it was 3.2 milligrams per kg, and here is 2 milligrams per kg. And you see, it was compared to standard of care chemo, topotecan or COW. You see the same median overall survival data, the same months, the same length of survival, but a little less toxicity. As you know, topotecan we don't like very much due to quite high toxicity. And now there are future trials going on with lurbinectedin. One combination also shows promising activity. It's the combination with irinotecan with 62% of overall response rate. And we have got a trial, a Lagoon phase 3 trial, which actually explores in 3 arms, lubri in 1 arm, then lubri and irinotecan in the 2nd arm, compared to the standard chemotherapy of choice. There are also data that lubri can be combined with immunotherapy, working as an immunomodulatory agent. There is one nice trial which actually tries to find out if lubri and atezolizumab as maintenance treatment in extended stage small cell is better than just atezo alone. Okay, the third is the target is neuroendocrine markers for neuroendocrine differentiation. Rafal already showed you the delta-like legend. It's expressed on the surface of the tumor cells, and this protein expression is actually induced by key transcriptor factor ASCL1, and it's expressed only in neuroendocrine cells, and small cell lung cancer have more than 85% of cells actually express DLL3, but it's not expressed in the normal tissue. That's why it makes it quite a good target for targeted agents. And Rafal also, I think, no, you have mentioned tarlatamab, but not ROA-T. ROA-T is like ADC that combines anti-DLL3 on one side and PBD-toxin on other side. And we have been really looking forward for positive results of phase 3 TAHOE trial, but unfortunately the trial was completely negative for primary endpoints, overall survival and progression-free survival, with a lot of toxicity with ROA-T, with a lot of serosal infusions, photosensitivity reactions, peripheral edema, and that's why AbbVie had to stop the evolution of the drug. And one of the criticism was that maybe it was really too fast to go from phase 1 to phase 3. You see in only 5 years all 3 phases. So this story is unfortunately closed. But we have another drug that has been mentioned, and it's more promising. It's a bispecific T-cell engager called tarlatamab that actually connects T cells with anti-CD3 antibody to a small cell lung cancer that with anti-DLL3 antibody. And Delphi-A phase 1 trial was quite encouraging. You have heard about that, and also phase 2 trial that was presented in last year's ASCO. Delphi 301 trial, which compared 10 milligrams of tarlatamab to 100 milligrams every 2 weeks in in patients who were pre-treated with chemo and IC and showed a better results for the lower dose. I'm really happy to see those results when they're more positive in lower dose, like here, with median overall survival of 14 months. But we have to be aware of possible quite serious adverse events like CRS, so cytokine release syndromes, and ICANS, which means immune effector cell-associated neurotoxicity syndrome, which was really important in higher dose, but fortunately is not so important in the lower dose. But here I think that before starting using that in the regular clinical practice, at least in our center, we will have to find out how to use it and how to take care of adverse events and to educate our people, our colleagues in ICUs. And to continue with receptor tyrosine kinases, which can be targets on the surface of the cell. There are some multiple kinase inhibitors like alatinib, which actually targets VEGFR, FGFR, PDGFR, and also c-KIT. And it was studied in the third or further lines of treatment of small cell lung cancer. So in completely patients who had no choice of other treatment. Actually, the drug is even approved in China. And you see quite impressive progression-free survival and overall survival hazard ratios. And that's why these and other multi-kinase inhibitors are studied in the very different combinations in different studies. We'll have to wait for the results. And for the other, so and category of other, I chose just another ADC that has data from the TROPiCS-03 phase 2 basket trial and was also presented in last year's ESMO. It's actually cetuximab with topoisomerase inhibitor govitecan on the other hand. Sorry, it's really hard to pronounce it. And it's a TROP2, anti-TROP2 on the one hand. And it showed a really great overall objective response rate of almost 40%, but with quite a lot of grade 3 and more adverse events, as Urška showed you before. So we are looking forward for phase 3 results of phase 3 trials. And what now? We have a lot of choices, but still what we miss targeted, so we miss the choice. How will we choose the drug if we have no true biomarkers to match with the right drug? Maybe the answer lies in the subtypes of small cell lung cancer, which were actually discovered back in 2019 and presented to us, and where patients were subgrouped based on 4 different global transcriptional regulators, dividing patients to 4 subgroups, A, N, P, and I. And I is the one who lacks the regulators of other regulators. But we know that inflamed subtype is the one in which immunotherapy actually works. But in the future, in the near future, we hope that we will be able to identify patients and to subgroup them in one of those groups and then choose the right drug for the right patient. So here I will conclude. So we are sure that consolidation Durva will become a new standard of care for patients with limited stage small cell lung cancer who have not progressed after chemoradiotherapy. A DRETIC trial showed us. And regarding new treatment options, I think that there are several agents who are promising, but the most promising are ADCs and BiTEs, but we need to wait for the results in phase 3 trials. And improvements in understanding small cell lung cancer biology and different subtypes, and to predict biomarkers and better trial designs will probably move the field forward, and I think the sun is shining on small cell. Thank you very much for your attention.
See, I told you she has all the answers. Now, if you could all join us, please, for a discussion. So, Jelena, Rafal, Katja. And Igor, sorry. Do I have to stand up? Any questions from the audience? Yes, please.
My question is to Rafal as he takes a seat. optimal radiation for small cell lung cancer. Question 1A and 1B. 1A, is there a role for hippocampal sparing if we're considering PCI?
Excellent point. Actually, the conflicting results of studies on that topic regarding the benefit in terms of neurocognitive testing after patients are treated with hippocampal sparing technology, which is not so difficult in real practice, however time-consuming. We have stopped doing that, actually. We think there may be potential small benefit, but not to the extent to implement that in routine practice.
And question 1B, in patients with brain metastases, what is the role of SRS versus whole brain?
Well, actually, that depends on the situation. If this is a patient treated with PCI and has 2 brain mets, I would go for SRS without hesitation because you have no other option. Repeat whole brain radiotherapy is not a good thing. You can make a life of your patient miserable with that. So in the absence of any other systemic ways to approach brain mets, I would use SRS. The question is, for especially difficult question, is what to do in those patients who have few brain mets after they had not been treated with PCI, as it tends to be more common in elderly patients with comorbidities. That really depends on the situation, whether it's doable in terms of number, but most importantly, volume of these brain mets. I would still tend to use whole brain radiotherapy in most of these patients. However, I would use stereotactic treatment for those with long-term period between initial treatment and few brain mets and brain mets with small volume in my practice. But there are no convincing data what to do really. And the beauty of tarlatamab study is that there were many patients with treated brain mets with overall survival of 14 months. It gives some hope that you can target this population with systemic treatment. How this works in the brain after SBRT, for example, I don't know, but at least I have one patient who is 4 years out with multiple brain mets treated with SBRT because he had an option to go for tarlatamab. He's still doing fine. His physician, he's operating. A miracle.
Hi, everybody. I'm Professor Nikitovic, radiation oncologist. I just want to give a comment, if you agree. When you speak about whole brain irradiation, we call it prophylactic, but dose of 25 grays in 10 fraction is actually very high dose. That's one thing. And the other thing is that 2.5 gray daily definitely in long run will give cognitive late effects. There is no doubt about that. So the dose of 2.5 grays for whole brain is quite a large dose. I think that they started these trials because they think that they were not expected that their patients will live for long term. And that's the only explanation. I'm working with the patients with brain tumors a lot. And for children, we always give 1.8, 1.6, never higher. Also, there is the question of hippocampus that also I completely agree with you. We were very excited. We started to do that, but there is no quite improvement. So individually, if we have patients that we accept for some reason in good condition, even young age, to live maybe we have better results of survival, maybe we can go with the MRI checking and surveillance, as you said. So I have to check for my colleagues. 2.5 gray is a huge grade for whole brain. And they will all have cognitive function. There's no doubt about that. I think from my experience of 30 years working with brain tumors patients.
I do agree that these are excellent points. The only data that we have are with 2.5 gray per fraction in randomized long-term trials, and we don't know whether we can suppress with PCI to the same extent with, say, 1.8 gray per fraction. But you are right. the leukoencephalopathy that we observed 2 years out on MRIs is telling you that a lot has happened to the brain. And the problem becomes significant because these patients live longer than before. And that's the interplay between PCI and systemic therapy is now making this story another question for the future. Say in the Adriatic study, when we see that median survival is now 50 months, should you still be delivering whole brain PCI with 25/10 fractions? That is a very debatable question. On the other hand, we would like not to see brain relapses in those patients, which is another story which is also impacting their daily living. So it's a problem.
I just want to say, my colleague, neurosurgeons with who I'm working for 30 years, just from clinical practice, no trial, they don't like those higher than 2 grays on whole. They see what you said, neuroencephalopathy, very distinguished. So some of my colleagues, and we were arguing in our Congress for brain tumors, for glioblastoma, which is trial 60 gray and 30 fractions 2 gray, they asked me, please, Marina, give 1.8, because when they see the children, I can't give that. We discuss on the there is a protocol everywhere that we give 60 or 30. But I do really believe that that the reason is they did not expect this patient to live long, and then something should be done about that.
I agree dose per fraction matters, but also the final dose of radiotherapy is also an open question, and as more effective systemic therapies will shift this question maybe out of the equation one day. Thank you for your excellent comment.
Thank you very much. One more question for all of us here. Is actually immunophenotyping ready to live in a real-world clinical practice? And how? Will it change anything in our approach to the treatment of lung cancer, small cell lung cancer? Igor?
I mean, not at the moment, but I am aware that some clinical trials are being designed taking into account those 4 subtypes. So hopefully we'll have some answers in the medium term, but at the moment we cannot use that in our clinical practice. And when it comes to tarlatamab, we know that DLL3 is overexpressed in most patients, so I don't think that we are going to select by biomarkers in the near future. We will give tarlatamab to everybody who is fit enough.
So we are still sitting even without the surrogate of a biomarker. Yeah. So that would be a surrogate of biomarker.
Yeah, I would agree, and we just have to remember that the subtypes are being done using RNA sequencing, which is very complicated. I am aware that they can be done with using immunohistochemistry, but I think RNA sequencing is going to be a very difficult thing to implement throughout the world. So yeah, I think we're still lacking a biomarker.
Even the SWAFL11 story seems quite disappointing with the latest results presented. So.
Yeah, just to comment on that. I mean, I think the RNA issue is problematic. There are IHCs that people use, but actually, if you look at some of the Spanish data, the tumors are heterogeneous, and the dynamic, as you'd expect for a transcription factor, you give us therapy and then you rebiopsy them, and they've changed their subtype again, right? So I can't see how this data is going to be useful from a clinical trial selection viewpoint. I don't see we're going to be using any biomarker selection anytime soon in small cell personally.
Thank you very much. For the sake of time, I think we're going to approach the closing of the session. It was beautiful to have you all here. I would really love to ask the presenters and the moderators to come on the stage so that we can take a picture together. For the rest of you in the audience, I will switch to Serbian. Bilo bi lepo da ostanete da se družite sa nama i odmah posle masterklasa Sledi mali deep dive u imunoterapiju karcinoma pluća sa rasklimavanjem po svim temama. Posle toga idemo u EGFR revoluciju sa AstraZenecom, posle ručka, a onda ćemo na kraju da krunišemo nekog, pa ostanite i na ovim simpozijumima, bit će zanimljivo. For the moderators and for the speakers, please can you get up on the stage? Thank you. Yeah. As long as Mr. Trump is actually Dutch here. I would keep the sumac. I'll stick to it. But I think we're all fine. iPhone. Please use the iPhone. Okay, thank you. Thank you. It was a great pleasure having you here. I pretty much enjoyed. I hope we'll see each other very soon. Thank you. Thank you so much. It was great. It was really great. Thank you. Nice to meet you. Nice to meet you, and I hope to see you soon. Ja moram počinjati simpozijum. Ne znam. Da. Ove godine nazvali Futurospection, ja bih samo molio slajdove da ih vidim na screenu. Da, još uvek se ne vide, sad ćemo vidjeti da li... Evo ga, tu smo. Dakle, negde idemo u novi scenariju, idemo da pričamo o imunoterapiji na razne načine, a znate da kad ja volim nešto da smislim, da to smislim na neki drugačiji način, pa ispadne provokativno, vidjet ćemo koliko ćemo zapravo uspeti u tome. Moje veliko zadovoljstvo da vam najavim moje današnje saradnike u ovom Rošovom simpozijumu, doktorku Nataliju Samardžić i doktora Davorina Radosavljevića. Videli ste da baš izgledaju onako fancy ovi naslovi, futurospekcija, nove uloge i terapija po meri pacijenta. Vidjet ćete zapravo o čemu se radi. A ja ću početi sa onim najstrašnijim i zapravo zašto smo odlučili i ja i moji saradnici i Roš da okrenemo igricu na opačke i da probamo da zapravo vidimo šta nam se to dešava u stvarnom svetu. Kad pogledamo ove brojeve, u stvarnom svetu imamo 20 miliona karcinoma godišnje. Imamo 9,7 miliona Srbiju i po koja umre godišnje. Dakle, Srbija i po umire godišnje. Imamo 13 miliona novo otkrivenih. 2,4 miliona karcinoma pluća, dakle, cela Vojvodina oboli od karcinoma pluća u jednoj godini. 2,3 miliona karcinom dojke takođe, 1,8 je kolorektum. Pogledajte distribuciju po stadijumima, ja neću ulaziti u nju, ali vrlo je jasno kada se džumle stave različiti karcinomi, da statistika može da se ispriča i reprezentuje na sasvim jedan drugačiji način. I sada, ono gde ja volim uvek da zahvalim Rošu kao inovativnoj kompaniji koja uspeva da isprati čak i moje ponekad malo sulude ideje, priznajem, jeste zapravo u tome da su spremni da koračaju u cilju zadovoljavanja ovih nezadovoljenih potreba. A mi definitivno, bez obzira na sve imunoterapije, skrininge, sve je fancy, sve je super, imamo i dalje karcinom koji je vodeći uzrok smrti u svetu. Dakle, vodeći uzrok smrti uzrokovane malignitetima su definitivno pluća, kao jedini karcinom vitalnog organa. Sa druge strane, dakle, čuli ste sad kroz ovaj masterclass užasno kompleksnu bolest. Mi zapravo ne znamo s kojim se sve tipovima borimo. Ako podvučete crtu šta smo sve na masterclassu pričali, ima ih 100.000 i apsolutno nismo sigurni ni u šta, ni kod jednog, osim u neke stvari koje ćete čuti malo kasnije. Ono što zapravo negde stalno guramo pod tepih jeste to opterećenje koje karcinom pluća predstavlja i za društvo i za porodicu. I u kontekstu novca koji treba izdvojiti i u kontekstu svih onih nenaplativih troškova koji se provlače uokolo. Upravo zato vam najavljujem da će kraj biti priča o supkutanoj formulaciji atezolizumaba i ceo sledeći simpozijum će biti posvećen upravo tome. I na kraju, nemamo palijativca ovde, ali zaboravljamo to šta ova dijagnoza znači za pacijenta. I konačno, ono gde i moj tim i ja i moji današnji sagovornici stoje sa Rošom, to je upravo, znači, ovo. To su ti stubovi inovacije koji su neophodni da krenemo napred. Mi bez efikasnije terapije i boljih prediktivnih markera, kao što ste malo prečuli, apsolutno ne možemo dalje da kreiramo terapiju onako kako treba. Dakle, da li će to biti biomarkeri u SCLC-u, da li će to biti dalje NGS-iranje EGFR-a, pa traženje šta je insercija, šta je delecija, šta je mutacija, da li ćemo se spustiti u rani stadijum, pa ćemo svakom ranom stadijumu sve ovo da radimo, ili ćemo definitivno da izučavamo mehanizme rezistencije, jer bez NGS-a, bez comprehensive genome sequencinga, mi apsolutno nemamo šansu da znamo šta ćemo da uradimo ni sa pacijentom kom smo dali platinum-based doublet u prvoj liniji. Mi moramo da znamo šta se dešava sa njegovom genomikom i moramo imati, naravno, dostupnost te terapije ispred nas. U ovih zadnjih 2000-ih godina je užasna gužva u 16-tercu. Svi žele komad kolača. Dakle, svi se bore, svi dolaze sa novim lekovima, svi nas trpaju sa novim informacijama, a da mi prethodno uopšte nismo procesuirali sve ono što je došlo do nas u ovih nekih 10-15 godina. I ako mene pitate šta sam pričao pre 10 godina, pričao sam potpuno drugačiju priču u odnosu na ovu što pričam danas i verovatno ću za 10 godina pričati potpuno drugačiju priču. Zato moramo da pratimo inovacije i moramo stalno da unapređujemo sisteme i uskoro dolazimo u jedan vrlo veliki moment gde je opet Roche odigrao jako značajnu ulogu, ne samo sa Navify-em i sa rešenjima koje je Roche Diagnostics, ne znam da li je neko iz Roche Diagnosticsa tu, ali to je department koji nam je užasno važan, jer bez njih ne možemo da mrdnemo dalje uopšte u lečenju karcinoma bronha. To su i, znači, comprehensive genome sequencing i različiti sistemi koji su clinical decision making support. I to je taj prokleti artificial intelligence koji će na kraju ući u svaku poru društva. Tu smo mi svi vrlo srećni kada radimo sa inovativnom kompanijom takvog kalibra koja nekad i nas gurne u momentu kad mi posustanemo, a onda kad oni posustanu mi ih gurnemo u suprotnu stranu i kažemo ne, klinički razmišljate potpuno pogrešno, hajte da idemo u neku drugu stranu. Ja neću prolaziti kroz sve ovo, jer sve ovo vi znate. Dakle, i ono što se dešava u dijagnostici, i ono što se dešava u biomarkerima, i ono što se dešava u ranom stadijumu, i ono što se dešava u kasnim stadijumima, i naročito ono što se dešava u praćenju pacijenata. Jer mi smo napravili deep dive u rani stadijum. Mi smo ušli i sa alektinibom u rani stadijum, mi ulazimo i sa entrektinibom u rani stadijum, ulazimo sa mnogim lekovima u rani stadijum. Dakle, širimo se na sve strane i na taj način ćemo imati toliku količinu informacija da više nećemo znati zapravo šta radimo. A šta se dešava? Jelena je izašla, ovo je jedan od njenih omiljenih slajdova i ja uvek volim kad je on tu. Šta se dešava ako pacijentu koji je driver pozitivan zapravo ne damo driver pozitivnu terapiju, pa dešava se ova razlika između plave i crvene crte. Dešava se ogromna smrtnost onih pacijenata koji su bili driver pozitivni, a koji nisu dobili driver drajvere. I sad zamislite bez NGS-a svaki dan u našoj kliničkoj praksi koliko mi pacijenata ne znamo da su NTRK pozitivni, RET pozitivni, ROS1 fuzionisani, da imaju exon 20 inserciju. Nije to tako mali broj ove pite. Ključ je u ovom donjem delu bez onkogenih pokretača, jer tih 40% su definitivno kandidati za imunoterapiju. Svi ovi gore koji imaju drajvere definitivno nisu kandidati za imunoterapiju. I mi ćemo se danas podeliti u razgovoru, i Davorin i Nata i ja, i možda Davorina i Nato da sednete na binu ako želite, ako ne želite možete da uzmete mikrofone i odavde da pričate jer se bolje vidi ekran, ali znači pričat ćemo o dve stvari. Pričat ćemo o monoterapiji kod overexpresora, a znamo da nam je tu definitivno atezolizumab jedan od glavnih igrača, potpuno komplementaran sa svim ostalim igračima koji su u ovoj grupi pacijenata, i znamo da treba da tražimo i taj neki bezbedonosni profil i iskustva i zaključke i u onoj grupi pacijenata koji su 1 do 49 i to je popularna četvorostruka terapija oko koje je napravljena potpuno nebitna fama, jer je bevacizumab lek koji je tu promenuo igricu, ne atezolizumab. Bevacizumab je taj koji je potpuno prekrenuo igricu, a bevacizumab je lek koji je star 25-30 godina. Dakle, to uopšte nije neki potpuno inovativni lek. Kako je bevacizumab promenuo igricu? Stalno se priča bevacizumab anti-VEGF. Da, ja se slažem, ali bevacizumab pored anti-VEGF-a ima mnogo važnije uloge u imunoterapiji. Atezo je poznat. Atezo je anti-PDL1, blokirat će PDL1, iako je taj PDL1 Davorin zna i svi moji znaju moje mišljenje o PDL1, ja ga neću ponovo izreći javno, izreće ga neko drugi. Ali za 10 godina ga neće ni biti. Znači, sa ovom kombinacijom mi smo zapravo pokrili ceo onaj imuni krug koji vam stalno od 1 do 7 pričamo. Znači, sa paklikarbom smo razbili tumor, oslobodili smo antigene. Antigeni su naoružali dendritične ćelije, otišle su u limfne čvorove i praktično, znači, kad su ti limfociti koji su sazreli izašli napolje, anti-PDL1 je blokirao i sprečio deaktivaciju tih limfocita i ti limfociti dalje idu, ubijaju zapravo ćelije. A bevacizumab radi anti-IGF, sprečava angiogenezu, ali drastično menja i imunni sistem. I molim vas, uzmite svoje mobilne telefone. Molim vas, skenirajte QR kodove. Znam da čitate B92, znam da čitate poruke, ali ajde, iskulirajte, znači, skenirajte QR kod i da probamo da damo odgovor na pitanje koliko je ljudi u svetu lečeno pacijenata bevacizumabom. 85.000, 1,5 milion ili 4,5 miliona. I, znači, dajemo vam sad tu neko vreme da skenirate, da odglasate. Interesuje me šta zapravo mislite o bevacizumabu. Dobro, imamo za sad 15, ima nas više u prostoriji, ali okej. Tu smo mrtva trka između 1,5 miliona i 4,5 miliona, 85.000 je palo u vodu. I okej, stop, nećemo da gubimo vreme, mrtva trka, znači malo je prešao 1,5 milion u odnosu na 4,5 miliona. Okej, možete mi pustiti sledeći slajd, izađite iz ovog, momci. Znači, preko 4,5 miliona. Dakle, bili smo blizu i bili smo u pravu, barem 50% nas. Skoro 40.000 je lečeno unutar kliničkih studija za 13 indikacije i pogledajte koji: kolorektum, ovarijum, pluća, bubreg, dojka, cerviks, mozak, jetra. Dakle, stari lek koji ima mnogo funkcija. Ja vam neću pričati o ovom anti-VEGF-u, ovo je stvar koju znaju i ptice na grani. Ono što je važno, da je bevacizumab blokadom VEGF-a ostvario ne samo blokadu angiogeneze, već stimuliše aktivnost imunosupresora, smanjuje kretanje i preživljavanje negde aktiviranih T ćelija, slabi sazrevanje funkcionalno, ovo radi VEGF, a ovo inhibira, znači bevacizumab, i bevacizumab sprečava aberantnu hematopoezu. Dakle, on je taj koji na kraju dana uspeva da na neki način promeni kurs bolesti koja je već inhibirana imunoterapijom, a već tretirana i hemioterapijom. I zato je četvorostruka kombinacija jedna potpuno bezbedna, je jedna izuzetno efikasna kombinacija. Vidjet ćete za kakve lekove, pošto je Natalija definitivno moj oficir za stvarne životne podatke, ona će ih ispričati. Ja ću samo, znači, ovde kratko da vam highlightujem da je, dakle, 58% objektivni response rate, znači, unutar Empowera 150, a kada se poredimo sa konkurencijom, da je opet taj objektivni response rate dosta visok. Naco, upričak se ja jako. Hajde, iskomentariši mi, molim te, kako smo selektovali pacijente i kakva su tvoja iskustva?
Hvala, dragi poštovani, i na najavi i na ovako divnom prisustvu brojnih kolega. Vidim ovde sve poznata, draga lica, saradnike i ovako više se osjećam toliko mirno i slobodno kao da smo na jednom proširenom konzilijumu, pa ćemo malo samo prodiskutovati i razmeniti prva saznanja o lekovima i ulasku na novu pozitivnu listu koju smo toliko dugo čekali. Sada nama je danas fokus da popričamo o primjeni atezolizumaba u više indikacija, pri čemu počinjemo sa možda i najkompleksnijom, to je za pacijente koji imaju PDL1 ekspresiju između 1 i 49% i uz potpuno i jasno objašnjenje našeg ovde mentora danas, Bojana, jasno je koliko je po svojoj prirodi i kompleksna ova kombinacija lekova, pa samim tim jasno je da i sama ta grupa pacijenata koja bi bila u toj kandidaturi za primjenu ove četvorne terapije mora biti svakako kompleksna. Tako su se pokazala i naša prva iskustva, jer ove lekove koristimo od početka juna ove godine. Dakle, što se tiče samog starosne dobi, vidite da je to grupa pacijenata vrlo šarena od 49 do 76 godina. Uključeno ukupno do sada 11 pacijenata i to su pacijenti koji su imali raznorodna metastatska mesta. To su bile CNS metastaze, jetra, pluća, pleura, kosti. To je bilo najčešće.
Znači nisi se bojala ni CNS-a?
Apsolutno ne, a i kako bismo se plašili, jer to su pacijenti sa najgorim prognostičkim faktorom i upravo ta naša ciljna grupa koja je zaslužila da dobije nešto u svom životu u smislu efikasnosti, a i bezbednosti lečenja.
A komorbiditeti?
Komorbiditeti. Prvo, kada smo počeli da razmatramo sve opcije, faktore rizika i tako dalje, možda smo bili malo u početku uplašeni pod znacima navoda limitirajućim faktorima koje je ovde bevacizumab doneo sa sobom. Međutim, vremenom, a i kroz priču ćemo to prodiskutovati, ti strahovi su skoro pa nestali, ali da kažemo sigurno minimizirani, samo traže veću predostrožnost, tako da je i u tom pogledu naša grupa pacijenata bila vrlo raznorodna, tako da upravo je bilo najviše pacijenata sa arterijskom hipertenzijom, koja je jedan od vodećih faktora rizika za uključivanje. Međutim, ukoliko je hipertenzija u kontrolisanim uslovima, apsolutno nas ne zastrašuje i to je i sadašnje iskustvo i pokazalo.
Jasno. Davorine, da li je negde iz tvog aspekta kao čoveka sa velikim iskustvom jedna ovakva distribucija potpuno logična i normalna?
Meni jeste, mi imamo sa mnogo tumorskih tipova iskustvo.
Upravo zato te i pitam.
Sa lekom. Tako da ja moram reći da je bevacizumab jedan od lekova s kojim imamo najmanje problema, apsolutno u više nego 15-godišnjem davanju, samo ako se pridržavamo elementarnih pravila igre što se tiče hipertenzije i proteinurije i ako savladamo, dakle, apsolutnu kontraindikaciju, to je akutno sveže krvarenje, dakle, bilo cerebrobi, bilo kardiovaskularnih event u poslednjih nekoliko meseci.
Jasno. I infiltracija velikih krvnih sudova, za što nam treba dobar radiolog, koji će, znači, reći ima ili nema, ali slažeš se, sećaš se onog nekog našeg prvog advisory boarda i kaverne, dakle da kaverna nema nikakve veze sa kontraindikacijama. Dakle, jedino akutno krvarenje i kontakt sa krvnim sudom. Naco, tvoj prvi pacijent.
I ovome bih još samo dodala, rekli smo koje su apsolutne kontraindikacije, ali ja bih ovde samo, Bojane, dodala koja je apsolutna indikacija pod znacima navoda. Eko performance status. To je ono što nas je opredeljivalo u ovoj složenoj priči. I mi ćemo začas proći kroz nekoliko primjera pacijenata kojima smo dodelili četvornu terapiju. Evo prvog pacijenta, to je pacijent starosne dobi 48 godina, adenokarcinom, pušač, PDL1 ekspresije 1%. Mali tumor u...
Junaco ko ja.
Da, zašto uopšte to pominjemo i poredimo, Bojane, nema potrebe da razmišljamo sad na taj način. Ali, dakle, ovaj pacijent je u samom grudnom košu imao jako mali tumor, to je tumor do 2 cm u srednjem režnju, i mediastinalna limfadenopatija sa N2B subdivizijom. Međutim, vidite, to je izuzetno agresivna bolest, rasprostranjena, multiple metastaze u jetri, levom nadbubregu, peritonalni implanti, paraspinalni mišići, takođe zahvaćeni kosti. Dakle, ovde nam je opredeljujući faktor bila izuzetna agresivnost bolesti, metastatska bolest, veliko tumorsko opterećenje, a kao što vidite, faktor rizika kao što je hipertenzija ovde nije bila za nas limitirajući faktor. Sledeći pacijent je takođe bio muškarac, 66 godina star. On u svojoj, to je takođe dokazan adenokarcinom pluća, PDL1 ekspresija 40%, bivši pušač. Pacijent u svojoj anemnezi ima hroničnu obstrukcijsku bolest, ali ozbiljan bulozni emfizem pluća, tako da su bule bile prisutno i u levom i u desnom pluću i to čak do 8 cm. Sam tumor je bio lociran u levom gornjem režnju i on je u obliku mufa obuhvatao i lobarnu granu plućne arterije. Uz konsultaciju sa radiologom naše klinike, bez koga praktično ne donosimo odluke, nego samo upravo ovako u ovom multidisciplinarnom pristupu, proverili smo da li postoji faktor infiltracije krvnog suda. Kada smo dobili negativan odgovor, pacijentu je uključena terapija.
Znači, kontakt je sasvim ok, infiltracija ne.
Velikog krvnog suda, da. I treći pacijent je bila ženskog pola, 74 godine stara pacijentkinja, takođe dokazan adenokarcinom pluća. Njoj je karcinom bio veličine do 6 cm, najdužeg dijametra u desnom donjem režnju i ovde takođe smo imali situaciju da je tumor obuhvatao bronh za posteriorni segment, ali imali smo i infiltraciju segmentnih grana plućne arterije. Takođe smo se konsultovali sa našom koleginicom radiologom i s obzirom da infiltracija nije se odnosila na velike krvne sudove, mi smo se opredelili da ovoj pacijentkinji uključimo terapiju. I mogu vam reći da je ovo jedna od pacijentkinja, jer, ponavljam, iskustva su sasvim mlada i sveža. Od tih 11 pacijenata, 5 pacijenata je u ovom trenutku doživelo kontrolu bolesti skenerom grudnog koša i upravo ovo je jedna od tih pacijenata koja je pokazala odličan odgovor na terapiju, odnosno parcijalnu regresiju. I da ne bude samo bajkovita priča, ovde moram da napomenem da je ova pacijentkinja pred sam kraj, praktično pred ulazak u fazu održavanja, iskusila i jedan hematotoksični efekat lečenja, a to je bila anemija koju smo ipak morali ovih dana da korigujemo transfuzijom i leukopenija. Tako da Ako sumiramo ovu priču koja je zaista na početku, ali vrlo obećavajućom na početku, svi pacijenti kojima smo sproveli kontrole do sada postigle su kontrolu bolesti. Dakle, 3 pacijenta parcijalni i 2 stabilnu bolest. Nijedan pacijent nije progredirao, niti je i kod njih isključen, niti je bilo smrtnih ishoda do sada.
Naco, s obzirom da smo se i ekipa iz Roša i ja namučili da iz tvojih tabela koje si nam dala, i hvala ti što si nam dala real world data tabele, znači namuči smo se jako da izvučemo te podatke i da ih prikažemo grafički i da ih stavimo ovde u kontekst. Hajde malo, koji su sad to po tebi, znači ti si definitivno videla najveći broj pacijenata u odnosu na nas, ni mi, ja mislim da Daliborka nismo imali toliko pacijenata, slično, znači da sledeći put sprema Daliborka sa svojom tabelicom, to će mi biti lakše da ušminkam. Koji su to najčešći neželjeni efekti bili tokom indukcione terapije? Sad prelazimo u taj fancy terminološki indukciona faza, pa ne znam sve to, faza održavanja, znači to smo sve prekopirali od dojke, ali dobro, aj šta sad mislim.
Od nekoga moram učiti.
Tako je, šta si sve ovde videla najčešće?
Pa, Bojane, ja moram možda malo da te razočaram, ali nisam videla ništa što već nije u praksi analizirano i u studijskim protokolima. Odnosno, pokazalo se da u indukcionoj fazi najčešći neželjeni efekti su upravo i vezani za praktično hemoterapijski platinski dublet. I to je alopecija, mučnina, nagon na povrećenje, umor, malaksalost, pa i anemija, a može da se desi i ponekad tečna stolica. Međutim, kao što vidite iz ovih analiza studijskih, vidite da su sve te promene prisutne, međutim, lakšeg gradusa 1/2, dok to su ova tamnija polja, težak gradus je bio zaista vrlo retko prisutan. Tako da vrlo slična iskustva imamo i mi i dakle manje od 1/5 pacijenata smo nešto slično i mi iskusili.
Znači, kad budemo imali 100-tinjak, onda ćemo napraviti malo veću analizu, a za sad se zadržavamo na ovom. A šta je u fazi održavanja?
U fazi održavanja ja za sada ne mogu da pričam previše, možemo samo da pomenemo koje su iskustva u svetu, a to je da je hipertenzija ta koja se najčešće javljala kod pacijenata na ovoj četvornoj terapiji, odnosno u održavanju, a mi možemo da kažemo da zaista za sada nikad nismo imali, niti smo uočili bilo kakav skok tenzije ili hipertenzivne krize i u tom smislu.
Davorine, iz ostalih indikacija, je li ovo slično isto?
Hipertenzija koja se kontroliše pred svako davanje i koriguje lekovima preventivno i terapijski ako treba.
Znači, tu smo gde smo, 20 godina bevacizumaba, stvarno nema razloga da bežimo od četvorostruke kombinacije, osim što je time consuming i osim što traje, i kod mene u dnevnoj bolnici traje, ali to je nešto što je tako, radimo za benefit pacijenta i definitivno, znači, znamo u zaključku da kod adenokarcinoma s PDL 1 od 1 do 49, četvorostruka je zapravo terapija izbora za svakog pacijenta, osim onda kada postoje apsolutne kontraindikacije. Nekako, Davorine, mislim da si ti najpozvaniji da malo iskomentarišeš monoterapiju, preko 50% overexpresore, guideline-ove.
Monoterapija je ona kojom nas je zadivila imunoterapija, dakle, kad se pojavila i zaista nekako to nepoverenje u visoke ekspresore ovde najmanje treba da postoji. Dakle, ESMO i NCCN kažu bez ikakve dileme sa najvišom kategorijom, preporučuju ove terapije sa ocenom 5 ESMO. Dakle, hvala. I za atezolizumab i za pembrolizumab. Za pembro imamo, dakle, 2 studije koje su obe, jedna bila isključivo za ekspresore preko 50%, to je 0,24, a u studiji 0,42 bio jako veliki procenat preko 40%, pacijenata sa preko 50%, tako da je to jedan veliki broj, apsolutno veliki broj pacijenata koji se mora uzeti u obzir i ESMO ga uzima u obzir u razmatranjima pre nego što formuliše svoje preporuke, a preporuke su, dakle, da se pembrolizumab i atezolizumab, atezol na osnovu studije Empower 110, gde je kombinovan sa hemioterapijskim, gde je dat kao mono, pardon, u terapiji, nego sam je ovde čorao pa ne vidim dobro, ali nego je dat versus hemioterapijski dublet sa pemetrexedom ili sa gemcitabinom. Dakle, kao mono u studiji 110 ili pembro kao mono imaju ukupnu ESMO ocenu za takozvanu razmeru kliničke koristi 5 i to ne može biti više jer imaju podatke i o quality of life-u. Što se tiče nekakvog poređenja ta dva leka u istoj indikaciji, mi naravno da nemamo head-to-head poređenje. Imamo jedan poster koji je napravio jedno indirektno poređenje, statistički vođeno. Među autorima je i Neil Raimund koji je bio prošle godine na našem masterklasu, dakle, nemačka grupa autora i poređena je i bezbednost i efikasnost ova dva režima i ono što je pokazano što se tiče, dakle, efikasnosti indirektne, praktično vidite da je to u granicama veoma sličnog ili istoga. Tu nema nikakve razlike, ne treba tražiti sitnice koje malo se sakriju iza ove ili one strane, dakle nule, ali to možemo reći da je studija 0.24 i Empower 110 ili 0.42 i Empower 110, praktično bez razlike u efikasnosti. Što se tiče bezbednosti, ima određenih razlika koje upućuju pre svega u odnosu na broj pacijenata koji su napustili lečenje, ali kad uzmemo sve u obzir, takođe se može reći da tu velikih razlika u safety-u nema. I u ostalom i ne očekuje se, to su lekovi slične strukture i sličnog mehanizma delovanja, gotovo istog, tako da praktično je i safety profil, jer su pacijenti za kliničke studije bili izabrani.
Znači i efikasnost i sigurnost praktično jeste.
Jeste. Praktično je bez razlike.
Pa negde i da zajednički zaključimo. Znači, kontrola bolesti i kod over ekspresora imamo 70% pacijenata koji su prošli prvu liniju i procenu efekta, imamo 16% pacijenata kod kojih je došlo do obustave, to je kod NACE i NACO bezbedonosni profil na kraju, ta neželjena dejstva koja si rekla 1 i 2, kod četvrtine pacijenata, gradusa 3, 4.
To je najčešće bio neki svrab kože, ponekad tečna stolica i tako dalje. Dakle, mi smo već spremni ušli u ovu priču jer smo prethodno imali dugogodišnje iskustvo lečenja sa drugim antitelom, tako da smo potpuno rasterećeni.
Pa potpuno je jasno da nam je zapravo Pembro otvorio put za sve ovo jer smo na konto iskustva stečenog sa jednim monoklonalnim antitelom shvatili kako ćemo ići sa drugim monoklonalnim antitelom i ovo je indikacija koja trenutno trči na listi je i potpuno egal, dakle, daje svoje rezultate. Ono što nam jeste i nama kao kliničarima uvek zanimljivo zbog toga što na kraju dana u toj liniji, drugoj liniji nam ostaje, jel da, atezo, nemamo šta drugo da damo, pa malo volimo da damo taj atezo, ali ipak ovde moramo biti pažljivi. Imali smo jako puno pacijenata, dakle preko 200, preko člana 9 je otišlo tokom 3 godine, 350 je na RFZO indikaciji, a zapravo u osnovi ove druge linije stoji ne samo efikasnost, za koju iz ovuka znamo da je velika. Mi smo iz ovog studije, dakle iz second line-a, saznali da ćemo imati 20% pacijenata koji bez obzira na PDL ekspresiju će imati dvogodišnje i duže preživljavanje. Dakle, i to je sve okej, ali to su bili ipak super selektovani pacijenti. Dakle, ono što je jako važno jeste ovo, klinička procena samog lekara. Dakle, ovde zaista moramo da budemo fair i prema sebi i prema pacijentima i da one koji su 0,1 stavimo na second line atezolizumab, A one koji su 2, iako često to radimo, da izbegnemo, jer tim ljudima nismo pomogli. Ti su ljudi dobili 2 ciklusa i ti su ljudi umrli nakon 2 ciklusa. Ne zbog ATZOA, nego zbog toga što su bili takvog performans statusa da ništa nije moglo da im pomogne i da bi bilo bolje da su bili kući uz šoljicu čaja, kašiku supe, gledali svoju omiljenu utakmicu ili seriju, nego provodili vreme u bolnici, dugo vreme u bolnici, dobijajući atezolizumab i gubeći vreme, vučeći se po nalazima, krvnim slikama, rengenima i svem ostalom. Zato performans status 0 i 1 za drugu liniju da, ostalo gledajte negde da izbegnete.
A to je i zaključak, ako mogu ovo samo da kažem, jer ovih dana je upravo objavljen rad gde su učesnici 2 najveće kuće na našem terenu, dakle Klinika za plućne bolesti, Institut za plućne bolesti Kamenica, gde je u zaključku i iznešeno da zapravo nije opredeljujući faktor ishoda lečenja broj terapijskih linija koje su sprovedene pre primene atezolizumaba u drugoj liniji, nego upravo ECOG performance status.
Tako je, i nikako ne treba ovu situaciju mešati sa Ipsosom, koji su frontlineri. Dakle, Ipsos jeste ECOG 2, ali frontlineri, koji su, znači, ušli odmah u atezo bez prethodnog iscrpljivanja sa ostalim terapijama. Davore, iz ugla pacijenta najvažnije teme, idemo polako ka subkutanoj formulaciji.
Da, što bi rekli, povlačimo se pod kožu pacijenta.
Tako je. Ajde da zbrzimo s 10 minuta da uđemo pod kožu i damo atezo.
Jer to kaže vreme. Pa, razume se da svakoga najviše zanima efikasnost leka. Tu nemamo nikakvu dilemu nikada. Drugo je ta neželjena dejstva o kojima se mnogo priča, a iskuse ih ipak u velikoj formi samo neki pacijenti. Takođe i dužina lečenja i dužina primene terapije. A kad je reč o novim formulacijama, naravno da pre svega mislimo na subkutane formulacije koje smo vidjeli da se, dakle, daju iz više razloga, ali hajde da damo neka opšta mesta. Dakle, to je prvo potvrđivanje neinferiornosti, zato što to je jedan prilično širok pojam sa marginama koji omogućuje da se očuva efikasnost i bezbednost, imunogenost, da se proveri da li ga ima u toj formi davanja, da li je ima, takođe adekvatna doza, da li se menja doza samim subkutanim davanjem, određivanje mesta administracije leka takođe i praktično ispitivanje zadovoljstva pacijenta, odnosno da li je taj napor koji je bio učinjen zbog praktičnosti naišao na takvu istu i reakciju. Pa jeste, ima jako mnogo dobrih reakcija kod formulacija koje su već odavno subkutane, kao što je retoksima, naravno i kod malignih pacijenata i nekih drugih. Takođe, te preferencije smo videli vrlo jasno i kod pacijenata na trastozumabu i vi ste čuli da je u toku, to je bilo od juče vest, praktično decentralizacija za karcinom dojke, a ona je moguća sa olakšavanjem primene leka, a olakšavanje primene leka ide sa subkutanim davanjem i to je jedna forma koja jeste tehnička, ali sve što vodi ka jednoj boljoj distribuciji lečenja ka pacijentovom mestu stanovanja nas raduje, a i smanjuje nepotrebno opterećenje za tercijarne centre. Ono što su pacijenti govorili tom prilikom je da zaista se osjećaju sigurno, bezbedno i da cela ta terapija traje kraće, imaju manje nelagodnosti od subkutanog davanja, a to su potvrdile i analize ovih publikacija. Praktično, ishodi koji se prate su, dakle, uticaj na kvalitet života, na resurse zdravstvenog sistema, ekonomski ishodi, to je sve rađeno i ti ishodi i u časopisima, u radovima in extenso i u abstraktima govore da je to otprilike 3/4 ili 80-90% u korist subkutane primene. To je potpuno jasno. Znači, favorizovanje na nivou anegdote starog režima, to je negde na nivou 2-3%. To uvek imate i pacijente koji će uvek govoriti kontraintuitivno.
Tako je. A šta je sa ovim JCO Oncology Practice-om?
Pa, JCO Oncology Practice izražava, dakle, veliku praktičnost američkog sistema, koji ako neko zna šta je to praktično, neka pogleda američke vodiče, oni izlaze 80 puta godišnje.
NCCN pričaš.
Da, NCCN. Ali ne, ovo je Oncology Practice, ovo je za community oncology, ovo je za lekare dakle, koji su bedside i koji su za upravo ono što mi želimo, da se kvalitetni lekovi koji su jednom bili veoma inovativni, a uvek su ostali efikasni, da se približe pacijentu.
I da ja pustim jedan slajd za Dadu. Da može? Samo jaču muziku. Više vremena, manje provođenja u dnevnoj bolnici, više pričanja s pacijentom, ne moraju svi moji da budu hospitalizovani. Sad kad dođe subkutana formulacija i moja dnevna bolnica dobije novih 150 kreveta, ipak će imati malo više vremena za sve, a ja ću da sumiram i da napravim wrap-up, jer znam da ste svi gladni. Dakle, u sledećoj sezoni, pa možda i kancerološke nedelje ili nekog drugog sastanka, moći ćemo da pričamo mnogo više o subkutanoj formulaciji leka, jer ona će dovesti do jako velikih promena. Dakle, definitivno pacijenti koji su malo mlađe životne dobi, ali i oni koji žive sa mladima, uvek će pristati na to da ne idu u bolnicu, nego da kod kuće dobiju lekove. Pa valjda neko i u tom RFZO-u i Ministarstvu finansija razume da je to mnogo isplativije nego da pacijente hospitalizujemo i naravno mnogo je veća fleksibilnost u primeni ovih lekova, što će omogućiti da pacijenti primaju terapiju i kod kuće. Da biste nas ocenili i da bismo mi na neki način izašli odavde srećni i zadovoljni, molim vas još jednom skenerajte QR kodove, ocenite vaše zadovoljstvo sa nas troje, mi smo se potrudili, dali smo sve od sebe posle master klasa od jutra 8 sati. Sad mislim da smo spremni za ručak, infuziju, malo vitamina, ne morate da glasate za, možete i da glasate protiv, ja uvek glasam protiv, tako da ja u moje ime, u ime mojih panelista i u ime najinovativnije kompanije u ovom momentu na tlu Srbije želim da vas pozdravim, da vam zaželim dobar ručak i u nadi da se vidimo dogodine. Hvala vam lepo. Hvala. Prešedniče, hvala. Dobrodošli u 20 godina revolucije EGFR-a. Meni je veliko zadovoljstvo što mogu da vam predstavim moje paneliste danas koji su sa mnom, docent dr. Milica Kontić-Jovanović sa Klinike za pulmologiju Univerzitetskog kliničkog centra u Srbiji, naučni savjetnik Radmila Janković, naša omiljena molekularna biološkinja iz Instituta za onkologiju i radiologiju Srbije i ni manje ni više nego profesor dr. Nebojša Marić, torakalni hirurg sa VMA. Naš četvoro ćemo danas pokušati da vam negde približimo šta smo to uradili u proteklih 20 godina u domenu EGFR pozitivnih adenokarcinoma pluća i zašto smo zapravo ovaj ceo simpozijum nazvali jednom velikom revolucijom. A svi oni koji znaju nas zajedno, znaju da mi volimo da krenemo od Charlesa Darwina i od ovog čuvenog citata da zapravo inteligencija nije vezana za one najjače u vrsti, nego u sposobnost prilagođavanja novonastalim okolnostima, pa se tako i terapija EGFR-a definitivno prilagođava novonastalim okolnostima, novonastalim saznanjima i dostignućima kako u nauci, tako i u klinici. Vidite kakav je pathway bio i ovo su prvi početci 2004. godine, a zapravo ja ću vam ispričati priču koja je malo mimo ovih slajdova, a ta priča kaže da prvi put kada je zapravo napravljena studija sa EGFR pozitivnim adenokarcinomima pluća, niko nije imao pojma da su to zaista EGFR pozitivni karcinomi pluća. Uređena je velika IPAS studija, čiji glavni istraživač je bio Tony Mock i ta studija je na samom početku svoje karijere bila užasno negativna. Dakle, pokazala je da nema nikakve razlike u preživljavanju. A onda su došli ovi ljudi koji su zapravo otkrili mutacije u domenu gena za EGFR, napravljena je dublja analiza studije, izdvojene su žene, azijatkinje i nepušači i videlo se da je zapravo populacija koja ima benefit upravo ta populacija. Studije koje su kasnije krenule i koje su kasnije definisale domen mutacija, common mutacija u EGFR genu, dakle pre svega govorimo o insercijama na nivou egzona 19 i tačkastim mutacijama na nivou egzona 21. Tu se desila prva revolucija i prvi lek koji je stigao kao prva generacija, to je bio gefitinib, sledeo je erlotinib, a tada su nastale i nove generacije, druga, afatinib i dakomitinib, i nakon njih se shvatilo u čemu je greška i na čemu treba raditi, tako da onog momenta kada je završena Aura 3, dakle, jedna velika faza 3 kliničke studije, shvatilo se da postoji lek koji se zove osimertinib, odnosno Tagrisso, čije je danas carstvo EGFR mutacija, koji je bio pozitivan i u drugoj liniji lečenja nakon progresije na first line, a koji je primarno targetovao T790 mutaciju, otišlo se korak dalje i uz analizu podataka videlo da ne samo što deluje na primarnu rezistencijonu T790 mutaciju, osimertinib zapravo deluje i na ostale dve aktivirajuće mutacije i na taj način dobili smo najveću studiju svih vremena koja je ikad završena u domenu EGFR-a, a to je FLAURA studija. FLAURA studija, čije inclusion kriterijume vidite ovde, koja je sa jedne strane sukobila osimertinib i ovo je bila prva studija koja se usudila da sukobljava dva EGFR inhibitora. Ostali su se svi sukobljavali sa hemioterapijom, što i nije bilo tako teško, jer se a priori znalo da hemioterapija baš i nije efikasna u toj grupi pacijenata, ali osimertinib se sukobio sa gefitinibom i erlotinibom kao prvogeneracijskim tirozin kinaza inhibitorima i dao rezultate koje ću vam pokazati sada. Dakle, sa jedne strane, PFS koji je definitivno pozitivan i PFS koji je bio 19 i u momentu kada je zapravo sve ovo izašlo, niko od nas nije video PFS koji je iznosio 19 meseci, niko od nas tada nije ni video u 3. B i 4. stadijumu karcinoma pluća da postoji hazard ratio koji je 0,46 i koji je preko 50% smanjenje mogućnosti progresije, a onda je zapravo došlo još veće iznenađenje i došao rezultat ukupnog preživljavanja. Dakle, sa FLAURA studijom, prvi put u istoriji lečenja karcinoma pluća, videli smo da jedan lek ima efekat na ukupno preživljavanje, a pritom govorim o 4. stadijumu i 3. B, naravno, adenokarcinoma pluća, jer sve do tada preživljavanje je išlo nešto malo preko godinu dana i tu se završavalo. Kao što vidite, ovde je ogromno preživljavanje i nakon 5 godina sa ogromnim hazardom. Milice, da li bi ti iskomentarisala negde ovaj timeline molekularne revolucije zajedno naravno sa radom, negde kako smo došli do toga da sad na kraju 24. imamo sve ove igrače na kraju repa. Mikrofoni su ovde. Može, koja god hoće.
Koji ćemo redosledom? Pa, dakle, kao što si rekao, ciljana terapija jeste počela sa EGFR inhibitorima, vrlo brzo su počeli da se pojavljaju nove generacije i ono što je malo pre prokomentarisano i što je zapravo bilo najznačajnije, nije samo to koji lek je najefikasniji, nego i koja je sekvenca kojom trebamo davati lekove. Tako da Flowers studija je rešila to pitanje i samim tim vrlo brzo zapravo EGFR inhibitore prve i druge generacije zapravo ostavila u istoriji. Sa vremenom, ovaj timeline to najbolje pokazuje, sa razvojem NGS-a, sa otkrivanjem novih target mutacija, sledeći uvek korak bi bio i nova ciljana terapija. I ono što smo brzo naučili, to je da pacijenti koji imaju ciljane, odnosno driver mutacije, imaju najbolje ishode kada su u prvoj liniji lečenja leče ciljanom terapijom. Iz tog razloga je testiranje mnogo važno i terapijski algoritam pacijenata u 4. stadiju nesvetnog ćelijskog karcinoma pluća se zaista iz godine u godinu menja.
Rado, jel očekujemo slične rezultate sa ovima, N-trekom, retom, KRAS-om? Samo onako u jednoj rečenici. Da, tako je. I ja očekujem. Ovo je tvoj domen.
Pa evo, pošto se prisjećamo 20 godina, ja bih rekla da je ta naša revolucija počela 2011. godine i za našu laboratoriju. Ja se dobro sećam toga dana i prvog rana za EGFR mutacije, kada smo pustili pacijente koji su dobro odgovorili na TKI u drugoj liniji bez testiranja i svi su imali mutaciju. Znači, to je bilo onako veliko zadovoljstvo i sećam se, to je bio samo početak, jer je to otvorilo vrata i dalo zamah molekulnoj biologiji, jer ona je iznedrila tako ove alteracije na osnovu kojih su napravljeni lekovi i EGFR je bio samo početak. Posle toga počeli smo da delimo ovu piticu od genetičkih alteracija, pa smo i različite vrste genskih promena, znači tu su RET rearanžmani, ALK rearanžmani, amplifikacije, insercije i mnoge druge. Takođe, populaciona genetika je učinila svoje, pa se videlo da ti procenti nisu isti kod Azijata i u western populaciji i priča se komplikovala, ali na dobar način, jer i skoro za sve te alteracije i sve te medicinski hemičari su našli način da naprave konformacijne proteine koji u stvari su pravi lek za te terapije.
Jasno, i na taj način smo u stvari i došli do te 790M konfiguracije koja prolazi hematoencefalnu barijeru.
Tako je, upravo je mapiran taj jedan hidrofobni džep zbog koga je i terapija prestala da deli. Upravo na tu je konformacionalizam napravljen molekul koji fituje, odnosno osimertinib koji prevazilazi tu barijeru.
Znači, upravo zato nam basic science zapravo i treba. I koliko je sada kompleksno sve ovo?
Pa mi u stvari sad imamo biomarkere u okviru biomarkera, znači EGFR. Prvo što smo znali deleci egzona 19, tačkasta mutacija L858R, ređe mutacije, naravno mi smo ih otkrivali od početka, G719, E78 i mnoge druge. Insercije vrlo retko. Sada insercija, kao što si rekao danas, posebna grupa, posebna biološka molekulna grupa sa potpuno različitim ponašanjem. Otkrilo se da tih insercija koje su primarno rezistentne, uzrok primarne rezistencije osim jedne jedine na TKI inhibitore, predstavljaju heteronu grupu. I šta smo još otkrili? Mi smo testirali njih 5 godinama, tako, od 2011. godine, pa ima ih preko 120. Znači, to nam je stavilo sumnju u glavu da li je ta metoda koju koristimo dobra, nije. I drugo, imajući u vidu sve te biomarkere, da li nam treba novi izvor DNK, pa je direktno karcinom pluća, odnosno molekularna analiza kod adenokarcinoma pluća i zaslužna za razvoj tečne biopsije. Pa smo krenuli malo s tim tečnim biopsijama, očigledno i očekivano u kasnim fazama bolesti. Upravo smo pratili mehanizme rezistencije, tako se i otkrio T790M, gde te cirkulišuće tumorske DNK ima više. I to je bio prvi korak. Ali ono što je gol, kao i što idu Svi biomarkeri, naravno, to su rani događaji u kancerogenezi, većina za ranije faze bolesti, tako je i nama cilj da otkrijemo tu cirkulišuću DNK kao biomarker za molekulnu rezidualnu bolest, pa čak i u ranijim fazama za stratifikaciju bolesti. Tu što predstavlja jedino to nam je korak napred, naročito za biologe, da tražimo osetljivije metode, naročito za te ranije faze.
Da, i ono što je danas rečeno u jednom momentu na master klasu, a s čim ja moram reći da se ne slažem, a to je da CT-DNK, koja nije isto što i CF-DNK, ali znači CT-DNK neće na neki način biti surogat biomarker kad dođemo do Nebojše i do hirurgije i do operacije, ja ipak mislim da hoće. Ja ipak mislim da će molekularna rezidualna bolest ukombinovana sa radiomikom i ukombinovana sa znacima progresije ili odsustvom znaka progresije na radiološkim tehnikama otkrivanja, zapravo biti jedan od zajedničkih biomarkera za budućnost. Nebojša, šta je tu u hirurgiji se zapravo izdešavalo dok smo mi na neki način pokušavali da shvatimo gene?
Dobar dan svima. Teško je prokomentarisati poslednjih 20 godina, a ovaj slajd je praktično predstavlja 2500 godina istorije hirurgije, stvari koje su se dešavale i koje su interesantne, obzirom da je postojala i velika vremenska pauza od prvog, dakle, tog Smithovog papirusa kada je registrovano da je urađena prva operacija, to ne operacija, nego da su konstatovali stari Egipćani da treba da se radi šav na jednjaku da bi mogla da voda i hrana protiče, pa do današnjih dana, dakle, bilo je mnogo interesantnih stvari. Ono što bih ja izdvojio, a što ima veze sa tim, a čisto radi i svoje vežbe i gledajući ovaj skup na kome se nalazimo, a da inače imam problema sa generičkim imenima, a nekad i fabričkim lekova o kojima se radi, a zato sam se potrudio da zapamtim ime Avenzoara, znači Abdu Malik Abdal Malik, koji Ibn Zuhur, dakle, ili Avenzoar, koji je prvi uradio traheostomiju u 12. veku. Kao što vidite, ni to mi nije bilo lako, ali gledajući ova generička imena, i fabrička, recimo, Tagriso, vrlo lako sam zapamtio. Što se same torakalne hirurgije tiče, praktično njen razvoj ide sa hiruškim umetanjem u lečenju tuberkuloze, to je 1882. godina i Kohovo izlaganje na Berlinskom fiziološkom kongresu i nakon toga praktično ide razvoj, ali koji je napredovao tek sa razvojem i anestezije, sa razvojem tehnoloških pratećih stvari do današnjih dana kada imamo sve minimalno invazivne prateće procedure, dobru tehniku i mogućnosti da pacijente lečimo. Od dana kada je urađena prva operacija zbog adenokarcinoma pluća, to je bilo 32. godine, do današnjih dana izmenile su se mnoge tehničke stvari.
Šta kažeš za ovo?
Za ovo mogu da kažem da, recimo, ako poredimo nešto o čemu smo, što bi komentarisali pre samo 10 godina, kada je Jessica Dunnington, dakle, objavila svoj rad čuveni gde je komentarisala na koji način se treba ponašati prema pacijentima u trećem stadijumu bolesti i kako tretirati N2 bolest, pa do današnjih dana napravljen je pomak da praktično single N2 bolest se može operisati. I ono što je vrlo značajno, o čemu smo komentarisali na jednom skorašnjem sastanku, da odluku o samoj operaciji treba da donosi multidisciplinarni tim od samog momenta kada postoji indikacija ili kada postoji sumnja na karcinom pluća. Što se samog ovog slajda tiče, vrlo jasno je razgraničeno na šta je resektabilno, šta je iresektabilno i ono što može biti potencijalno resektabilno, a što je generalno i dan danas teško odlučiti. Da li dati neoadjuvantnu terapiju, da li prvo pristupiti operaciji, ali mislim da u današnje vreme sa ovom terapijom napravili smo pomak u tom pravcu da možemo razmišljati da prvo primenimo neoadjuvantni protokol, a posle da operišemo.
Tako je, ali ćemo definitivno u domenu EGFR pozitivnih pacijenata imati situaciju da ili ćemo im dati ovima koji su resektabilni, a imaju EGFR mutaciju, dakle Tagrisso adjuvantno, ili ćemo znači ići na lečenje Tagrisom kroz Flaura protokol. Dakle, resektabilnost versus operabilnost ćemo preskočiti, to nam je svima zapravo jasno i ovo je negde Adaura dizajn. Milice, hajde kratko da prođemo, vremena nam otkucava, kroz Adauru i kroz ovaj dizajn, pa onda da krenemo na rezultate.
Da, mislim da je dizajn Adaure svima dobro poznat. Dakle, ideja je naravno bila dati EGFR inhibitor u adjuvantnom settingu. Osimertinib je bio u pitanju, druga grupa pacijenata je primala placebo sa ciljem da se proveri da li će to uticati na odlaganje progresije bolesti, odnosno disease-free survival. I na ovom slajdu možemo da vidimo ono što nas najviše zanima, kako se to odrazilo na ukupno preživljavanje pacijenata i to 5-godišnje, to je ono što je onkologiji najvažnije. Razlika je evidentna, dakle 88% pacijenata koji su u adjuvantnom settingu primili osimertinib je bilo živo nakon 5 godina u odnosu na 78% pacijenata koji su primili placebo. Samo bih htela da prokomentarišem da su u ovoj studiji pacijenti osimertinib u adjuvantnom settingu primali 3 godine. I malo ako se zagledamo u ovaj Kaplan-Meier možemo da vidimo da se dotle nekako i ova grupa pacijenata koja je primala osimertinib držala dosta dobro. Nakon toga počinje taj blagi pad i te dileme su dosta, da kažem sada, aktuelne. Da li je 3 godine dovoljno, da li možda 5 godina.
Naravno u imunoterapiji.
U imuni, ali i u ciljenoj terapiji, da.
Tako
I u ciljenoj terapiji je to očigledno...
Ali čisto da se malo vratimo na ovaj dizajn, ono što je bilo jako važno jeste da je jedan deo ovih pacijenata primio, je li tako, i adjuvantnu hemioterapiju. I znači ovi koji su bili u kontrol armu su bili zapravo lečeni standard of care-om za dati moment, znači za date indikacije. Tako da u principu ovo je jedna vrlo dobra studija koja nam je na kraju dovela zapravo, Radmila, do jedne oluje NGS-a. Ajde, probaj u minut, dva da nam tu oluju NGS-a približiš i da nam objasniš šta se to sada dešava.
Puno pričamo danas o NGS-u, pričamo i svih ovih godina i nikako da dođemo do njega, je li tako? Mislim, došli smo za druge indikacije. NGS, naravno, jeste prva preporuka, sećamo se onog slajda sa velikim brojem alteracija. Znači, jedino NGS može u jednom koraku detektovati sve alteracije. Problem, konkretni ako pričamo danas za neku laboratoriju manjeg tipa, manjeg protoka informacija, treba biti pametan i izabrati pravu metodu. Ja sam svedok puno toga da lekari bi odmah panel od 500 gena kao rutinsku analizu, to ne može, ne rade čak ni veće kuće. Znači, izabrati dobro, nešto što je adekvatno, što ima brzo izdavanje rezultata, što može pokriti adekvatno i DNK alteracije i fuzije, što znači treba razmišljati o RNK panelima ili na jednom panelu raditi obe analize. Znači, neću reći biti skroman, ali biti objektivan.
Ali da li ćeš biti glavna što se tiče selekcije pacijenata?
Pa ja se tu slažem s tobom, ja mislim da već možemo pričati o selekciji pacijenata, naročito u adjuvantnom settingu od minimalne rezidualne bolesti, već su objavljeni rezultati, ušli su u vodiče za kolorektalni karcinom, zahvaljujući tim ctDNK testovima koji nisu tumorom informisani. Znači, to su nove metode, nešto malo si spomenuo, nisu samo to genetičke alteracije, to se radi i o metilaciji, o fragmentomiksi, o radiomiksu, o svim vrstama koje su dovoljno precizne, znači da nam daju tu verodostojnost nalaza i u ranijim fazama. Znači, bukvalno na osnovu koncentracije cirkulišuće tumorske DNK, odnosno njenog kliransa, da li ili nema, moći će da se tailoriše adjuvantni tretman. Znači, ako nema, pacijent može ići na praćenje, ako je ima, onda se radi reeskalacija doze ili malo se, znači vrlo, i to se već radi, to je nešto što se dešava. Tako sam ja vrlo ubeđena.
Tako je, što znači da jedni bez drugih zapravo nećemo moći, naročito u domenu EGFR pozitivnih pacijenata, da odaberemo pravu terapiju i da odaberemo pravi pristup pacijentu, jer ćemo samo na osnovu informacija koje si evo malo pre pomenula, a stoje na ovom slajdu, morati da imamo i molekularni tumor board i morati da imamo klinički multidisciplinarni tumor board i molekularni tumor board i klinički multidisciplinarni tumor board sa hirurgom, radiologom, patologom i svim ostalima će morati negde zajedno da se sastaje i zajedno da donosi odluke za svakog pojedinačnog pacijenta, što će iziskivati puno vremena.
Apsolutno, naročito sa rezultatima NGS-a treba odlučiti, na primjer, koja je mutacija driver i to smo pričali danas, tako da...
Milice, 2026. Šta nam sve dolazi? Šta kažeš? Kako li ćemo isplivati?
Da, ono što mislim, ka čemu idemo, to su kombinacije. Mi smo inicijalno o tome mnogo govorili kad je u pitanju imunoterapija, dakle, brzo se došlo do toga da dodatak hemoterapije i imunoterapije donosi veći benefit efikasnosti. A što se tiče ciljane terapije, ti neki inicijalni pokušaj da se hemoterapija daje zajedno sa ciljanom terapijom i nisu se baš proslavili sa rezultatima, pa se nekako od toga privremeno odustalo. Naknadno se došlo do toga da ta sekvenca davanja nije bila dobra, odnosi se na erlotinib i gefitinib, da je i to bitno, da li se prvo daje hemoterapija, pa nakon toga EGFR inhibitor ili obrnuto, jer ako se ne daje dobro, neće doći do sinergizma, nego do antagonizma, što će da, jer ti lekovi deluju u različitim fazama ćelijskog ciklusa, zbog čega će im se poništiti međusobno dejstvo. Tako se objasnilo zašto su rezultati tih inicijalnih studija vezani za kombinovanu terapiju bili negativni, pa se ponovo došlo do dizajna nove studije, a to je Flaura 2, je li tako? I to je nešto što je, da kažem, tema današnjeg simpozijuma, da najavimo, samo da govorimo o dizajnu novih studija, ne toliko o rezultatima, ali naravno znamo već preliminarno koliko je ova kombinacija donela benefita u smislu PFS-a. Ono što je donela takođe, to je i toksičnost, dakle to ne možemo da zanemarimo. Hemoterapija zajedno sa ciljanom terapijom će pogoršati toksičnost i onda nekako u perspektivi ćemo razmišljati ko su ti pacijenti koji su za kombinaciju, možda ljudi koji su mlađi, koji imaju veće tumorsko opterećenje, koji imaju potrebna brza redukcija tumora i koji imaju metastaze u CNS-u.
I možda neki od njih koje nam Radmila identifikuje sa nekim od novih biomarkera. Hoćeš da iskomentarišeš Lauru?
Ista stvar, dakle sad već dobro znamo da kad imamo target mutaciju, odnosno driver mutaciju, pacijente treba lečiti ciljanom terapijom, očigledno bez obzira na fazu bolesti. Počeli smo sa metastatskim, to nas je apsolutno uverilo da ovaj mehanizam deluje, ide se ka nižim stadijuma, sad je jasno naravno kako deluju, slušali smo danas dosta o tome u ranom stadijumu, isto se odnosi na treću, dakle ideja Laura studije, EGFR pozitivni, nakon konsolidacione hemo i radioterapije, ako nisu progredirali, dobijaju EGFR inhibitore.
Kanda replika Pacifika, a?
Da, malo je diskutabilno, ali nemamo mi sad vremena za ovo, ali jeste malo diskutabilno taj redosled, sekvenca i uopšte pitanje da li davati EGFR inhibitore pozitivnim pacijentima u trećem stadijumu. I evo, kad smo već kod ovih novih studija, možemo da prokomentarišemo i neoadauru, mislim, sa istim šlagvortom, dakle, isto očekujemo benefit kod pacijenata ako dajemo neoadjuvantnom, ako su EGFR pozitivni. Ovo je sad zanimljivo ko će najbolje reagovati. Da li samo oni koji primaju osimertinib, koji primaju kombinaciju osimertiniba i hemoterapije ili samo hemoterapije, jer videli smo, nismo danas stigli da komentarišemo, da možda u odauri i nije bilo neophodno davati hemoterapiju onima koji dobiju osimertinib. Vidjet ćemo da li to isto važi za neoadauru, pogotovo jer ih čeka operacija. Ne vole hirurzi da mi mnogo pacijente opteretimo raznim terapijama pre operacije.
I imamo u neoadauru ubačene sve ove za koje nam je neophodna rada, 719X, 20 insercije, S7681, L861Q, znači imamo ih mnogo. Rado, hoćeš li ti iskomentarisati s obzirom na plazma, cell-free DNA, s obzirom na sve ovo vrlo kratko, pa onda hirurgija, pa sve ostalo?
Znači, ovo se malo i nastavlja na prethodni slajd, kao i što testiranje biomarkera se pomera u ranije faze i što je najbitnije znati ga što ranije, tako i klinička upotrebljivost tečne biopsije takođe se pomera u ranije faze bolesti, pa može biti i dobar biomarker u neoadjuvantnom settingu. Ja sam ubeđena da za 5 godina, kao što i ovde piše, da će njena uloga biti i u samom proceni rizika, prognostikaciji i mnogo toga zahvaljujući upravo tim metodama. Takođe, jutros je bilo reči na master klasu da je PCR PCR, novi endpoint uz major pathological response, ctDNA vrlo blizu s njima kao taj surogat end marker, jer je pokazano da udruženo kliran ctDNA i major pathological response ti pacijenti imaju najbolji odgovor i najduže preživljavaju. Znači, ctDNA tu da ostane i pomera se, zahvaljujući novim metodima biće rutinska analiza za par godina.
Ali ništa od tih stvari apsolutno nisu moguće, ni pathological complete response, ni major pathological response bez hirurgije. Jer samo sa hirurgijom možemo znati da li smo ih postigli. Nebojša, šta kažeš?
Da, ovaj slajd je interesantan. U suštini to bi trebalo da bude sadašnjost grudne hirurgije i uopšte hirurgije, dakle robotski sistem i da se na taj način rade operacije. Postoje mnoge i značajne prednosti, sedmostepeni pokret i manji tremor, praktično mogućnost i mentorstva na distanci, jer može sa 400 km da se radi operacija, da se prenose podaci fiberoptičkim kablom i na kraju krajeva, a što nije uopšte nebitno, produžava se i hiruški vek, jer ne morate...
Hiruzima će biti lakše, pacijenti će imati manje traumatizma, mi ćemo imati veliko tkivo, genetičari će imati dovoljno materijala. Misliš li da smo stvarno za ovih 20 godina od 2004. do 2024. kako smo uspeli da pređemo taj put 20 godina i završili sa robotičkom hirurgijom?
Mogu da kažem samo da, nažalost, mi još nismo završili sa robotičkom hirurgijom.
Okej.
Ja se nadam da će postati, i to je ono što je suština, da postane standardna praksa, a ne nešto što ćemo notirati, a što se radi u svetu. Praktično pratili smo trendove, pratili smo primere i trudili se da ih poštujemo.
Nešto na čemu ćemo svi zajedno morati da radimo, i ovo su finalni slajdovi ove revolucije o kojoj smo vam pričali. Dakle, mi za sada u Srbiji imamo Adaura, Flaura i Aura 3 indikaciju, dakle imamo adjuvantni Tagriso kod EGFR pozitivnih pacijenata, imamo u prvoj liniji Tagriso kod 3. B, C i 4. stadijuma EGFR pozitivnih adenokarcinoma pluća na common mutacijama i naravno imamo mogućnost davanja osimertiniba u drugoj liniji. Nadamo se da će i sve ove ostale studije, kako budu završavale svoje faze 3 i kako budu izlazile sa svojim, siguran sam, pozitivnim rezultatima, polako dolaziti i tako ćemo biti u situaciji da 5 godina od sad kažemo da smo za četvrt veka u potpunosti promenuli landscape lečenja EGFR pozitivnog adenokarcinoma pluća. Ako uspete da ostanete i narednih 45 minuta vidjet ćete kako smo promenuli i landscape ALK pozitivnog adenokarcinoma pluća, a sa ovim ja završavam. EGFR revolucija je u toku, ona nije nikako ni blizu da završi. Dakle, još jednom Charles Darwin, ja neću čitati slajd, ali budite spremni na to da sledeće godine pričamo nove stvari, a da za 5 godina, verujem, neko od mlađih koji upravo sede tu i tamo se zabavljaju i gledaju u mobilni telefon, će umesto mene pričati upravo ovo. Hvala vam na pažnji. Ok, poštovane koleginice i kolege, znači nastavljamo ovim tempom, idemo da završimo još 45 minuta, pa pluća odlaze kući, ostaju ove ostale indikacije. Meni je veliko zadovoljstvo da vas pozdravim u svoje ime, u ime kompanije Pfizer, i da nastavimo priču o onim targetabilnim adenokarcinomima pluća. Moji saučesnici u današnjem simpozijumu su profesor dr. Marko Jakopović, koga apsolutno nije potrebno predstavljati nešto posebno, znači doktorka Natalija Samardžić, koja je i malo pre bila ovde sa svojim real world data i ovde će biti, i moja malenkost koja će poslužiti samo kao domaćin i nešto malo ispričati o ALK pozitivnim adenokarcinomima pluća. Marko, izvoli.
Evo, dobar dan svima, najhrabriji su ipak ostali, i najuporniji u stvari, ovo je šteta, jer prvo smo vidjeli oluju NGS-a i EGFR pozitivnih, sad ćemo vidjeti oluju ALK pozitivnih tumora, a ono što je nevjerojatno da kad sam ja počeo raditi onkologiju, što stvarno zvuči davno, ali početkom tisućljeća, nećemo to govoriti previše, onda nije postojalo ništa, onda su glavni, kako bi ja to rekao, koji je Hallmark imao neke znači glavne zvijezde vodilje onkologije su bili karcinom dojke, pa smo svi znali za HER2, pa onda svi znaju za Philadelphia kromosom, pa svi znamo za jako puno drugih molekula. Odjednom u karcinomu pluća danas imate 10 ili 11 molekula za koje postoji odobrena terapija ne samo u Americi nego u Evropskoj uniji. Tako da je sad karcinom pluća postao predvodnik, to je jedna stvar. I druga stvar je kad se sjetite da je 2007. je otkriven ALK, translokacija je otkrivena u adenokarcinomu pluća, manje 4 godine je trebalo da se stvori krizotinib, koju je napravila ova kompanija o kojem nećemo danas sad pričati, a imamo satelit Pfizer, a onda je došao ovaj lijek o kojem smo malo prije pričali, od kad su našli opće konformaciju, 2,7 godina od otkrića strukture receptora trebalo dođe lijek na listu. To su nevjerojatni napreci, jer se sjećate prije, oni stariji, mladi se vjerojatno ne sjećaju, da je trebalo 20 godina od otkrića molekula do dospjeća lijeka na listu. To je potpuno drugačija priča. I ono što još moram reći, bile su dva super mantre, neke smo rekli danas. Jedna je tissue is the issue, druga je stage is the destiny, treća je da inteligentni ljudi neće napredovati, ili tako da to je super pa nam je lakše malo, pa možemo kolaborirati, ne? I treću ne smijem reći ili prosto, ali ono, smaller is better, to je zbog molekula u stvari, ne pa ono, samo da se malo šalimo, ne? Ispričavam. Sad ću probati u narednih 10 minuta nešto reći o lorlatinibu i mislim da je to neka potpuno druga priča i ono što je nevjerojatno kad gledate tumore adenokarcinoma imaju koliko, 3-4%. Znamo da imaju ALK promjenu u svom genomu, onda ako uvedemo NGS doćemo do 7-8%, ali u svakom slučaju nije baš česta promjena u genomu, a opet imamo 5 lijekova koji su danas odobreni od i Europske agencije, i Američke agencije za lijekove i to dovodi do značajno boljeg liječenja ljudi. A probat ćemo vam reći zašto je lorlatinib tu najvažniji. Čuli smo danas, je rekao Sanjay, kako se to već izgovara, ne znam, zvuči kao Sanjay Popat, da je ja se slažem s time da uvijek treba najbolju terapiju vjerojatno na početku, pa ćemo vam probat pokazati da je lorlatinib vjerojatno ovaj čas najučinkovitiji lijek. Znači, krenuli smo s krizotinibom koji je promijenio potpuno pristup liječenju bolesnika sa ALK pozitivnim tumorima, onda je došao ceritinib koji barem u Hrvatskoj, ne znam kako od vas nikad nije zaživio, dali smo 2-3 bolesnika terapiju, imali jako puno nuspojava, nije bio puno bolji od krizotiniba, pa smo to napustili, nikad nije bio reimbursan, pa smo živjeli na krizotinibu jako dugo. I onda je došlo jako puno novih lijekova u tom malom, kako su danas rekli više puta naši predavači, ALK space-u, znači u ALK svijetu, je došlo puno nekih manjih puno molekula koje su onda ušle u tu usku, ajmo reći, relativnu nišu naših terapija. Ono što je sad najveći problem bio što, kad pogledate sve studije, došao je alektinib, brigatinib, ensartinib, bar u Hrvatskoj nije dostupan, no u svakom slučaju svi su se oni borili protiv jadnog malog krizotiniba koji je promijenio cijelu priču i svi su bili značajno bolji od njega. Krizo je bio bolji od kemoterapije, što ajmo reći ne fair borba bila, ali nismo imali bolje prije 10 godina ili 15, a sad smo došli do toga da su oni svi značajno bolji od krizotiniba koji postoje. I sad kad gledate ove brojke, oprosti, Bojan je čermen, pa onda, ali nećemo gledati PFS-ove, jer Bojan ne voli PFS-ove. Mogu ja dobiti ovaj slajd, ekran dolje, hvala, super. Bojan ne voli PFS-ove, ali kad pogledate kako su krivulje razmaknute, one su stvarno ekstremno razmaknute, gledate PFS. Znači, govorimo sad više o kemoterapiji je OS bio prije 25 godina 10 mjeseci, govorimo o PFS-u od 25 do 35 mjeseci. Možemo sad raspravljati kak je Alex studija došla sa 25 jedanput na 35 mjeseci, kad su radili neku drugu subanalizu, drugačija analiza. U svakom slučaju imamo 2 do 3 godine samo PFS u tih naših bolesnika. Ono što znamo da oni koji su dobili više generacije ALK inhibitora danas žive 8, 9 ili 10 godina, to je nešto što je stvarno fenomenalno. Onda kad pogledate overall survival, pogledate 5-godišnje, odnosno 4-godišnje preživljenje, vrlo slično brigatinib i alektinib negdje 65%, usporedbi sa krizom, i krizo je jako visok overall survival, a većina tih bolesnika koji su dobili krizu u prvoj liniji su dobili ove neki od drugih ALK inhibitora kasnije. Kad pogledate ove sve druge ostale lijekove, tu su stvarno impresivne brojke, bez obzira koji ALK inhibitor danas dajemo. I sad kad pogledate ono što je još fenomenalno, znamo da su ALK pozitivni tumori vrlo često skloni metastaziranju u glavu i znamo da krizotinib baš nije imao dobru penetraciju CNS, ali znamo da i alektinib i brigatinib imaju dobru penetraciju u CNS, znači značajno su bolji od krizotiniba. I onda kad pogledamo neke toxicity, ono što zvuči nevjerojatno, svaki od njih je potpuno drugačiji. Ja sjećam kad je došao krizotinib, onda je neko pričao da neko ima, ne znam, neke svjetli mu pred očima, onda kad neko dobije alektinib ili neke drugih lijekova, onda se malo, ne znam, da ima edeme pa dobije na težini, tako da sigurnosni profil je potpuno drugačiji nego što smo mi očekivali prije, ali u stvari iznimno lako se može kontrolirati. Ti ćeš govoriti više o safety profilu koji je potpuno drugačiji i za ovaj lijek o kojem ćemo kasnije govoriti, jer to ću ja komentirati kasnije, ali to je nešto što uopće nismo razmišljali. Mi sad razgovaraš o tome da neko ima, ne znam, svjetlje, ima neke svjetla se pred očima, pa ovaj dođe, niko nema pojma šta se dešava, pa šaljemo to oko liste, a sve prođe za 2 tjedna kad je bio kriza, a onda dođemo od ovog svega kasnije. I onda smo skužili da su ove novije generacije značajno bolje od prve generacije, što je obično tako. I onda se pojavio kao kruna na sve to, ili kao ona višnja na vrhu šlaga na torti, Crown studija sa lorlatinibom, najnovija generacija ALK inhibitor, znači opet, nažalost, borba protiv krizotiniba, jer to je kad je tako bilo dizajnirane su studije, onda je krizotinib bio standard of care. Uglavnom, vrlo sličan dizajn, tako da nećemo govoriti previše o dizajnu. Međutim, kad pogledate prvu analizu, onda smo došli od toga da su nakon 3 godine praktički gotovo 65% bolesnika nije imalo opće progresiju bolesti, za razliku od 20% ili 19% na krizotinibu, i hazard ratio je bio 0,27. I sad mi danas pričamo jako puno i o imunoterapiji i o nekim drugim terapijama. Kad gledate hazard ratio da imate 73% manju šansu dobiti progresiju bolesti, znači lorla versus krizo, znači ne versus kemoterapija, to su stvarno impresivne brojke. I ono što je bio problem, PFS za krizotinib je uvijek sličan, negdje 9 do 10 mjeseci, i sad nakon 3 godine praćenja praktički nismo imali uopće dosegnut PFS u medijanu kod lorle, zato što je to super u stvari. Ne? Znači morate imati barem 50% progresije bolesti da bi dobili medijan PFS-a, znači to uopće nemamo. I onda se ove godine na ASKU pojavili podaci, smo svi očekivali sumanuto taj PFS. Šta se desilo? Opet nema medijana PFS-a, što je još bolje. Nakon 5 godina i dalje 50% ljudi koji su dobili terapiju nemaju progresiju bolesti. I sad kad pogledate, ako se sjetite, onda je bilo 64% nakon 3 godine nije imalo progresiju, od 60%, znači samo 4% u apsolutnim brojkama ljudi nije dobilo progresiju bolesti u ove 2 dodatne godine. I sad kad pogledate, ovo se malo pomaklo, ali tu je 0,19, ako ja dobro sam zapamtio brojku, znači imate 80% manju šansu imati progresiju bolesti ako se na lorla nego na krizotinibu, i ti hazard ratio, znači ti, kako se to zove na hrvatski, ja ne znam, ili na srpskom, ali dobro, hazard ratio, kako? Odnos rizika su, to je jedino što možemo teoretski uspoređivati iz različitih studija, znači brigatiniba, alektiniba i lorlatiniba, znači ti odnos rizika ili hazard ratio je puno bolji i povoljniji u Crown studiju odnosno na ostale studije koje smo danas imali. Kad pogledate sve podskupine, naravno da je sve na strani lorlatiniba u usporedbi sa krizotinibom. E sad, ono što je ključno sad reći su bolesnici koji su imali ili nisu imali moždane metastaze na početku. Znamo da su i briga i alektinib super učinkoviti u CNS-u, ali ima još jedan lijek koji je bolje i učinkovitiji u CNS-u, barem se tako čini u ovom podatku. Kad pogledate, bolesnici koji su imali moždane metastaze na početku imaju 5-godišnje preživljenje, odnosno PFS, znači gotovo 50% nije imalo opće progresiju bolesti. Kad gledate hazard ratio 0,08, ja nisam mislio da ću ikad vidjeti te brojke u životu, hazard ratio u karcinomu pluća. Oni koji nisu imali moždane metastaze su prolazili naravno bolje, ali to je bilo za očekivati, ali apsolutne brojke su naravno uvijek na strani koji nisu imali moždane metastaze na početku. I sad kad pogledate one bolesnike koji su nakon 5 godina, gledali smo da li imaju vrijeme do progresije bolesti u CNS, kad pogledate hazard ratio je ono 0,06 i sad kad pogledate da je 65 bolesnika, znači gotovo pola bolesnika na krizotenibu je dobilo, ili 40% dobilo progresiju u CNS, a samo 9 bolesnika je dobilo progresiju na lorlatinib. To je nešto što stvarno, to sam već rekao danas, to zvuči kao statistička pogreška. Kad pogledate krivlju, nakon 6 godina 92% bolesnika nije imalo uopće progresiju bolesti, odnosno samo 8% je imalo progresiju bolesti. Sad kad pogledate malo drugačije to opet, znači te brojke su stvarno, ne znam, to ja uopće kako da to kažem, znači očigledno lorlatinib ima još veću CNS učinkovito nego dostupni lijekovi koji danas postoje. Kad pogledate krivulje, one su stvarno impresivne. Oni bolesnici koji nisu uopće imali metastaze možda na početku, njih je samo 4 kroz ovih 5 godina praćenja dobilo moždanu metastazu. A znamo da su ALK pozitivni bolesnici oni koji najčešće umru zbog progresije bolesti u CNS. Nije bilo nekakvog značajne toksičnosti. Ono što će Bojan govoriti detaljnije, jedanput govorimo o hiperkolesterolemiji i onda kad je došao neki pacijent koji smo prvi put dali lorlatinib još u drugoj liniji, pa je neka gospođa došla i rekla da ona čitala da ona ima masnoće u krvi, pa smo rekli da ćemo dati ponovno, pa kaže kako će ja to napraviti, onda smo se mi smijali, rekao kog briga za masnoće kad imaš metastatski karcinom pluća, a onda shvatiš kad neko živi 10 ili 15 godina da je bolje da ne dobije infarkt ako ima masnoće koje su ogromne, ali se sa lijekovima to danas, ajmo reći, dobro kontrolira, ostalo će govoriti Bojan detaljnije. I ono što je važno reći da od dijela bolesnika zbog nuspoja moramo smanjiti dozu, a ono što smo danas već čuli da sama doza je možda važna kad se, ona maksimalna doza koja se daje od 100 mg je važna kad se govori o recimo davanju terapije u nekoj kasnijoj liniji kada idemo na ove mutacije rezistencije djelovati, ali ako moramo smanjiti dozu nema uopće neke razlike učinkovitosti bilo u CNS-u, bilo u sistemski, tako da mislim da nema razloga i straha da se doza lijeka ne smanji. I ono što je važno reći koje su sve mogućnosti rezistencije. Ono što je problem kod ALK pozitivnih tumora je da svaki, kad date bilo neki lijek, svaki ima drugačije mehanizme rezistencije. Ono se uvijek bojimo nekih najgorih, pa jedna od tih najgorih je G1202R, ali međutim te mutacije su relativno rijetke. Kad se daje lorlatinib, on je dizajniran da blokira tu rezistenciju, ali onda moramo gledati ono što pričamo cijelo jutro, kao što smo čuli malo prije, da treba raditi u trenutku progresije NGS, što baš ni u Hrvatskoj se ne radi, ali bi trebalo da možemo krojiti terapiju prema razvoju rezistencije. Međutim, ono što je problem da ima i onih alternativnih mehanizama i bypass mehanizama i on-site mutacija i nekih drugih mutacija, ali u svakom slučaju ja mislim da bi svaki bolesnik koji je ALK pozitivan treba dobiti sve ALK inhibitore u nekom času. Znali mi profili ne dali, pa ćemo barem u našim uvjetima napraviti klinički. Ono što je rekao Rafal jutros, da mislim da je puno jeftinije napraviti NGS koji košta 2000 eura nego dati lijek koji košta ili 3 put više, pa idemo raditi kliničku procjenu. Da li lijek djeluje, ne bi puno bolje napraviti testiranje u tih bolesnika. No u svakom slučaju tu smo gdje jesmo, mi dajemo onda nakon lorla dajemo neku drugu sekvencu koju radimo, ali ako nakon 5 godina većina bolesnika uopće nema progresiju bolesti, onda se ne trebamo baš previše toga bojati. Tako da ova naša vaga sada prevagla je na stranu treće generacije, znači to je lorlatinib, tako da mislim da su ove brojke stvarno impresivne. Ja sam prvi bio impresioniran kad sam čuo te brojke, jer stalno smo očekivali da će te brojke biti slične postojećim lijekovima na tržištu, međutim očigledno su puno impresivnije. I srećom Bojane, medijan PFS-a nije dostignut i onako ga ne voliš i mrziš, tako da gledamo samo 5-godišnji PFS i OS i sve ostalo, tako da mislim da je, ne smiješ to reći javno, nema head-to-head studija, niti će vjerojatno biti, ali mislim da ove su podaci za lorlatinib uvjerljivo najviše impresivni od svih dostupnih ALK inhibitora, bez obzira što rekla NCCN smjernice koje kažu su svi, ajmo reći, ravnopravni, ali i 5-godišnji PFS i intrakranijska učinkovitost je barem po meni na strani lorlatiniba, tako da je to ipak ovaj čas kralj liječenja, odnosno kruna na svemu u liječenju bolesnika koji su ALK pozitivni. Evo, hvala lijepo.
Ja ću probati u što kraćem vremenskom roku da zapravo prođem isto ovo što i Marko, samo možda iz nekog drugog ugla, jer definitivno čuli ste danas i od Sanđeja Popata da je paradigma lečenja ovih vrsta karcinoma pluća uvek započeti sa najboljim lekom na vreme. I ovo je Marko ispričao. Dakle, ovo je taj hazard ratio od 0,19 ili 19%. Zašto ja ne volim PFS i ne volim medijane? Marko zna, a to je zato što su to ipak apsolutni ili relativni brojevi koji se odnose na 50% populacije. Jedino hazard ratio je broj koji se odnosi na celu Kaplan-Majerovu krivu, dakle gleda od početka do kraja. I ovde definitivno sada imamo 80% manju šansu od, dakle, progresije ukoliko je pacijent na krizotinibu. Šta je u komparativnoj studiji? Šta je u Aleksu? Dakle, u onom što je u ovom slučaju naša realnost u Srbiji. Pa tu je hazard ratio 0,5. Dakle, tu imamo samo 50% u odnosu na 80% manju šansu od progresije ukoliko je pacijent na alektinibu. Nikada se ne sme raditi cross-trial comparison ili upoređivanje studija koje nisu iste, ali mi jedino što imamo to su hazard ratio. Mi jedino što možemo da uporedimo to su hazard ratio. Dakle, imamo 19% na krizotinibu, imamo 50% na alektinibu i imamo 50% na brigatinibu. Dakle, ni globalni hazard ratio ne može da se približi najboljem leku u ALK univerzumu, a to je u ovom momentu, bez obzira na te šarenolike trajale, u principu, dakle, lorlatinib. Marko vam je pokazao kako izgleda intrakranijalna progresija, znači sa dosad ipak neviđenim hazardima od 0,05 i 0,03. Dakle, 95% smanjenje šanse za intrakranijalnu progresiju kod pacijenata koji nisu imali metastaze u mozgu, što u proseku sa ovih sad 5 godina praćenja znači da je jako malo verovatno da će taj pacijent uopšte dobiti metastaze u mozgu kao osnovnog ubicu. Kod onih koji su imali metastaze u mozgu na baseline-u je praktično to još manje. 97% je manja šansa da će doći do progresije tih metastaza u mozgu i zapravo doći do nekog letalnog ishoda. Šta je u Aleksu? U Aleksu je to 0,18 i 0,14 i to su dobri hazardi. Da se razumemo, to su hazardi koje mi pre 5 godina nismo mogli da vidimo ni u jednoj indikaciji, ali game over u korist lorlatiniba. Ovo su ipak hazardi koji za neki procenat povećavaju mogućnost ili nastanka novih ili porasta već postojećih metastaza koje se nalaze u mozgu. I na kraju brigatinib koji je kao i alektinib drugogeneracijski, koji zapravo tu ima daleko veće hazarde, od 0,29 i 0,78. Uzmimo to sve sa rezervom, jer su dizajni studija različiti, različite su populacije koje su ušle u studiju i ne možemo ih direktno porediti. Možemo samo direktno porediti brojke koje su praktično takve kakve jesu. I ovo su, dakle, terapijske opcije frontline-a, lorlatinib, brigatinib, alektinib, dakle, lorlatinib kao treća generacija. Ali hajde da povučemo paralelu u EGFR. Dakle, ovo je isti driver mutation tumor. Da li iko više u EGFR pozitivnom adenokarcinomu bronha razmišlja o gefitinibu, erlotinibu, afatinibu, dakomitinibu? Pa čak ni Max više, da Marko zna, to je naša interna šala, radi se o profesoru Hochmajeru. Dakle, nema više ni afatiniba ni ničega. Tako će zapravo ići i prirodna evolucija lečenja. Postavljaće se pitanje šta u drugoj liniji lečenja, šta u trećoj liniji lečenja, ali nemojte da zaboravite da je dobra stara platinska hemioterapija i dalje tu. Ovi pacijenti koji prolaze lečenje TKI inhibitorima, bilo ALK ili nekim drugim, su pacijenti koji su nakon terapije i u momentu progresije, osim ako nije u CNS, uglavnom relativno dobri performeri, koji mogu da prime hemioterapiju. Nažalost, imunoterapija u ALK pozitivnim pacijentima nema nikakvog efekta i o imunoterapiji kod ALK pozitivnih pacijenata nikad ne treba razmišljati, jer je dokazano da nema nikakve efekte. Šta se dešava sa moždanim metastazama? Dakle, tokom lečenja sa drugom generacijom ALK TKI-eva. Dakle, više od polovine će razviti moždane metastaze koje imaju taj detrimentalni uticaj, odnosno deterioraciju, kako mi kažemo na nativnom srpskom jeziku, ili propadanje opšteg stanja, kvaliteta života i svega ostalo. Kada govorimo o neželjenim efektima. Dakle, oni na koje smo naišli su uglavnom nama već poznati i poznati su iz ostalih TKI-eva. Mučnina, povraćanje, dijareja, obstipacija i generalno oni imaju uticaj na kvalitet života, ali dok god su to, a najčešće su u velikom broju slučajeva, neželjeni efekti niskog CTC gradusa i dok god mogu da se kontrolišu uz upotrebu adekvatnih lekova i ne predstavljaju razlog za prekid terapije ili smanjenje doze, dotle je sve ok. A kod lorlatiniba je, dakle, upravo tako. Mogu se iskontrolisati kako treba sa lekovima ukoliko se na vreme prepoznaju i ukoliko se na vreme krene sa terapijom. Ovde ima, a verujem da će se i Marko i Natalija složiti, ogroman broj papirnih toksičnosti. Znači, jedno je elevacija asti i alt bez klinike koja govori u pravcu hepatitisa, u pravcu, znači, nekog razaranja hepatocita, a jedno je pojava simptoma žutica, hiperbilirubinemija i sve ostalo što nas može zateći, što znači moja ekipa, recimo, koja radi u dnevnoj bolnici, jako dobro zna. Dakle, ukoliko se pojavi paper toxicity, kod GOG gradusa bio bez klinike, to je toxicity koji zapravo treba da se prati. I ne znam koliko vidite, a vidite bolje na slajdu, dakle, incidenca, recimo, znači, svega ovog što je ispod, a znači, to su oni sada neželjeni efekti koji su nas sve jako zabrinjavali, a koji su zapravo toliko retki da ih ne vidimo baš mnogo i koje ne možemo baš u potpunosti da pripišemo svaki put i samoj terapiji, jer znate, prosek godina u Crown studiji je negde 65, što znači da godine idu mnogo gore, pa i mnogo dole, ima tu mnogo mladih pacijenata, ali ne možemo baš da kažemo da su olfaktorne i vizualne halucinacije nešto što je baš skroz izazvano lekom i pitanje je koliko pacijent zapravo može da definiše olfaktornu ili vizualnu halucinaciju. Sretali smo svašta u kliničkoj praksi, imali smo pacijenata koji su dolazili, koje smo skidali, rechallengeovali, dakle, zaista je bilo, ali ne u toj meri u kojoj se potencira na neželjenim efektima. Dakle, šta ako ipak moramo da smanjimo dozu? Ako ipak moramo da smanjimo dozu, ne dešava se ništa. Dakle, ovi Kaplan-Majeri koje vidite ovde govore u prilog tome da čak i onog momenta kad smanjimo dozu, zbog nekog neželjenog efekta, nemamo uticaj na PFS. Zašto nećemo imati još skoro OS? Zato što nakon 5 godina nemamo ni median PFS. Znači, OS ćemo moći da očekujemo negde za 7-8 godina od današnjeg dana. Ako ga budemo na kraju i imali i ostanemo, ili ćemo ostati samo na PFS-u koji je naravno bio i primarni outcome. Ono što znamo iz standardne kliničke prakse kod pacijenata koji su na hemioterapiji, pa ako ćemo iskreno, evo kod mene u klinici, a to je ono što znamo iz svakodnevnog životnog rada i posla, jako mali broj pacijenata će doći do second line-a zapravo. Dakle, najveći broj pacijenata će biti u takvom opštem stanju da neće moći da prime second line hemioterapiju. Druga stvar je second line ciljana terapija ili second line imunoterapija koja se mnogo lakše podnosi. I ovde u ovoj PTI stoji 93% je klinička deterioracija ili smrt, 7% je nešto drugo. Pitanje jeste šta ćemo posle i kakva se vrsta rezistencije javlja na prvu generaciju, drugu generaciju TKI-eva ili treću generaciju TKI-eva. Izlišno je sada govoriti o tome. Izlišno je u onom momentu dok ne dođe NGS, izlišno je uopšte pričati koje su to mutacije koje su važne, jer tek sa NGS-om mi ćemo biti verovatno u situaciji da onog pacijenta kog smo lečili lorlatinibom 3 godine, 4 godine, 5 godina, istestiramo NGS-om i vratimo ga na krizotinib. Dakle, na prvu generaciju, jer će ta rezistenciona mutacija zapravo biti u onom delu pite na koju će delovati sam krizotinib. Ili ako ne bude ništa, ići ćemo na hemioterapiju. Dakle, ovo sekvenciranje, u slučaju da razmišljamo da krenemo prvo nekom drugom generacijom, pa onda idemo na treću. Sećaš se, Marko, da je to bila priča i sa afatinibom ista, da smo pokušavali da sekvencioniramo 1000 puta, da idemo s prvom, drugom, pa dve prve, pa jednom drugom generacijom i nismo nikad uspeli. Kod alka će ovo dovesti samo do stvaranja klonova koje nećemo moći na kraju da lečimo ničim drugim. Dakle, rezistencioni mehanizmi na prvu liniju lorlatiniba kod pacijenata koji su bili u Crownu su, vidite kakvi. Dakle, bypass mehanizmi 30% i druge mutacije za koje nemamo odgovor 35%. Dakle, treba krenuti u frontline sa onim najjačim, šta ćemo kasnije, NGS će morati da odgovori. Neću uopšte da pričam o efikasnosti u prvoj i drugoj liniji, jer efikasnost u prvoj liniji je zapravo najvažnija. Ipak 64% pacijenata koji su primili neku subsekventnu liniju, znači neki subsekventni ALK ili hemioterapiju i angiogenezu, imaju dobru šansu da žive dalje. I verovatno ćemo ovaj slajd zapravo koristiti. Taj slajd pokušava da objasni sekvencu i pokušava da objasni šta se dešava sa PFS-om u sekvenciji. I znači ovu sekvencu, lorlatinib u Crownu i treatment beyond progression, koju god kombinaciju uzmete ovde dole, nikad ne može zapravo da dostigne. Dakle, da sumiramo, jako veliki broj pacijenata neće doći do druge linije i do šanse da primi lorlatinib ako krenemo sa alektinibom, brigatinibom ili nekim drugim lekom. Sekvencioniranje će nam samo napraviti veliki problem, jer sa sekvencioniranjem ćemo imati klonove s kojima ništa nećemo moći da uradimo. Prva linija je ovo što je Marko pričao, Crown studija, ta koja je definitivno indikacija za lorlatinib i ni jedna druga, ako ne mora i ako postoji mogućnost, i jednostavno CNS metastaze će se sigurno javljati kod ove populacije pacijenata, ali najmanja šansa da se one jave je zapravo ukoliko je pacijent na prvoj liniji lorlatinibom. Ostaje 20 minuta za Nataliju i za klinička iskustva. Hvala na pažnji.
Jeste. ALK ekspresija je vrlo retka mutacija, prisutna u 3 do 5% pacijenata. Međutim, ti pacijenti kod kojih otkrijemo prisustvo ove mutacije imaju pravo da očekuju potpuno izmenjenu sudbinu i drugačiju prognozu u odnosu na sve ono što smo doživeli u metastatskom karcinomu pluća i lokalno uznapredovalom i tako dalje i tako dalje. E sada, nakon što smo prespavali 10 godina od ulaska krizotiniba kao prve generacije, gde je toliko i toliko života moglo biti na drugi način proživljeno, jako smo se obradovali kada su ušla 2 leka na pozitivnu listu druge generacije, to je alektinib i brigatinib. I to se desilo tek 2020. godine. Naša iskustva su toliko fantastična sa ovim lekovima da smo se malo razmazili i da sada sa punim pravom očekujemo, jer znamo da postoji nešto još bolje. Međutim, nažalost, u našoj državi lorlatinib se ne nalazi na pozitivnoj listi ni u prvoj liniji, ni u drugoj liniji. Ono što smo mi mogli da steknemo iskustvo, to je pre svega započelo sa donacijom upravo kompanije koja je naš današnji domaćin, tako da smo za 6 pacijenata dobili lekove gde smo pacijentima u drugoj liniji primjenjivali lorlatinib. Kasnije smo tu tradiciju preneli na takozvani naš član 9, to je na jednom sastanku dr. Markose i ostale kolege iz susedne nam regije zapitali šta vam je sad to pa član 9. To je jedna specifičnost u našoj državi da u takozvanim iscrpljenim terapijskim mogućnostima. Svaka ustanova, uglavnom su to tercijarnog tipa, na svoj način uspeva da obezbedi svojim pacijentima lek, a da kasnije ta sredstva nadoknadi od Republičkog fonda zdravstvenog osiguranja. Tako da za one viđali smo i takve kolege koji su nam rekli pa dobro, ta ispitivanje i te analize, to je negde nekakav svet i tako dalje, pa ne verujemo mi da je to baš tako. Tako da ja mogu samo kroz naše iskustvo i to primene lorlatiniba u drugoj liniji, odnosno u sekvenciji, da prikažem da li se išta od ovoga o čemu pričamo pokazalo i u praksi kao tako efikasno i bezbedno i nešto što do te mere menja kvalitet života. Tako da ću ja svoje iskustva, to jest naše klinike, prikažem kroz 4 pacijenta, od kojih je ovaj prvi o kome ću pričati je najmlađi, 42 godine, ostali su u 7. deceniji, svi su bili nepušači i vidjet ćete poslednji pacijent je bio bivši pušač, da skratim priču po sistemima, jer ovde želim samo ugrubo da prinesem koje je to bilo bogatstvo života i raznih komplementarnih terapijskih postupaka. Tako krećemo sa prvim našim pacijentom i praktično dalekom 2015. godinom, kada je pacijent vac biopsijom pleure desno sa skenerom verifikovanim i bilateralnim metastatskim promenama u plućima, gde se klinički ispoljavao toliko intenzivan bol da se nikakvim analgeticima gotovo nije mogao adekvatno kupirati, dokazana je adenokarcinoza pleure sa prisutnom ALK ekspresijom. Pacijent je imao neverovatnu sreću da je u to vreme počinjen na našem centru ALEX studija i on upada na granu lečenja sa krizotinibom. On probija očekivano vreme do progresije, gde biva lečen prvom generacijom krizotiniba sa čak 3 godine. I prva progresija zapravo nastupa sa CNS metastazama, pri čemu skener grudnog koša pokazuje gotovo kompletan odgovor koji se do dana današnjeg održava, a pri čemu nakon samo nekoliko meseci primene krizotiniba pacijentovo stanje se izuzetno poboljšava u svakom pogledu, a obezboljavanje praktično trenutno. Promene na endokranijumu su bile multiple, ali ipak dovoljno dobar teren da se sprovede neurohiruška intervencija gama nožem. U isto vreme, ponovo sreća za našeg pacijenta, stiže nam lorlatinib u donaciji, tako da se on praktično odmah sredinom novembra, zapravo sutra će biti tačno 6 godina od kada je pacijentu uključen lorlatinib. Nakon lokalne kontrole bolesti, gde se praktično postiže potpuna regresija promena u endokranijumu, pacijent nastavlja uspešno da se leči lorlatinibom, gde se nalaz u grudnom košu održava kao što je i postignut, sa fantastičnim kvalitetom života, i on je praktično sada u 10. godini od kada se leči tirozinkinaznim inhibitorima. Tako da ovo je jedan primer pacijenta koji oslikava ono što je do sada više puta rečeno, a pogotovo za pacijente koji su lečeni krizotinibom, da prvo mesto progresije kod tih pacijenata lečenih prvom generacijom u 40% slučajeva je upravo CNS. Sledeća pacijentkinja je specifična po nekim drugim situacijama. Ona je skenerom grudnog koša je početkom marta 2019. godine uočena promjena najvećih dimenzija do oko najveći dijametar oko 6 cm u levom donjem režnju, ali u istom režnju postoji i metastatska promjena i kontralateralno u desnom gornjem režnju postoji jedna manja promjena 5 mm. Nekim svojim ličnim putevima i snalaženjem i tako dalje, pacijentkinja biva operisana, sprovedena je lobektomija 1. aprila 2019. godine. Patohistološki nalaz je adenokarcinoma sa prisutnom ALK ekspresijom. MX, odnosno u to vreme praktično ona promjenica kontralateralno nije shvaćena kao metastaza. Međutim, mjesec dana kasnije skenerom grudnog koša jasno se evidentira metastatska bolest, obostrano u plućima postoje prisutne metastaze i pacijentkinja počinje da se leči praktično odmah. Ovo je inače dobar primjer brzog dejstvovanja, odnosno onog što nam je prioritet, brzo do dijagnoze, brzo od dijagnoze do leka. Dakle, ona počinje odmah da se leči primjenom alektiniba, također u, da kažemo, ličnoj režiji, zato što u to vreme lek nije bio prisutan na pozitivnoj listi. Međutim, vrlo brzo, nakon nepunih mjesec dana, pojava neurološke simptomatologije i uradi se skener endokranijuma i tu se uočava parijetalno jedna promjena, jasno da je to metastaza i biva opet s procedura stereotaksično radioterapija gama nožem i pacijentkinja na taj način postiže lokalnu kontrolu bolesti i ovo je također primjer pacijenta gde je potpuno jasno da su ovdje bile prisutne asimptomatske metastaze i da su se prosto u datom momentu samo ispoljile i nažalost takav broj pacijenata koji u baseline-u ima CNS metastaze kod pacijenata sa ALK ekspresijom je čak može ići i do 80%. I pacijentkinja ima sreću da odmah nakon sprovedene gama nož intervencije ubrzo ulazi u program donacije i ona kreće sa lečenjem lorlatinibom od početka juna 2019. godine i evo do sada više od 5 godina je na terapiji sa sjajnim kvalitetom života. Sve smo videli ove fantastične krivulje, samo još jednom reći, evo, to je ta razlika između krizatiniba, lorlatiniba kod pacijenata koji startno imaju metastaze u baseline-u na endokranijumu i bez, vidite na tom petogodišnjem preseku, čak 83% pacijenata koji se leče lorlatinibu su bez intrakranijalne progresije, a 96% kod onih koji nisu imali u baseline-u. Sada sljedeći pacijent je prvo imao operaciju karcinoma bubrega radikalnu avgusta 2019. godine. U svemu tome, u sklopu osnovnog skrininga uradi se naravno skener grudnog koša, abdomena i nažalost tu se uoči u desnom gornjem režnju mala promjena do 3 cm, manje od 3 cm, konglomerati žlezda u medijastinumu, praktično to je bila kao N2B subdivizija i nažalost metastaze u jetri i na kostima. Uradi se bronhoskopija, dokazan je adenokarcinom porekla pluća i prisutna ALK ekspresija. U datom momentu, naravno ponavljam, nismo imali ove lekove za tirozin kinazne inhibitore za ALK ekspresiju na pozitivnoj listi i pacijent je počeo da se leči primenom hemoterapije. Nakon 2 ciklusa platinskog dubleta, jasna progresija i pacijent sad ponovo ima sreću, ulazi u program donacije na drugu generaciju, dakle, tirozin kinaznih inhibitora, to je bio brigatinib. On u međuvremenu sprovodi lokalne procedure kontrole bolesti kao što je radioterapija lediranih kostiju. Sredinom januara 2020. počinje lečenje brigatinibom i to lečenje traje punih 4 godine, a u međuvremenu je sproveden i SBRT, to jest X-nož intervencija, radioterapijska promena u jetri. I tada se ispoljava nakon 4 godine jedna strašna neurološka simptomatologija gde je pacijent potpuno nepokretan, dizartričan. Urađen je magnet endokranijuma i tu su viđene multiple promene endokranijuma, a takođe i u ponsu, mezencefalonu i brojne promene prema produženoj moždini. Dakle, pacijentu se borimo za nastavak lečenja i poboljšanje na taj način što pristupamo takozvanom članu 9, gde uspevamo da dobijemo lorlatinib po članu 9 i on je lečenje započeo marta meseca ove godine. Neposredno posle toga uporedo se sprovodi i whole brain radioterapija i, dakle, uspešno je sprovedena bez ikakvih toksičnih posledica, nije prekidao terapiju lorlatinibom i pacijent vrlo brzo postaje potpuno pokretan, funkcionalan i takvo stanje se održava, evo, to je sada već druga kontrola posle pola godine. I poslednji pacijent je pacijent kome je adenokarcinom u desnom gornjem režnju najvećih dimenzija do negde oko 6 cm sa medijastinalnom limfadenopatijom, bronhoskopski dokazan i sa ALK ekspresijom prisutnom u lokalno uznapredovalom stadijumu bolesti i novembra 2022. započeta je terapija drugom generacijom tirozin kinaznih inhibitora, to je alektinib i lečenje se vrlo uspešno sprovodi i vrlo brzo sledi odličan odgovor sa parcijalnom regresijom svih uočenih promena. Takođe, u međuvremenu, obzirom na sjajan odgovor, uspeva da sprovede i lokalnu radioterapijsku proceduru, tako da je ozračen tumor i limfne žlezde, dakle, primenom standardne radioterapijske tehnike. Međutim, nakon 16 ciklusa alektiniba evidentira se progresija bolesti, sve dimenzije se ponovo uvećavaju kako tumora, tako i limfnih žlezda i tako da smo se u istom momentu kao i za prethodnog pacijenta izborili da pacijent primi lek lorlatinib po članu 9 i evo i on više od pola godine se uspešno leči. Svi pacijenti imaju sjajan kvalitet života i ovo su poruke koje su već sve izrečene, da sa ovim lekom zaista i potpuno dokazano u realnoj kliničkoj praksi imamo fenomenalno superiorno preživljavanje, bezbedan profil lečenja gde na sve ono što možemo da očekujemo znamo da dočekamo te neželjene efekte i da ih rešavamo i da nekakav strah od pojave neželjenih efekata treba da nas limitira u izboru najboljeg leka. Samo je poenta i poruka da ovi dugoživući pacijenti moraju vrlo promptno i učestalo da se prate, da budemo u stalnoj komunikaciji kako pojava neka od neželjenih dejstava ili bilo kakve situacije može da kompromituje efikasnost lečenja pacijenata. Hvala na pažnji.
I evo, ja ću sa ovim polako da privodim kraju simpozijum kompanije Pfizer, da vam se zahvalim što ste sa nama ostali do kraja, da vam definitivno kažem da Lorlatinibu jeste mesto u prvoj liniji sa hazardom 0,16, 0,05, 0,02, apsolutno nemamo o čemu da pričamo kada je u pitanju pozicioniranje ALK inhibitora i gde treba da mu je mesto, a sve ostalo onog momenta kada terapija započne, kao što ste videli od Natalije, može vrlo uspešno da se rešava. Hvala vam lepo i želim vam ugodan ostatak večeri. Prijetno.
Milane, hoćeš da sedneš? Milane, sedi. Okay. I'm so sorry that we don't have more participants here, but I know that they are at the exhibition area. Maybe they will just show up at one point. First of all, I would really love to congratulate everyone for organization, everyone who helped, and to thank you guys for accepting the invitation to participate, because I think this is important that ESSO and ASAC have to be present at our Congress yearly. And I hope that maybe awareness of people will change. Maybe if we sanction those who don't come, maybe then they will start coming, but otherwise there is no chance that we can motivate them further, other than the measures that we already took, we inviting them personally. So apologies for that, because it was not possible to provide more audience. And thanks a lot for being here. Today's session is practically a workshop that we designed to help young people who are interested in research to get to know the first steps on how to do so. Wim Celine, who is a person who is very important to us in the ASAC Research Academy, helped me organize the structure of the session. We will have 2 talks and then 2 important talks on the research and RedCap platform that will be provided by Wim Celine and Dara London. So you can freely ask them anything while they present, and the introductory talk will be done by me and also John Henry, who will talk about disparities in cancer treatment, which is really important and a hot topic in the world, and we will try to address for future research on this department. So to start with what we are, actually some of these people who are here already know, because I talk about that very much in my hospital. For others who don't, we are the actually European Society of Surgical Oncology, who was founded back in 1981, and first it was only European society, but then it spread more worldwide. With the mission to advance science and practice of cancer surgery for the benefit of patients through education, research and innovation, and of course multidisciplinary care. As I said, it started as European society, now it's much wider. We have a lot of representatives and presence worldwide. So talking about 3 pillars of our mission, that is to cure cancer together, it's education, harmonization, and partnership and advocacy. Now we will see why this is important to have all these 3 present all the time in our activities. Education is basically the important platform for everything, not only for society, but also for meetings like this and for our everyday practice. If we don't improve, so we can't provide the best care for our patients. ESSO is doing wonders in education. We design congresses every year who are up to date, presenting hot topics in specific areas. Also, we have training and fellowship programs that are certified, which is really important for any society to provide to their members. And of course, there are a lot of other educational events that we organize, webinars, courses, hands-on courses. You all know because you're on the mailing list, so you receive this newsletter and all the information about the events that ESSO provides for their members. There are a lot of benefits for members, discounted rates and other things. So there are a lot of important benefits of being a member of ESSO. Regarding harmonization, what is one of the most important missions of ESSO is promotion of surgical oncology as individual discipline. We also try to do that in Serbia, some of you may know, but it is a really, really hard thing. So you can imagine how hard it is when ESSO is doing it in the international platform. There are so many different activities, advocacies that they start in order to have this enabled. Also, ESSO participates in multidisciplinary guidelines, and we promote research in different ways that we will talk about in a few minutes. Regarding partnership and advocacy as a third pillar of our mission, it is important to say that ESSO is actively involving patients' organization in decision-making and also promoting advocacy actions that are based on evidence. ESSO has a strong network of national societies. You are all members of Serbian Society of Surgical Oncology, so you know that we are a national affiliated society within ESSO, but there are many societies worldwide and a lot of partnerships with the different societies that are dedicated to cancer. Also, ESSO has a lot of strong connections with the industry, which is really important, because if you combine education, good contents, big network with the membership, and also engaging members from low middle income countries, including patients and industry in all this, it is the best way that we can reach excellence in surgical oncology and improve our patients' outcomes, which is actually the main mission of ESSO. There are many things that ESSO is dedicated to. Among these is to provide optimal care for the benefit of cancer patients, to ensure quality care by educational skill improvement, which I explained how important it is, and we all learn every day. This is what needs to be done when we are doing this field. Also, ESSO is positioning surgical oncology at the heart of cancer care and promoting research and innovation, which I also mentioned. There are several goals of ESSO. One of them is, of course, Congress, which has the aim to update knowledge and practice in every surgical fields that are connected to oncology. Second one is education, as I said, to set the standard for the training, qualification, examination across the Europe. Third one is research to improve quality of care and patients' experience and outcomes. Fourth one, advocacy, to promote optimal surgical care through the standardization of education and qualification of surgical oncologists. There is also the next goal regarding membership, which aims to engage cancer surgeons to grow our big surgical oncology community worldwide. And of course, last but not least, communication, because we aim to establish a strong platform to position the voice of ESSO and all our members strongly. Basically, the structure goes like this. We have General Assembly, and the Board of Directors is directing the activities of ESSO. All these five structures have representatives in the Board of Directors, and there is ESSO Secretariat, which is actually the most important part of ESSO, because they make this all happen, and they work just behind all of us, helping in the educational activities, in the Congress organization, and many other things. This is current board that was promoted recently, and I'm proud to say that I became part of it as a chair of ASAC. What is ASAC? ASAC was formed thanks to our seniors at ESSO. It was formed in 2016 with aim to help junior surgeons and surgeons in training like you to play an active role in the future of surgical oncology. We aim to facilitate networking, to help junior surgeons with academic research, and to ensure that surgical oncology training throughout Europe is specially tailored and uniform towards young surgeons. It's from a little group of national representatives back in 2016, it has grown significantly and became a pathway for young surgeons to make an impact on surgical oncology globally. By connecting and collaborating in the research, this way we can contribute to the mission and vision of ESSO. So we are not separate from ESSO, we're just a little branch. But I don't think young surgeons or any medical oncologists are this visible as we are in ESSO. This is what makes this society quite special and unique. There are many benefits of becoming members. That's why we did sign the contract between ESSO and our national society. because all our people who are members of ESSO have benefits that are listed here. You can take different exams that are certified by important European institutions. You can apply for fellowship grants, you can get support for ESSO Congress, and you have a lot of networking opportunities which obviously people don't use even when ESSO and ASAC session is happening in Serbia. But this is what we actually try to do. I'll skip through this. These are the past ASAC chairs. I'm proud to say that I'm the 5th one. As you see, there is no gender bias, so it's not important if you're a man or a woman. They just select you based on your contributions to ESSO, not based on your other things, which country you're from or whatever, because I'm from Serbia and nobody cares about Serbia. We are outside the European Union. You all know how underprivileged we are, but still here we are present at ESSO significantly. So I think this is very important to emphasize regarding ESSO. This is our structure. We have national representatives. You know that Milan was the national representative from Serbia after me. Then now there is Nikola, who is not present. Also, we have the core group that is practically leading the ASAC, and the research academy that has been designed as mixing practically members from national representatives and a steering committee, so including anyone who is interested in research. It doesn't have to be somebody who has a specific role within ASAC. ASAC steering committee group has a lot of activities to promote ESSO, to enable a connection between young members of ESSO and the board. We provide connections with the potential mentors for academic research, for fellowships. So we are present at the ESSO board finally through ASAC chair. So also we participate at education training committees, which is important. Every education training committee, the working groups have representatives from ASAC steering committee. This is the current group of ASAC steering committee, and as you see, Nikos and John are here today among them. Research Academy, as I said, is a nice platform for research, and it was designed in the challenging years of COVID. So it was the only possible solution to make collaborative work happen, since we could not meet. And the designers of the academy were actually current chairs, back then chairs of ASAC, Laura Lorenzo and Andreas Brandl. And we have the senior lead in the Research Academy, which is Wim Seelin, who is kindly here today with us. And he will give this important talk that I announced in the introductory part. So yes, national representatives have important roles. It's not just a fictive role. You saw that I worked a lot in previous years. So it's not just an honorable role. You have to be an ambassador for your country within the ESSO, also be important link between the society and the ESSO. And by that, we engage more people from Serbia to be active at ESSO platforms, at our webinars, courses, which I still think that it's not enough. Even when we have completely free webinars, it's only the same people participating. But it obviously has to do with mentality. We, in general, as national representatives, can contribute to for ESSO mission and vision to be seen, present, not only in Serbia but in region. I tried when I was national representative along with Milan to include as many possible people in the ESSO through our National Affiliated Society of Serbia. So now we have over 100 members, thanks to us. And those are people from Montenegro as well, from Bosnia. They don't have national society, so they decided to join ESSO through us, actually. We will skip through this. I just want to emphasize that ESSO is no longer just a European society, and national representatives also are not only from European countries, but also from Asia and Africa. It is, of course, difficult for these people to participate, but you can be really surprised that these people actually attend ESSO congresses usually. So they travel far and reach the ESSO. It is a very big privilege when you don't have to travel and you can attend it here. There are many activities. We are present in research. We have our specific session at the ESSO Congress, which I hope that you will attend one day when you attend the ESSO Congress somewhere abroad, or maybe if we make it ever in Serbia possible to organize the ESSO. We have collaborations with young radiologists, young medical oncologists, many other collaborations with ECHO. So it is important to emphasize that there are a lot of activities. You can be engaged in many of these. You can be participants in these webinars and everything for free, mostly. I would proudly say that the ESSO 1 year more in a row endorsed our Congress as a Congress of interest for them, which is a big privilege. Maybe people are not aware of that, but I would like to emphasize that it is. We have a lot of activities planned in future. We have a lot of energy. We will focus on mentorship, on addressing disparities in surgical oncology training, on early research engagement of young people, on women as leaders, and on surgical innovations, of course. So I hope that you will be in tune with all the activities educational that ESSO platform is offering that are for free, and try to join them or access after it happens, because the recordings are always available. And I invite you to stay until the end of the workshop to see what we will talk about together today. Thank you. I would ask maybe John to give his talk now as introductory part of workshop, and further we will move on to the more specific part on research. John is from Spain. Originally from Peru, this needs to be said, and he will talk about cancer disparities in the world.
Okay. Hello everyone, I'm John Herrera. First of all, I would like to thank to the organizers of the Congress, Dr. Markovic and Nada. Thank you very much for the invitation. It's my pleasure to be here with you tonight. My goal tonight is to talk to you about disparities in cancer care. And I have no disclosures for this talk. These are data from the Globocan 2022, the last published report from them. And we see that around 20 million cases, new cases of cancer were diagnosed in 2022. And almost 10 million deaths. This means that we have around 50% mortality for all cancer sites all over the globe in this year. We also know from this data that there is an uneven distribution of incidence, mortality, and prevalence, mainly because of geographic issues, but we will see that there are other factors that contribute to this. From this data, breast cancer is the second cancer in incidence and the fourth in mortality. And we can see that there is a wide variety in mortality rates around the world, depending on where you were born or where you live. So disparities in cancer care are differences in cancer outcomes across various groups. And we need to understand that despite advances in cancer care that we have nowadays, not all patients benefit equally due to barriers that are mainly linked to socioeconomic status, race, geography, and healthcare access. As an example, we have here uterine cancer in the US, and we see that the mortality doubles in African American populations. There are some factors that contribute to these disparities. Socioeconomic status, for example, we know that the level of income that patients have contribute to these disparities in the access to screenings and treatment. And we see here that the lowest the income level, the lowest access they have to screening programs in colorectal cancer in this case. We also have geographic location. The typical comparison that we make that we see in studies is urban versus rural areas, where rural patients may lack specialized oncology centers nearby, so they have to travel. But also in urban areas, like in this case, this is Detroit, this is in the area of Detroit, depending on where you live, and not only that, but also your race and income level, you can have a higher probability to have some types of cancer. In this case is colorectal cancer. We also have racial and ethnic differences. This is a study on breast cancer in Africa where they compare the outcomes of black and white people in Africa. We see here that the outcome is worse in black people, and then they compare these two lines over these two lines here. They are white and black women in North America, in the US. So we can see that there's a difference because of race, and there's a difference also because of the setting. We also have language and cultural barriers. We know that traditionally black and Hispanic or Latin American populations have worse outcomes than the white population. And of course, we have to say that this is related to quality of life in one hand and to survival in the other one. What we can say about this type of studies in disparities is a typical case, or the main studies have been focused on breast cancer. And despite having similar incidence rates than white or other communities in the US, black women have 40% higher mortality rates. And this is because they have limited access to early screening, they have delays in diagnosis, and they have difference in treatment. In this case, this graphic shows the access they have to radiotherapy for breast cancer. And we can clearly see that there is a big difference between black population and others. So disparities have an impact. Delayed diagnosis, we have fewer treatment options at the end, we have lower survival rates, and we have an impact, especially in underserved communities. We need to remember that we have a healthcare continuum. So we have prevention, detection, early detection is possible, treatment, follow-up, and survival and quality of life. Now, let's imagine you or one of your relative is diagnosed with cancer. Then we have a cancer treatment plan, our guidelines. But imagine you don't live in a country where you have universal access to healthcare. So you will have to pay or co-pay in the best scenario for your diagnosis, for imaging, for your treatment, and also to visit your doctor for your follow-up. Sometimes if patients live in a rural area, they have to afford for this travel expensive, accommodation, and the consultation with the doctor. So this is called financial toxicity. This is higher cost, and depending on the characteristics of the patient, maybe if it's not an economically active patient, they will face worse outcomes. They will have a financial impact, not only for them, but also for their families. They have less access to care, less access to oncological treatment and to follow-up. They will experience emotional distress because of this, and they will have inferior quality of life, and of course, worse outcome, worse survival. I have to mention here that there are some studies that say that around 5 to 10% of mortality nowadays can be improved if we eliminate these disparities. And this is in a global way. But if we see, for example, in the US, like it's around 35% of mortality can be prevented. 1 in 3 patients in 3 deaths for cancer can be prevented. This is very important that we need to consider. So now that we have a better understanding of the complexities that we have with disparities, we need to know that the solution is not only, it's not simple. We will need policy interventions, community outreach programs, research and data, which is very important, and culturally competent care. So we need to prepare for this. In the case of our careers, our specialties, we are the providers where we need to be culturally sensitive and we need to provide a patient-centered communication. We are not the center of the world, so we need to understand that our patients, they are different, they have different knowledge, they have different expectations, and we need to take this take this into account. I always tell to my residents, it's always better to be in the position of the person who can help. We need to remember this always. And regarding policymakers, well, they need to prioritize funding of underserved populations and incentivize equitable healthcare practices. This is good. I don't know about you, but I don't believe in politicians. I don't trust them. So this means that we need to do the work, okay? And for researchers, maybe this is your case, we need to focus on underrepresented demographics in clinical trials and on outcome studies. In conclusion, guys, disparities are preventable through targeted interventions, but please, we need to prioritize and advocate for equitable cancer care in our respective fields. It's in our hands to do this. We cannot expect that the politicians take decisions or they take the lead on this because they don't even know how to deal with these things. We can do things, we can start in our local settings, and I think this is the beginning of the change. We cannot change things if we don't start by ourselves. And remember that when everyone has an equal opportunity to be as healthy as possible, this is what we call health equity, not other thing. I go down?
No, you stay for the questions.
Okay.
So thank you, John. Excellent talk. And you really touched upon a topic that is really a matter of justice. I think in a just society, there should be no inequality, structural inequalities, as the really shocking examples that you showed from the US. Are there any questions or comments or remarks? So you mentioned that we should not trust politicians too much, but the only major change that is possible is, of course, through the political level and how society is organized and healthcare systems are organized. For instance, in the US, it was thanks to Mr. Obama that now millions more of Americans get access to even basic healthcare. So what do you think our impact can be? Because, of course, we don't have the leverage and we don't have the power to change things. Everything has to go ultimately via funding and healthcare systems. So if you don't trust politicians, you want to bypass them, how would you do it then? I
don't trust them because I don't think they are proactive in this sense. We have some exceptions, of course. But I think the message is that we should not wait for them to start. We should start. We should start doing the research and providing the data that our patients need to change this. And of course, you can always exteriorize this, but we need to remember that at certain point in your life, if the cancer previsions that we have for future years are true, that you or someone in your family is going to be in this situation. So, you know, being that in ESO we are, in our group, We are working on this. We don't think that this will change immediately the things that the problems that we have, but we think is a good starting point. This is the message. And as I was saying before, we need to think in our patients. We need to put ourselves in their places because it's not easy. Sometimes I think that you become a better professional, a better doctor when you experience disease in yourself or you experience disease in your close relatives, you know? This is very important. And of course, we also have the experience from our friends and colleagues from Africa, from Asia, and we know the situations they live there and what the amazing things they do with very few things. I think this is an inspiring situation for us, and we should work together for it.
Yeah, maybe starting projects that can like detect what are the vulnerable situations and where the problems lie. We can initiate something. It can be initiation of this. But as I said, the ESSO is doing wonders in the global level thanks to the evidence-based advocacy and trying to implement surgical oncology to uniform the cancer access and the patient care worldwide. This is why I emphasize that these activities can really contribute globally, because this can also be a good example for other societies to join, and we are joining actually our missions together with many societies, and I think we can work on that even more, right?
Thank you.
Thank you, John, for an amazing talk. You really addressed disparities nicely. It is now the time for Nikos and I to introduce our esteemed speaker, Wim. As I said, he's senior at he's not so senior, but he's senior at the Research Academy of Young Surgeons. So in that terms, yes, and he's an amazing advisor. Whatever we have any idea, he's the one who helps. He's a surgical oncologist professor working at the University of Ghent in Belgium. So welcome, Wim.
Thank you, Nada, for the kind introduction. So what do you need if you want to be like a surgeon scientist? And I hope you all have this ambition. First of all, you need some time, some protected time. It's often difficult to combine and to reconcile the duties and expectations of your chief of department, who needs to generate income for the department, to get everyone paid, all salaries paid. But what is often possible is that not everyone has really the ambition to do research. And so if you are in a group of like 10 staff members, that 8 of them are really focusing on clinical work and 2 of them are focusing more on research. And that's how we do it. Of course, everything starts with having data and having samples, and we are at the source of samples and the possibility to take biological samples, so collect them. It's not so difficult. You need a biobank and prospectively collect data. It's really a bad idea to wait until you have treated 100 patients and then you say to your medical student, go to the archive and take out the last 100 files of rectal cancers that we treated and then do a retrospective study. That's probably not going to end up in good science. Collaborate. Nada has very elegantly shown the success of the ASAC collaboration, but there are many collaborative networks that exist, and I will give you some examples. And you should, of course, collaborate with basic scientists, with AI specialists, with radiologists in order to start with translational research specifically. And also, if you want to do research, if you want to do science, you need to have skills. If you want to be a surgeon, you need to learn surgical skills. If you want to do research, you need scientific skills. And you can learn them. You can learn them easily. You can learn them for free. And so the skills that you need is, of course, English language. And English is the Latin of the modern world. But I think the younger generation has no trouble with acquiring English language skills. You should know how to write a decent article, how to apply for a grant. you should know how to do data analysis and data visualization. For example, using R. And R software is completely free, R Studio. If you really want to push it, you can learn Bayesian techniques, and I will give you an example of a paper where everything is explained at a really basic level. And many of you are probably familiar already with machine learning, artificial intelligence, with coding in Python, etc., etc. So I think for the younger generations, this should be not so much of a hurdle. The right arrow, yeah, I'm pushing it, but... okay, now it's... So if you want to get started with R, it can be a little bit daunting and a bit frightening when you have a first look at it, but really the learning curve is very short. It's quite easy to learn. And go to this website. This is a free book, a free online book that really starts with the basics, how you use it, and then a lot of examples in biomedicine, how to do Kaplan-Meier analysis, how to visualize data. It's really easy and it's completely free. So just go for it. And this is an example of a paper. It's still a pre-proof, in fact, of a paper that explains really very nicely how you can do a Bayesian reanalysis of results. This is cardiovascular trials, but you can do exactly the same thing, of course, in the field of surgery. And it gives you, in a supplement, in a GitHub site, all the code in R that you can just copy and paste. So I would really, if you're interested in Bayesian statistics, and this is really the new kid on the block for several reasons, which I will not discuss, but if you're interested in it, this is really a nice introduction. It's very easy to read, and it's focused on clinicians. It doesn't have formulas or mathematics or other difficult stuff.
Guys, what's happening? Что значит strelice?
Yeah, this is an example of some of these collaborative initiatives that already exist. And so the Global Search, you may know it, ASAC has been mentioned. STAR Search, which is a collaboration of surgical residents in the UK. The Canadian Network of Residents in neurosurgery, etc., etc. And so these are very successful. And why are they successful? Because they collaborate, they can do international trials, collaborative trials, which are, of course, an asset because it's easier to gather more data, more patients, and also the external validity will be, of course, much higher if you do multi-center trials. So how do you motivate surgical residents? Of course, if from the start you're really focused on doing clinical stuff and treating patients and you don't have any interest in research, then yeah, okay, it's like that. You will never motivate such a person. But it is possible to motivate people, and the most important thing in my experience is that you work in an environment that is conducive for research, where you have a culture, an appropriate culture of research and of critically questioning what you are doing. And why are we treating patients like this? Why don't we remove drains earlier? Why do we do this? Let's take a look at the evidence. Let's go to PubMed and have a look. So a culture of inquiry and of scientific curiosity, that's where it starts. Of course, it helps if you have specifically defined scientific curricula for the residents, if you have journal clubs, if you provide funding for conferences, etc., etc. Translational research starts with biobanking and prospective data collection. There I will talk about the REDCap platform, which is also free, by the way. Don't use Excel. Don't use Excel to keep a log of your data, of your clinical data, of your patients, of where your samples are located. It's just not suited as a database. It's a calculation sheet. It's very good for people who are doing financial logs, etc. But for a medical database, it's unsuitable. You should use like REDCap. That's really the gold standard. And you should identify partners. As a surgeon, you are an interesting partner. I really get several times per year questions from our basic science labs. Please, can we get samples? Can we get healthy samples? Can we get cancer samples? And that's a way to start collaboration. First, of course, the only thing you will do is you provide them some samples and you will be a co-author or you will have acknowledgement. But then later, you will have the opportunity to submit joint grant proposals, so that you get money as well, for instance, to pay a study nurse and to do in parallel a clinical trial and a translational trial. And that's one of the scenarios that really work well often. And ideally, you should get a working knowledge of the methods that the basic scientists are using. For instance, now, single cell sequencing and single nucleus sequencing and spatial transcriptomics are very hot. And make sure you have at least a superficial knowledge of what these techniques can do, what they are, and what these plots mean, etc., etc. So for clinical research, everything starts with a hypothesis. If you don't have a hypothesis or a scientific question, then don't bother starting a clinical study. You should have a real question, which is often based on clinical observation or on clinical needs that you perceive in patients. And there should be hypothesis. The next step is to decide on an appropriate study design. Should it be a randomized trial? If it's randomized, should it be a superiority trial, a non-inferiority trial, a pragmatic trial, etc. You should follow a number of guidelines, ethical guidelines and methodological guidelines, which are open source, which are available, which you can look up. Follow them. The guidelines are there, follow them. I very, very often, because I'm editor of a surgical journal, get reports of randomized trials that I have to reject at the desk, that I don't send out for review, just for the one reason that the guidelines that exist, like the consort guidelines for randomized trials, were not followed. But they are there, they are freely consultable, and everyone can use them. So stick to the guidelines, look up what the guidelines are, and then develop your protocol. Decide on the endpoint, the sample size, etc., etc. I'll give a few details on that. So there's a kind of taxonomy in clinical trial designs in any field of medicine. And so case reports, surveys, retrospective case series, and chart reviews are sometimes called cohort trials, but in fact a cohort trial is really an observational prospective trial. And then you have, within the prospective trials, there are the observational ones. For instance, in epidemiology, you have the Framingham cohort study, you have the nurses' health study, where large groups of persons are followed prospectively over time with the aim of making correlations between their healthcare status and their lifestyle, smoking, exercise, etc., etc. That's an observational study. But then you have the interventional studies, prospective interventional studies, and only those are really termed, from a legal point of view, clinical trials. And it's for that type of trial that you need informed consent, and that you need to submit a protocol to your IRB. So that's a clinical trial. So it's an interventional prospective trial, where you intervene in the patient. You give a treatment, or you implant a pacemaker or another medical device. That's an interventional trial. And they can be randomized, non-randomized, quasi-randomized, etc., etc. So about the ethics, this is universal. This applies in Belgrado, in Brussels, in Colombia. It applies everywhere. The basis is the Helsinki Declaration. So the Helsinki Declaration is the basis of also the ICH Good Clinical Practice Guidelines, and you should have a written informed consent whenever possible. Of course, in patients who are unconscious, in children, etc., there the legal representative can provide the written informed consent. And there are some designs that are questionable. For instance, if you want to perform a study trying to address a question that has already been answered. A typical example, does it make sense to do extensive lymphadenectomies in gastric cancer? No, that doesn't make sense. And if you do a splenectomy, etc., you will harm the patient. We know that, we knew that, but still, after 5 years, there was another study from another country that tried to address the exactly same question, which was already answered in a convincing way. So that's not ethical. And then you have these partial consent designs, for instance, the Zelen design, where you first randomize the patient, and then you inform the patient that she or he was randomized and allocated to a specific treatment. And this is not very ethical, and in very, very, very specific circumstances, this may be an option, but usually it's not ethical to first randomize and then ask the consent of the patient. And if the patient is recognizable, in surgery it's in head and neck or ophthalmology, and often patients are, well, case reports or other reports where a photograph, digital image of the patient's face is being published, then the patient needs to give an additional consent where she or he knows and declares to be aware of the publication channels that will be used to spread this image. Yeah. So watch out for integrity issues. There's a lot of falsification, there's a lot of fabrication, and the risk is higher in academic medicine than in pharmaceutical research, because in pharmacy everything is very, very well controlled, and there are audits and paper trails, etc., etc. But in academia, there have been a lot of scandals, and so don't do that. And one of the typical examples is harking, and that stands for hypothesizing after the results are known. That means you do a study, and you look at your primary endpoint, the p-value is not what you want, and then you pick another endpoint, which is significant. And this is called harking, and that's why nowadays all trial protocols should be registered, for instance at clinicaltrials.gov, before you start the study, not after you have completed it. No, before you start the study, you should register at clinicaltrials.gov, EudraCT, and China has its own repository, Japan has its own repository, etc., etc. Watch out when using AI and ChatGPT. You can do it, but at least be careful. And this is an example here of an author who was not very careful. You see the first sentence of the introduction was, certainly, here is a possible introduction for your paper. So not only they cheated by really copy and pasting output from ChatGPT, but they were so stupid to not delete that first sentence. And so this was then in the social media, maybe you saw it on Twitter or on LinkedIn, and this was then retracted in the end. But a little bit silly to do stuff like that. So again, why do you need to register a study to prevent harking? And in the past, this was a real problem. You see that study from 2008, where it appeared that about half of all the publications had at least one primary outcome changed, another one, a new one introduced, another one omitted, compared to the original protocol. And if you want a guideline for doing your clinical trial, this is your one-stop shop, and the Equator Network. Have a look at that website, and I will give you the slides. Well, I will send them to NADA, and NADA will then distribute them to all those who are interested. But here you have all the guidelines for randomized trials, for non-randomized trials, for surgical trials, for device-based trials, for animal studies, for diagnostic studies. It's all there, and you just have to look it up and follow the guidelines and state in your paper that you did follow the guidelines. So if you then want to do a clinical trial, what endpoint should I use? Well, the first and important point is that you should only have one primary endpoint, which should be the endpoint that is used to calculate the sample size. You can have co-primary endpoints or composite endpoints, but these are not so frequent. Usually it's one primary endpoint, for instance, overall survival, disease-free survival, complication rate, amputation rate, etc., etc. And so one primary endpoint, and then you can have secondary endpoints as much as you want, but these are so-called hypothesis generating, because you have in the frequentist framework of statistics, you have this so-called multiplicity issue, which means that your risk of making a false conclusion of efficacy is inflated. So the so-called alpha value is inflated, and the more comparisons you do, the higher the risk that at least one of your comparisons will turn up with a p-value less than 5%, purely due to random error and not due to a real effect that is present in nature. And a good primary endpoint should be clinically relevant for the patient. And I have seen trials where they study a new way to treat a hernia, an inguinal hernia, and then the primary endpoint is the amount of fluid that is coming out of the drain. And sorry, but that's not a relevant endpoint. And why should patients bother if they have 20 ml of fluid coming out of the drain or 100 ml? They want to be cured from their hernia without long-term complications like chronic pain. And It should, of course, be measurable in all the patients with an accuracy that is acceptable, and it should be available in all the patients. And once you have defined the endpoint, it's time to calculate how many patients will I need. And this is not so simple. And remember that there are 4 things that you need in order to calculate the sample size for a clinical trial. And this is the example of a simple parallel groups randomized trial where you have a 1-to-1 ratio of randomization. And so the equal number of patients in the control arm versus the experimental arm, which is the most efficient design in terms of statistical efficiency. And so first of all, again, you need to have a hypothesis. For instance, my hypothesis is with a novel treatment, I will have a 30% less risk of recurrence, or I will have a hazard ratio of 0.7 compared to the control treatment. That's the hypothesis. If you don't have a hypothesis, you cannot calculate the sample size because it is in the formula to calculate the sample size. Next to that, you also need the precision with which you can estimate the variance, the statistical variance. This needs to be in the formula as well. Because the higher the variance and the larger the uncertainty with which you can measure the endpoint, the more patients you will need. If you have a very accurate measurement with a very low variance, then you will need less patients. And then you need the type 1 error rate and the so-called alpha value, which is nearly always fixed at 5%, which is not based on some higher statistical theory or mathematical theory. It's just convenience. And so the fact that the p-value is 5% as a definition of statistical significance is just arbitrary. It's not based on some underlying theory. It could have been 1%. It's just because Mr. Fisher wrote in his book, Statistical Methods for Research Workers in the 1930s, we should choose 5%, and that is convenient, and this has then been used ever since. And then the power that you need, the power is usually fixed at 80%, and so the power is by definition 1 minus the type 2 error rate. How do you do that? Well, you can do it by hand, of course, by using the formulas. And the formulas are not that complex. You need these 4 elements that I've just shown. You put them in the formula and you get a number per treatment arm. But nowadays, of course, you have software to do that. There are 2 nice online, freely available online tools. You can see them there. Look it up. And you can use R, since you are all going to learn to work with R. There are very nice R packages. It's 2 lines of code, and you have a nice sample size calculation, including a plot where the sample size is being varied, and you can see what happens to your power and to the effect that you can measure, etc., etc. And then you have commercial software like GPower, nQuery, etc., etc. But that's more for sophisticated designs like group sequential trials, crossover trials, factorial designs, etc. So this effect size that I want to choose is really, really important. Because if your sample size is too small, your study will be underpowered. And that's really very, very frequent. Specifically in surgery, I would say that about 70 to 80% of all clinical studies that are published are underpowered. And this has a consequence. First of all, it risks that the authors make a false conclusion, that they state that an effect is not significant, whereas if you look at their confidence interval around their estimate of survival, for instance, there is a potentially clinically important benefit that is being discarded. On the other hand, if a study is underpowered, the chance is very high that the effect that you will find is really an overestimation, the so-called inflation of the effect size. So remember, an underpowered study, if it has a lower probability to find an effect, but if it finds an effect, then nearly always this effect will be inflated, will be overestimated, a huge overestimation usually. That's the more common scenario. On the other hand, a sample size can be too large. You can have a study that is too big. And what's the issue there? The issue there is that if you have a very large sample size, and if you look at the formulas, then you will see it immediately, then a very small effect will become statistically significant. There's no doubt that if you design a study with a new antihypertensive drug and you have twice 10,000 patients, then a difference in mean blood pressure between both groups of 0.01 millimeters of mercury will certainly be statistically significant, but it's clinically meaningless. And so that's why a sample size can be too large as well. But that's, of course, less common. Usually they are too small and they are underpowered. So how do I then choose this effect size? Well, there are different methods that are being used. You can base it on a literature review. And typically in pharma research, they use the results from earlier phase 2 trials to decide on the desired effect size in a phase 3 trial. You can do a pilot study. That's often done. You do a pilot study just to have an estimation of the effect size that we will find with the new therapy and the accuracy with which we can estimate it. And so this variance, which also needs to be in the formula. And more, you do this in consultation with stakeholders, funders, charities, the EMA in Europe, European Medicines Agency, or the FDA, the Food and Drug Administration in the US. But the most important stakeholders are the patients, and that's why now we have a thing called a minimal clinically important difference. And so this is by definition the minimal difference that is important to patients. And how do we know that? We know that by involving patients in the design of the study. And this is now more and more the rule, that whenever you design a study, you involve patients. And usually it's via patient organizations, like in breast cancer, Europa Donna, etc., etc. And more and more these patients are organized on a European level. So it's easy to get in contact with them and to have them surveyed, to ask them, what is important for you? Is a 5% lowering, is that important for you? Should it be 10%, 20, 30, etc.? And there is some guidance that can help you. For instance, the Delta 2 guidance, you can look it up if you're interested. And then to finish, a few slides on how to study devices and surgical procedures. It's completely different from pharmaceutical research. And in Europe, you have to know, at least the European Union, that there is a new medical device regulation which is now in place. And the major difference with the existing framework and before this came into effect is that now for the so-called high-risk devices and implants, you need a clinical study. The industry needs to come up with proof in a clinical study that the device is safe and effective. In the past, this was not the case. If I wanted to take a piece of textile, put it in a patient as a new mesh for hernia, no clinical studies needed in the past. But now you do need a clinical study for high-risk devices and implants. For instance, a hip prosthesis is considered now a high-risk implant. Breast prosthesis, everything that uses electrical currents, pacemakers, defibrillators, etc., etc. So the industry now needs to do clinical studies for devices. And so the framework that we now tend to use is not the phase 1, phase 2, phase 3 trials like they do it in pharma, but the IDEAL framework. It's an acronym. It stands for idea, development, evaluation, long-term effects, etc., etc. And the IDEAL collaboration, did you hear of it? Not yet. It's specifically focused on surgical research, on the study of procedures and of devices. And it has been published in The Lancet. I didn't put a reference there, but you can look it up. It's easy to find. So it's a stepwise, systematic, stepwise exploration of a new device or of a new procedure, where you start with the idea, then you develop it, then you explore the effects in a larger population, and then you do the long-term assessments. And here you can see in this table that according to each stage, there is a difference in whether or not you need ethical approval and informed consent in the methods that you should use, prospective studies or RCTs, etc., etc. And so the IDEAL framework is now the way to go to study devices and or surgical procedures. And why has this been developed? Well, because there are specific obstacles with doing RCTs in these circumstances, and there's a lack of standardization, and you know that. And if you do a gastrectomy, I will do it differently than John will do it, and Dara will do it, although you don't do gastrectomies, I think. So there is a difference in how people do things, whereas in pharma research, if you give patients an experimental drug, you will know for sure that every patient gets the same molecule at the same dose and at the same concentration. And there are the learning curve effects, there is Buxton's law, there is the impossibility to blind patients. If you compare a surgical intervention versus a medical intervention, of course it's impossible to mask patients. That's obvious, and that's why I will not go into details. I will just show you that there are a number of alternative prospective designs and clinical trial designs that you can use in surgical trials, and pragmatic trials, registry-based trials, trials within cohorts, expertise-based trials, etc., etc. This is upcoming, so-called pragmatic trials, which have a higher external validity, because that's a traditional criticism on randomized controlled trials, that they have a very high internal validity. So the methodology of the randomized trial is the best guarantee that you will demonstrate a causal effect, that you will demonstrate causality. But their external validity is often limited. Why? Because the patients that you treat in a randomized trial, although it's called a randomized trial, this is not a random sample of the population. Not at all, not at all. It's highly selected. It's patients who comply with very strict inclusion-exclusion criteria. It's patients who are selected based on the fact that they have the education and the socioeconomic status that allows them to visit university hospitals where these trials are being done, etc. So that results in the fact that the trial population is often very, very different from the average patient that you will treat afterwards. And this has been demonstrated many times in studies, that the results that you find in randomized trials can never be replicated in the real world, in the average patient. And this is the so-called external validity, and pragmatic trials are a way to tackle that, to increase the external validity of trials. And so, for your interest again, you can look it up if you're interested, and there is this so-called pragmatic continuum wheel, the PRESS is 2. It's a score which ranges from 9 to 45, so 9 points it's a real traditional randomized trial, and 45 points is a very pragmatic study. And so to finish, word on evidence synthesis, because that's also a form of research. It's evidence synthesis, typically the meta-analysis, but you can do a narrative review, you can do a scoping review. Systematic reviews also need to be registered before you start them. At the Prospero website, you see the link there. And a meta-analysis, the difference with a systematic review is the fact that you do a pooling of the individual studies based on a weighted average of the individual effects. And the weighting is based on the precision of the estimate in the individual studies. For instance, if you look at this hypothetical example here, study J was a larger study, and you see that because the surface area of this rectangle is higher than in study A, for instance, and also the associated confidence interval is a lot shorter. So this study had more patients, and you can see that there in the column at the left, 70 patients versus 20 patients. So the more patients you have, the more you are able to do an accurate measurement, the less wide your confidence interval will be, the larger the area of that rectangle will be, and the higher the weight that will be assigned to this study in the meta-analysis. And so what is generated is a so-called forest plot, and this forest plot then generates a so-called summary statistic. And you see the diamond-shaped symbol at the bottom there. This is the summary statistic. If it doesn't cross the line of 1, in this case it's a relative measure, it's the odds ratio, but it could be the relative risk or the hazard ratio or any relative measure of effect. If it doesn't cross 1, like in this case, by definition, it's statistically significant at the 5% level. So this is all generated automatically by software, so no need for formulas or mathematics. You can do that yourself. How do you do that? Well, first step, develop a search strategy. Take care of that. That is important. You can use Boolean operators, or, and, not, etc. And you can use open source repositories, such as PubMed or Google Scholar. Those are already very, very nice if you combine both. And if you have access to commercial databases like Web of Science, it's even better, but in fact with PubMed and Google Scholar, that should be enough. Then you should select all the papers based on your inclusion and exclusion criteria. You extract the data and put it in some kind of database, and ideally that should be done by more than one person. And then you use free software for the actual meta-analysis. And what you can use is either RevMan, which is published by the Cochrane collaboration, and you can download it for free, very easy to use. Or you can use an R package, which is the preferred way. And since you will all learn R and RStudio, for instance, this package, it's called Meta, appropriately named, let's say. And it's just 2 lines of code, and it generates these forest plots. It does the analysis of the heterogeneity. You can generate funnel plots to look at publication bias, etc., etc. So very easy to do yourself, and I would advise you to do it. Meta-analyses, in fact, if you pick a topic, the right topic, are very easy to publish and to get published, because editors like that, because their likelihood of being cited is quite high. People often cite meta-analysis. If you choose a topic where there have been no decent meta-analysis over the past years, let's say, because often you see meta-analysis, typical example in colon cancer, complete mesocolic excision. Every month there is a new meta-analysis until you get really bored with these topics. And so go to the Cochrane collaboration. There is a link there where you can download the software called RevMan. It works on Windows and Apple, but R is even better, I would say. So, yeah, it's true. You found out. So to conclude, if you want to do research in a surgical setting, you need skills, and that's obvious. But you can learn these skills freely, and the learning curve is really not long. You don't need any mathematical or difficult knowledge or whatever, and all of this is easy to learn. I've shown you this website, but you can look at these MOOCs, like Coursera. Harvard has free courses. All the major US universities have free online courses. If you want a certificate, you have to pay, but to follow the course, it's free. There's a lot of videos, etc., etc. But again, collaboration and networking is really the key. If you are stuck on your own, on your small little office, isolated from the outside world, then you will get nowhere. And so collaborate and form a network. So on that note, I'll finish, and I will be happy to take any questions.
So thank you so much, Vin, for this really nice overview about the translational and clinical research. Are there any questions? We have, let's do that actually a little bit more interactive maybe. Your young surgeons, residents, right? Of surgery. Okay, so let's, yeah, he's actually the senior here, okay. Let's pretend that I am actually a young resident here, a Serbian one. I'm a Greek, but it's okay. There's not much difference, right? So, I'm working actually in a state hospital. It's not a university hospital. I do like research. Or I suppose that I do like research. I'm not sure about it. I want to start with, but I don't know how. Of course, we have talked about the skills. Okay, I have the passion. I do know a lot of statistics, maybe. Okay, my favorite topic is yours. Yeah. Breast reconstruction, right? But I do work actually in a isolated, I don't know, tell me one place in Serbia that is not actually so, anyway, wherever.
Many places are not so.
Okay, and I do want to start with, but I don't have anybody that I can talk to. I don't have actually any mentor. So which actually, what would you do? Would you advise me in this case?
I would advise to look for a mentor, and if you can't find anyone in your own hospital or in your own environment, be part of ASEC and of ESSO. There is a mentorship program, and we can assign you a mentor. Yeah. But of course, this is not the ideal scenario if you are really the only one, and then you have maybe a boss who is not really happy with the fact that you spend time not treating patients and generating income for the hospital. So it will not be that easy. But if you really want help and advice in really getting started and writing your first abstract or whatever, I think the ASEC and the ESSO is a really good forum for help and finding a mentor. Yeah.
Problem in Serbia is the one that we don't have actually designed time for research for any kind of this activity. So it's clinical work, and if you have time after clinical work, after working hours, you can stick around in the hospital, and it's a complete disorganization regarding initiation of any research and any study, any paper you want to publish. So I think that there are many structural and organizational problems in Serbia in terms of that.
But that's not unique to Serbia. I mean, in Belgium we have exactly the same,
Yes.
the same environment where the focus is on, indeed, on clinical treatments, and that has to do with the fact that everywhere in the world there is a huge burden now on healthcare systems. And there is a workforce crisis, and there's a shortage of doctors, of nursing personnel, etc., etc. There is a financial burden with the inflation and salaries that went up. So the times are difficult to get your boss to allow you to take 1 day per week off. But often it's allowed. And for instance, in the Netherlands, they are able to come up with really very high-level collaborative trials. And they get in the New England of Medicine, they get in the Lancet. And how they do it is, well, there are two things. The first explanation is the fact that if in the Netherlands you want to go into training and surgical training, you have to have a PhD. If you don't have a PhD, don't bother. You will never be accepted as a resident in surgery or any specialty. So that means these people already have the skills. And second, specifically in the university hospitals, but also in the private hospitals, they have protected research time, at least 1 day per week in the Netherlands. So that makes it easier to collaborate and to get results. And so that's maybe something that should be imposed from a higher level, from a political level, to make sure, because research it can be beneficial for hospitals. It attracts patients. If you come up with a nice study and the results come in the press, look what they found, like in Heidelberg, a novel method, a novel study, and patients pick it up. Patients read websites and social media, and so it can be a win-win for the hospital and for the administrators as well.
Dara?
I just want to, I suppose, as much a comment and then maybe a bit of a question. Certainly, a fantastic, not just a talk or a workshop, but an actual set of guidelines themselves on how to become a surgeon, scientist, or a medical academic. But just what you were talking about is I suppose maybe get your opinion on, I suppose, infrastructure. And so, I come from Ireland. And again, very similar to Serbia, very similar to Belgium, no protected time. And it's about, you make time for these things. But I suppose one of the hardest parts is, as you described in your talk, that very often you're going back through charts and you're going through old data, and it's retrospective work. And I suppose just the importance of, if someone has to start, someone has to create it. But I suppose the value of having, databases prospectively put in place and future-proofing them.
Yeah, absolutely. Yeah,
Yes.
I think that's the way to start, by prospectively collecting clinical data and samples. You only need a fridge, in fact. Well, it's a -80, so it's a complicated fridge, a very cold fridge, but that's the only thing you need, in fact. Yeah.
That's a good point, Dara.
To continue the question of Dara, I'm still actually in my second or third year of my residency, for example, right? And my question is, So I don't work actually now in a state hospital. I do work actually in a big university hospital where everybody actually, like I do work in Heidelberg or in Belgrade, in the University of Belgrade or wherever. And everybody actually is dealing with research, and I do want to do something, but I don't find any space for me in this environment. Which would be actually the best way to start with diplomatically, from the diplomatic point of view, and which would be actually the best way to start research generally? Because Dara just told that maybe, you did agree that maybe the best way is actually to start actually a prospective, with a prospective database. But my question from my side, maybe it would be easier just to write just a case report as first attempt, or a retrospective study, or maybe a meta-analysis or a systematic review. Which would be actually your proposals to start with? Which would be actually, should be the first attempt of a young resident?
Send posters to ESO.
Well, a case report, yeah, why not? But as you know...
I know it doesn't bring anything, but I mean, somehow somebody has to start with.
Indeed, indeed. But the thing with case reports is that most journals don't accept case reports any longer because they don't get cited, and so the editors don't like it. But like doing a review paper or a meta-analysis, my PhD students are always asked, if they start their project, do a systematic review or a meta-analysis, because it allows them to get very familiar with the topic of their PhD, and it's easy to get published, and they can just recycle it for the introduction of their thesis. So a review or a meta-analysis, I think, is the ideal way to start. And if you are lucky enough to be in an environment where there is a culture of research, then there's no doubt that they will ask you, please participate in this study, participate in that study, and then you will be assigned a task, and then you will have the opportunity to be co-author on an abstract or to present something at the ESO Congress or whatever, and then the ball gets rolling.
In Serbia, for example, we are discouraged to do meta-analysis and systematic reviews, and pushed to at least do case reports, like start something, try with something. Completely opposite philosophy, yeah. Which now I realize is wrong, obviously, but at least this gives people some way to explore the literature on some topic, to try to practice the skill of writing.
I understand the point, and of course, you know that there's now an inflation of these so-called predatory journals. I get spammed like 100 times per day with new journals. It's then the Journal of Surgery and Case Reports. The next day it's Journal of Surgical Oncology, Case Reports and Clinical Medicine. The next day so we have this inflation of rogue journals, of predatory journals that don't care about the content. They just take your paper if you pay. You pay $2,000, you get published, and that's it. So I think this is really a very sad development for the quality of science in general. The same with publishers like MDPI and similar ones, Frontiers. So I think even if it can look like a quick win, I would really discourage to try to write case reports instead of systematic reviews and meta-analysis. That seems like bad advice to me, honestly.
Okay, are there any other questions? Now, there should be some questions maybe from your side, guys.
I wanted to ask the same question as you, Nikos. So, how to start from the bottom? But you were saying about the fabricating the results. How do you deal with the fabricating results as an editor? Like, how often is that? Because in the past, I've seen a lot of papers that are published in really, really nice journals and with fabricated results.
Yeah.
How do you deal with the thing?
Well, if you, of course, catch them red-handed, then of course you just reject the paper and that's it. I will not take the step of informing their academic authorities, etc., etc. But usually you will not notice it. If it's well done, if the invention of patients is well done, then there's no way to find it out. But there are some methods that you can use. For instance, based on the means and the standard deviations that they report. And there are tools to find out that this is impossible, and that you cannot have that mean and that standard deviation, etc. And also, if the data look too good to be true, then usually they are just not true. And so there are some red flags. And also, it's of course a pity that I have to say that, but we know that in some regions of the world, the risk is higher that what is being submitted is maybe not completely transparent and completely true, let's say. But yeah, it's a huge problem. And it's estimated that like 30% of all scientific output in medicine, in biomedicine, is fabricated or false.
Yeah, a lot of young people are under pressure to publish some papers, so they just do it in the rush and they fabricate the results, and actually after that they get cited.
Yeah. Sometimes people are tempted to do that, or they are pushed to do it by their superiors. But remember that if you get caught, your reputation, your scientific reputation is gone forever. And you saw this retraction. This retraction will be online until the end of the world. So be very, very careful, I would say, and stick to really integrity. I think integrity is a base value in science, and stick to the truth. But it's difficult. It's getting more and more difficult, and we now have truths and alternative truths. And so we're surrounded by lies and falsehoods, and people just don't care anymore. Like in the US, people don't care if a president is honest or has any decency or integrity. Those values are disappearing, it seems. So the same. So let's keep science a beacon of integrity. Let's do that.
That's a good note.
Yeah.
Good message.
Great.
Did you finish your residency, Nikos?
I did finish my residency actually now, but exactly
what about the third year?
I finished that. I just actually wanted from Wien just a comment, because now we are discussing actually about research. How would you comment actually the phenomenon of the last years, especially after COVID era, that of this the phenomenon of these large collaborative papers where everybody, like thousands of authors and hundreds of hospitals, do provide their data, and these authors or these hospitals pretend to be like the biggest researchers of the world, just with a huge database, which actually is getting used actually by some people only.
It's a quick win, of course, if you participate like in COVID Search or in Global Search. But yeah, what you're saying is true. You should be modest, I think, in your contribution, and not. But that's more a matter of, how would I put it, of being modest and not trying to, inflate your contribution to that type of science. But apart from that, I think this evolution towards networking and collaborative efforts, I think that's really the way to go. Yeah.
For example, in my country, our medical school, university, they don't appreciate much participation in these projects, as you said, during COVID. Those publications are not valued if you want to move further in your career, academic career, like from clinic assistant professor to. So they just give you some points, like, of course, it can't be erased, but it's not valued much. These group collaborations that are made like this during COVID, like with small participation, 1 or 2 patients from your center.
Yeah, but I can understand, of course, that for the purpose of promotion and academic ranks and points, etc., that this is assigned a lower value compared to a first author paper where you did all the work and did the clinical trial and designed the clinical trial. That makes sense, I think, that it's assigned a lower value. Yeah.
Great.
We're on the same page.
Yeah, we're on the same page. We finished actually with the first part. I think that we can continue because we're out of time. Thanks, Vin, for this amazing overview. So in terms of this collaboration
platform, you know, we have to continue now with the next moderators, Wim and Milan. Yeah.
Yeah, I didn't realize that I had to stay.
Yeah, I wanted to mix us a bit so that we're not the same people sitting on the stage. Don't worry. We have this. If you need break, we can make one.
For data acquisition and analysis.
Yeah, thank you very much. Just before we get started, I was hoping you'd all just fill in this form, and then there'll come a point in the talk where this will be fully a workshop, and where we work through things together, and you can use your phone. If you have a laptop, you can use that, or even just your cell phone will be fine. So if you've completed it already, that's perfect. I have you already. I have you. You're perfect. Yeah. Just everyone.
What do you have to do now?
Nothing. Just sit still. You'll get an email in a few minutes.
Ajde.
Okay, I might use this for the slides. I might use this for the slides. Is that all right? Yeah, yeah. Thank you. Thanks.
Ogian is there. He managed.
Perfect.
Do you have us?
That's perfect. I have people here. This one is it? Or this one? Okay. Oh, perfect. Okay. Oh, Milan, all right, sorry, all right, okay, go for it.
Dara, have you found Alexandra?
No, please wait.
Yeah.
Or help me.
Okay, then.
It's like my phone is not recognizing.
Make a selfie, maybe it works.
You can type in the link. You can type in the link if you want. It's just redcap.link / oncology conquerors. Yeah. And I'll hang on until we get you registered.
Let's play some music. Let's play some music.
Any look?
I samo uđi na oncology congress. Si uspela? Ambiental music is by Nikos.
All right, thank you. We might get started, and I can make you an account when the time comes, and we can talk through it. So thank you. So thank you, everyone. Thanks for being here. Thank you, chairs. Thank you, the organising committee. Thank you, Nada, for the invitation to be here. And it's fantastic. It's my first time in Serbia, first time in Belgrade. This evening, I'm going to talk with you about REDCap, which was wonderfully introduced by Wim, and I think it is genuinely and sincerely a wonderful tool and phenomenal tool for research. Briefly, REDCap stands for Research Electronic Data Capture. So it's an EDC, Electronic Data Capture Device. And yes, they really do use a red cap as part of their logo. That wasn't me trying to be cute. But briefly, just to clarify, and this may disappoint some of you that are fascinated by mythological creatures, as this talk has nothing to do with the malevolent, murderous goblin from Irish and Scottish mythology, the Red Cap, nor has it anything to do with the Red Hat software, which some of you may know as a subsidiary of IBM, and who make a lot of enterprise software. But here's hoping that this workshop will be just as mythical and legendary as these creatures. So just briefly, just a quick outline of what it is we're going to talk about. I just want to tell you a little bit what REDCap is, some of the things which Wim introduced, which is like database versus spreadsheet. There's other alternative electronic data capture software tools available, and I suppose there's benefits to each. Some of the types of data that you can acquire, and just a little bit on data analysis. So just as promised, so REDCap is a secure web-based platform for collecting, storing, and managing data. It was developed by Vanderbilt University in Tennessee in the US back in 2004, and it's used around the world. Many of you, I'm sure you've heard of it or used it already. It's used by universities, used by hospitals, research organizations, and industry. REDCap includes many helpful features, giving access to existing surveys, data collection tools from across the research community, data summaries, and you can use clear visualizations of project progress. So it can be used as much for project management as it can be as a database tool or running a clinical trial. It has the ability, I suppose one of the key features of it is the ability to share data access with approved team members, and we'll talk about it a little bit more as we go through this, and in fact we'll demonstrate it in real time, that you can manage access on a per person basis. So if you have a statistician, they just really need to, they don't need to see personal information, they just need to see perhaps some basic demographic information to allow randomization. If you have research data analysts or medical students who are perhaps retrospectively entering data, they don't need to see any of the randomization information. And say, for instance, if it's a drug trial, if there's an intervention, you might have a pharmacist. They don't need to see any other information except for, is this person randomized to group drug A, drug B, drug C, or whatever. It's particularly helpful, and I suppose ESAC and ESO are testament to this, it's particularly helpful for survey research and conducting and collecting field data, as participants can follow unique links if they want, so you can even attach it to their very specific patient record. So for an individual person, you can enter research data on them prospectively, and then if there's, say for instance, patient-reported outcomes, you can link that to their record, and they directly enter it to their own record for you. It's also possible to automate emails or even text messages with these individual specific links from within REDCap to respond to these surveys. So again, if I wanted to, as I said, send a survey to a patient for their patient-reported outcome, they can get that via text or via email. I suppose I'm going to continue to insist that REDCap is user-friendly, and we're going to really put that to the test a little bit later when we all start either from zero or from having used it before, as to just how user-friendly it is. But again, it's another great tool for, I suppose, centralized data management. I've kind of touched on it already, but you can create, and we'll talk a little bit more about the terminology within REDCap, but you can create instruments and surveys online. These can be delivered across different operating systems. So it doesn't matter that we're using a cell phone here. If it's Android, if it's Apple, if it's iOS, if it's an iPad, if it's an Android tablet, if it's Windows, Mac, Linux, whatever, it doesn't matter. So it's the same across all platforms and all across the world. It allows real-time data access. And so again, super useful in whether it's emergency situations and collecting information, or things which happen 2 weeks or 2 months later. It's super efficient in terms of data collection, and you can really customize down to a very, very granular level the amount and type of data that you collect. You can introduce, I suppose, complex logic into your question format. So simple things are, what are you having for dinner? I'm having, the beef, I'm having the fish, or other. And then if you click other, there's perhaps a free text box, and you go, I'm having the vegetarian, the vegan, whatever, the gluten-free option. And there's much more complex logic than that. You can even randomize patients and stratify them, and stratify their randomization. You can even do multiple randomizations within the same trial from within REDCap if you wish. As I mentioned already, you can finally administer control and access rights to various instruments and tools within it. So perhaps, say for instance, some of this group, if we're part of a trial, have the rights to view data but not to edit it. Others would have the rights to enter data, and others would have the right to not to see certain parts of it whatsoever. So perhaps the example of the pharmacist versus the data analyst, or the person entering the data versus perhaps the principal investigator of the trial. I suppose another super important part of REDCap, and an amazing feature of it, is that it is compliant with, I suppose, major guidelines in terms of data privacy and data protection. So whether that's HIPAA in North America, which a lot of people are familiar with all over the world, to GDPR in Europe, and even national guidelines. Because the essence of it is that certainly personal identifiable information and personally identifiable data needs to be handled with certain respect and certain caution. And that is entirely possible from within REDCap. So you simply mark a field as identifiable information, and the system then will automatically de-identify data for you if you needed to share it again in the future. So accidental data loss is not an issue. And it became a huge issue in the US, I know, a number of years ago. A very large health system in New York, Northwell Health. It's the largest healthcare system in the entire state of New York. But they lost access to all federal funding for research, because somebody had a laptop, they left it in their car, and they had a ton of identifiable patient information on it. And so with that data breach, they now were in violation of that law and lost access to multiple millions of dollars in research funding for 5 years. So it has huge implications for institutions. And a lot of these things, I suppose, as individuals, might just say, individual researchers within each institution might not, be necessarily aware of the implications of these data breaches, but just that it is, I suppose, super important at an institutional level, but then also at a very individual and personal level. If that was your parents' identifiable information that was disclosed and is now available, not just the status of their disease, but that is something that we should all be very respectful of and very cognizant of. You can also, I suppose, a very important part of REDCap is data hygiene, keeping data clean, and data validation. So it's the example I've given here is of across different countries, people have different conventions for how it is that they enter digits. So say, for instance, if I said to you, type in, somebody's hemoglobin, and the example I gave here is it was 10.3. Some people use, instead of a full stop or a period sign, they will use a comma. Some people, and sometimes we're human, we make mistakes. So we have a keystroke error, so we either don't put in that point whatsoever, or we put it in the wrong place. And so you end up with very, very different values. And if this is in a data set, you end up you can really confuse and really change the pattern of your data for something very, very simple. But REDCap allows you to apply data validation measures and control exactly what it is entered into that field, and issue warnings if, say, for instance, it's outside of a range, or if it's not in the correct format. Like, say, for instance, if they use the comma instead of the full stop, that you can, that they get a warning to correct it before it's entered into the database. And the same for dates. I think a lot, I suppose North Americans use a lot, they use the format of month, day, year. And I suppose most other countries in the world use day, month, year, or otherwise. And you can standardize that so it gets stored exactly how you want to use it. And that's particularly useful because when you come to the stage, as mentioned earlier, when it comes to data analysis, a lot of the time if you create, say, for instance, code to analyze your data in R or other software packages, it's very dependent on the formatting of that data. So you can have it pre-formatted so that when it gets there, it's clean. You don't have to spend a lot of time going line by line, fixing, correcting, amending. And so I suppose that's kind of the main points just with regards to data hygiene. So I suppose there's a temptation to ask, why wouldn't you just use Google Forms or SurveyMonkey to do this survey or to collect this data? And I suppose that's a very fair question, but really this slide isn't so much why not use Google Forms, but it's as much why you should use REDCap so much. Google Forms and SurveyMonkey, very popular tools, but we've addressed many of the reasons why you shouldn't use them already, not just data validation, not just security, which is a really key feature, and scalability. But for me, the main reason we should use REDCap versus these are for managing the complexity of data, and especially in clinical trials and advanced access controls. So again, we mentioned that already, ensuring secure data sharing and safeguarding patients' information. As Wim mentioned, I know I love Excel, and we'll use a little bit of Excel later on, and everybody uses spreadsheets, but do not use spreadsheets for complex clinical research projects. They might seem like a simple solution for data collection, but you'll end up making a very complex problem for yourself when it comes to analyzing that data. We've already addressed much of this already, so I think some of the most interesting things for me, I think we're all used to this next image of, where you might have a version control. So this was the main issue is you've gotten an email and it was version 1. Then it was version 1.1. Then it was version 1.1 final. Version 1.1 final edits. Version 1.1 final edits final. And it just goes on and out of control. And then you might say, oh, I'll fix this later. But you don't have to fix it later. We don't have to make these problems for ourselves. We could just fix it now, and we could just use REDCap and not have these issues. So another example is something which I see an awful lot is another reason why not to use spreadsheets is sometimes we're all very confident, just like, yes, I want to sort and filter the data. I'm just having a quick look. And you end up selecting all the data, and then you sort and filter. And what you actually end up doing is shuffling the data because you made a simple mistake of you thought you selected all the data, but you didn't select all the data. And then you end up filtering the data or sorting it, and then all of the columns to the right don't change, and everything to the left does. And so you've now done this wonderful shuffling of your data, and you don't become aware of this until maybe a month later when you start to analyze, and things just don't really make sense anymore. So don't use spreadsheets. But you might ask, what can I use REDCap for? So I think you kind of have a pretty good idea already. I suppose you can use it for whether it's surveys, patient-reported outcomes, creating a prospective database or even a retrospective one, for clinical trials, project management, even collecting e-consent, which I kind of touched on a little bit earlier on, and things like longitudinal studies, so things over time. We'll have a look at, I'll give you access to all of these things in a short little bit of time, I promise, we're almost there. So it can also accommodate a wide type of data types. So not just demographic data, clinical data, surveys, environmental things, massive genetic and genomic data sets when you start getting towards large data sets and genomics or omics, and lots of behavioral data. Even within these, it can be lab values, it can be vital signs, medications, diagnoses, drug doses, anything. And not to labor the point too much, but if you can count it, you can measure it, you can classify it, name it, describe it, draw it, photograph it, record it, whether it's a file, a photograph, a signature, an audio file, you can collect it and securely store it on REDCap. This slide is just a quick summary of the types of responses we can use in REDCap, more for reference, and we'll come to that a lot more shortly. REDCap helps prepare and export data for analysis. Just to be clear, REDCap is not an analysis tool. It really is about data collection. The analysis occurs in statistical programs, whether that's OR, whether it's SPSS, SAS, or Strata, or otherwise. But REDCap does have dashboards which are very useful, and basic data analysis is possible within the platform. There are many EDC options, so electronic data capture. So I've mentioned already using REDCap. I suppose one of the most famous ones, I think, is Medidata. Incidentally, Medidata was invented in the institution I work at in Mount Sinai, and actually by 2 urologists and their medical, or the student who wanted to study medicine, who then never studied medicine. They invented Medidata, and he was one of the medical student who never studied medicine, was one of the people on Jeff Bezos' Blue Origin space shuttle on the first flight. So they made a lot of money with an EDC. But wonderfully, REDCap is open source, and if you know somebody in ESSO, and you all do, you can access it for free, and you can use it for free. So you don't have to pay Blue Origin money to use an EDC. I suppose this slide is not a political statement, and right before we get to the hands-on portion, this is as much to stress the point that we should choose the right tool for the right task. I remember a mentor of mine telling to me years ago when I was early in my training that the problem is not figuring out how to kill cancer cells. We know how to kill cancer cells. The problem is we have to solve killing cancer cells and not harming the patient. Which of course reminded me of, I suppose, a famous press conference during COVID-19 when bleach was mentioned. So people shouldn't drink bleach, but it is very useful for other things. And this is, I suppose, again, reminds us that medicines can be misused. Much like bleach, medicines can also be misused and abused, and so can other tools and technologies. So particularly when we come to data, using the right tool stops the abuse and misuse of that data and disclosure of people's personal information. So some things might be convenient to use right now, and it's important for us to be responsible in our uses of all sorts of technologies, just like it's important that some medicines are regulated and controlled. As doctors, we're privileged in that we not only get to prescribe these medicines, and we not only get to cut people and not go to jail for cutting people, but people share with us very personal information and very private information, and we should be responsible and ethical in all aspects of our work, not just in our prescribing or our operating. And in a similar way, I think about ways to make my life easier a lot. We live at a time with greater automation. We've heard a little bit about the use of AI tools, whether it's ChatGPT, and they can make our lives easier and more convenient. Unfortunately, though, I think sometimes we make our own lives more complicated. I sometimes wonder if it's impatience or eagerness just to get things completed and done that we'd rather have this now rather than slow down and just think about it and do it properly. But I think much like a surgical margin, it's important. We should take our time with some steps and be careful. And so much like using tools like this or any technology, be careful not to trade, in this instance, other people's personal and private information for our convenience right now. So I'm just going to literally write, as we all sit here together, we're going to grant all of you access to REDCap, and it'll just take a minute or two, so I'll just be a little bit silent and you can see it happen here for a second. And then you should get an email. So I'll tell you when you get the email, so just give me about a few minutes. So you should have all just gotten an email around the last minute or so, and you can just maybe log in and set your password, and then there's just some rules for setting your password, so at least 9 characters in length. And yeah. No, this is a new account.
Would you use this account actually in the future too?
I wouldn't. This is going to get deleted in a couple of weeks' time.
In a few minutes.